Morning, everyone. Kindly take your seats. We can start with the first session of day 2. So, first of all, I must thank everyone for joining yesterday for these sessions, and I'm sure you enjoyed a lot of good presentations from so many people who have come from ESD as well as from India. Yesterday we discussed quite a few important topics. Right from the word go, we had a wonderful presentation from Professor Andrea speaking on when and how the CVD starts in diabetes, and that was phenomenal presentation. And then we have discussions on incretin pathways, the impact of new drugs on management strategies, and focus on diabetes remission also. There was a fantastic debate. Unfortunately, I don't have the picture that Katrina had put in the slides, but I'm going to show you during the day. That was a fantastic picture she created during the debate, and David has not joined. I think he is still feeling hurt. He will join late. So we had a beautiful debate yesterday between David and Katrina. We had a session on type 1 diabetes, AID, insulin delivery, CGMs, lot of discussion of CGM matrix, and also a session on SOUL and STEP studies. We also had interesting discussion on when and why to use SGLT2, should we be combining with the GLP-1s, what are the challenges. Katrina had a session on sarcopenic obesity, and also we had session on what are the challenges with GLP-1 therapies, how should we take up the nutritional priorities in these people. This session is going to be today. Actually, Shagun did a session on CGM metrics yesterday. Today we are moving into a different direction. We are going to have discussion on SGLT2, sarcopenic obesity, nutritional priorities and GLP-1, monogenic diabetes. Professor Mohan is already there. We are going to have some wonderful data coming from him. And then we have, interesting sessions on combination therapies. Where do we position DPP-4 inhibitors, which have been integral part of therapy for us, and then looking into the future of management of diabetes as well as obesity, followed by some of the very recent trials like Believe, Achieve, Redefine, Stride, Meritide towards the end of the day. So I'm sure you are going to have very interesting discussions. At the same time, this year we have some, free papers. So we had 24 free papers, and you have the 5 best selected for the oral presentation starting right now in the co-meeting 1, which is the workshop hall, co-meeting room 2. We also have some interesting workshops lined up for the day, and one of the workshops, interesting workshops, we somehow came on the idea is looking away from science for doctors. We were approached by some of the real estate, agencies, and they wanted not only real estate, they wanted us to have a session on how to manage and create wealth for doctors. So some of the people may be interested because we are very poor with the financial management. So there is an interesting workshop at 10:30 on that note also. And then we have workshop on blood glucose monitoring as a surrogate for CGM, which is again very interesting, topic. In country like India, we don't have the availability and accessibility to CGM for most of the people. And can we use a simple blood glucose meter to convert the readings to CGM, and will they be as good or close to as good that what we are going to see with the CGM? Then we have, workshops. There is a symposium by Novo at 12:30. We have workshops on technologies, how to use them in clinics. We have an interesting session on erectile dysfunction by Mithun Bhartiya. He is already there. And we have a very important workshop on diabetes foot. So that's what we are going to see through the day. So on that note, I will just repeat some of the important housing, announcements. One, we are going to keep the sessions on time. Please make sure that you are, for all the chairpersons, make sure you are starting the sessions on time and finishing on time. And we have then discussion time allocated, followed by a quiz which is being run by Bharat. He is doing very well with the quiz which goes after each session, and there is a quiz winner prize for every quiz, every session quiz. We also have an app which you can download from the back of your badge. On the back of your badge, there are 2 QR codes. You can download the program as well as the conference app, and you can do a lot of things in conference app itself. And lunch will be served at 1:15 downstairs, and we will be finishing at 4:30 today. So that's the sum up of yesterday's program and today's program. I will end it here and invite Dr. Kirti to start with the first session. Thank you.
So thank you, sir, and welcome everyone to day 2. May I request Dr. Girish Khurana, Dr. Mudit Sabarwal, and Dr. Jimit on the stage to chair the session. So over to you, chairpersons.
Good morning, everyone. So to start with today's session, I would like to invite Professor Andre Accd to deliver his talk on when and why we should use SGLT2 inhibitor. Dr. Andre has been introduced yesterday, so there is no need to reintroduce again. So stage is yours, sir.
Hello, good morning, everybody. Happy you're here to hear something about the history, let's say, of SGLT2. As you read on the previous slide, I've been mentored by Ralph DeFronzo many years ago. And during those years, he was studying fluorescein, which is a sort of precursor of all the SGLT2 inhibitors. Fluorescein is a disaccharide, like sucrose, extracted from the bark of the apple tree, and is a potent inhibitor of both SGLT1 and SGLT2. Okay, both of them, not just SGLT2. And this means that all the glucose that is filtered either is usually reabsorbed with SGLT2 and the remaining by the SGLT1. And if you inhibit both of them, all the glucose is lost in the urines. Okay, so actually Ralph is a nephrologist, he's originally a nephrologist, so just measuring glucose concentration in the blood and in the urines with fluorescein, you can really measure very easily the glomerular filtration rate, because all glucose is lost in urine, so it's very easy to measure that. But still, Ralph had the idea that this was a good way to remove hyperglycemia, but to remove hyperglycemia a different way, not just pushing glucose in the liver or in the muscle or in the fat, just removing with the urine. So with that, you can remove hyperglycemia and actually understand the role of glucose toxicity in the pathogenesis of type 2 diabetes or diabetes in general. And this was my major studies in those years. I remember, 35 or 40 years ago. You know, this is the natural history of diabetes. You'll see hyperglycemia going on with history, postprandial fasting glucose, insulin resistance, we know it's already there, and then insulin secretion goes down, the progression of diabetes. Diabetes is a progressive disease, and the idea on those times was that, with Ralph, that the major mechanism by which there is a progression of diabetes is glucose toxicity. And when hyperglycemia goes there, higher glucose toxicity goes there, and this determines the deterioration of our glucose metabolism and the progression of diabetes. So with that, with the use of fluorescein, we tried to, we demonstrated that actually we were able in pancreatectomized rats, in meaning that diabetes is due to pancreatectomy and the reduction of insulin secretion, no insulin resistance at all, but still you can see that there is an increase in insulin secretion. Where is it? Okay, insulin secretion with fluorescein, and on the right side you will see that there is a determination of insulin resistance, the orange bar, with diabetes. Remember, this is insulin resistance due to hyperglycemia, to glucose toxicity, and by removing glucose toxicity with fluorescein, we were able to demonstrate that there was a reduction of this insulin resistance, actually normalization of insulin resistance, meaning that glucose toxicity can determine insulin resistance and might worsen diabetes itself. What we did not understand 35 years ago, that fluorescein could be a drug. We didn't use in people simply because we used to give it subcutaneously, because fluorescein is a disaccharide. So if you give it orally, you simply give, it's attacked by alpha-glucosidase, so you give glucose and fluorescein. It's just like giving glucose to a diabetic patient, so we cannot use it in humans. Very smart people, certainly smarter than me, understood that just by modifying this molecule so that it cannot be attacked by alpha-glucosidase, you can have something that can be given orally, just like the SGLT2. So you see, it's very simple and very similar. Dapagliflozin, empagliflozin, canagliflozin, they are all the same. They're just fluorescein analogs. So the mechanism of action is there, but you can give it orally, and this makes everything much easier. So once these molecules had been developed, Ralph, the first thing he did was to demonstrate that he was right. Now in humans, not in rats, as we did 35 years ago. And you will see that just after 2 weeks of dapagliflozin, he was able to recover some of the insulin sensitivity in diabetic patients. Again, demonstrating the role of glucose toxicity in humans. And on the right side, you will see something on insulin secretion. You will see that even if glucose concentration goes down because glucose is lost in urines, you will see the C-peptide, which means insulin secretion, is increased in these subjects. So it's not, you will see that glucose concentration is lower, so the stimulation is lower. Still, there is higher insulin secretion. And again, this means that in humans, there is also glucose toxicity on insulin secretion. By doing that, in humans, you can really remove glucose toxicity and probably slow down the progression of type 2 diabetes. Now, the mechanism of action is very easy. This vial is just like some kind of measure of the glucose concentration. In normal physiology, when glucose concentration goes up, we have glycosuria, and this is why decompensated patients lose glucose and they lose weight, and you see there is a significant amount of glucose which might be lost. Then after that, glucose concentration goes down, so it is no more glycosuria. With the dapagliflozin, the SGLT2 inhibitors, we simply lower the threshold beyond which there is glucose loss. So really the amount of glucose which can be lost is really significant. I mean, 150 grams per day means 600 calories per day. It's really a lot of calories which might be lost in urines. And this is responsible for the weight loss. Why we do lose glucose and become leaner? The reason is very easy because glucose which is oxidized and enters the cell depends on the glucose concentration. Once the glucose concentration goes down with the same insulin concentration, less glucose is oxidized, okay? But the cells need to survive. So if less calories are coming from glucose, they need to burn something else, and they start to burn free fatty acids. So that's why people simply lose weight with glycosuria. They lose calories and we start burning more fat. And you think that is probably one of the reasons for the generation of ketones, okay? This is our data of Giulia Ferranini, the daughter of Ele Ferranini. She simply collected some data from few studies with empagliflozin, and you will see that she was able to again show that okay, there is a reduction in fasting glucose. We know that there is also a small reduction in glomerular filtration rate. Because of the combination, especially because of the reduction in fasting glucose, less glucose is filtered here on the left, on the bottom, on the top, bottom, and on the right, you will see the less glucose is excreted. So because of that, from around 90 goes to around 50 grams of glucose, which is lost per day, which is still significant. Again, 50 times 4 means 200 calories per day, and people should lose weight, okay? But this was not happening in these patients. This is the expected weight loss in men and women inside the study, and there were no difference in the calorie expenditure. So, they also measured the real body weight, and you see that after the initial weight loss, there is no more weight loss. So, since the body weight is entries and exits of calories, if their excess of calories are still high, the only reason for not losing weight when you are giving these SGLT2 inhibitors in your patient is simply because your patients eat more. Now this has been demonstrated because there is somehow carbohydrate craving or whatever. And I believe it is very useful, clinically useful, because you just have to tell the patient, you don't have to diet, just don't eat more, and you will keep losing weight with the SGLT2 inhibitors. Another important point is that, again, the vial, is that giving this SGLT2 inhibitor is just like doing a hole inside this vial. So there are no other mechanism of action. The amount of glucose which is lost depends just on two variables: the glycemia, how much high is the level of glucose, the higher is the level, the higher is the amount of glucose you will lose, and the GFR, which is somehow how big is the hole you are doing in the vial. There are no other variables at all. So because of that, when glucose concentration goes down and you actually reach the level of the hole, then there is no more glucose loss, virtually no more glucose loss. So as I mentioned yesterday, this is particularly useful when you're giving these drugs together with insulin, because this is the only drug which stops working when hyperglycemia is getting there. So the only problem with that is that the mechanism of action of this drug is depending on GFR. So if the GFR is low, then SGLT2 inhibitors do not work anymore, okay? So it's much better to give early in the natural history of type 2 diabetes because, or type 1, because the GFR is high, the glucose loss is high, and because of that, the efficacy of this drug is high. I was very happy about this, but then something really changed my, and I think also your life. These data have been presented. You remember the major reduction in cardiovascular mortality with empagliflozin, which has been also confirmed by many other results. It really changed everything in the diabetes treatment. So we are not just treating hyperglycemia, we are saving our patients with these drugs. And also other results were coming. The Credence was the first renal trial demonstrating there was a reduction in chronic kidney disease progression with an SGLT2 inhibitors. The EMPA kidney confirmed these results also in patients without diabetes and even without albuminuria. So really is a drug that is able to reduce kidney disease progression. So because of this, rather than giving the drug at the beginning of the natural history, I think we are compelled to give SGLT2 inhibitors at the end of the natural history of type 2 diabetes, especially because we know very well that when the GFR reaches 30 milliliters per minute, we need to stop metformin. And at least me, I usually start insulin treatment. So the later is this moment, the GFR is 30, the better is for the patient, and when GFR is approaching 30, really it's a good moment to give SGLT2. So at the beginning and at the end. But there's something more. There has also been a demonstration that these drugs are able to reduce heart failure and also cardiovascular death in patients with heart failure, again also in patients without diabetes. Okay, so because of these changes in glucose loss, which is followed by water, is an independent mechanism to reduce heart failure. And it's also very interesting that this happens in all the natural history of diabetes, because this is the CLARE trial, see on the left, the hospitalization for heart failure was obtained even in patients without any cardiovascular history on the left, and on the right, even in patients without heart failure history. So even if the patient does not have any history of heart failure, you're preventing heart failure hospitalization. Maybe the number not that high, but still there is prevention. So we are seeing many things. We can see higher efficacy with low GFR. It's a good reason to give SGLT2 inhibitors at the beginning of the natural history of type 2 diabetes. But you also seen that they are able to prevent chronic kidney disease. So this is a good reason to give SGLT2 inhibitors at the end of the natural history of diabetes when chronic kidney disease is there. And putting all this together means that they should be given always in patients with type 2 diabetes, also because together with chronic kidney disease prevention, together with hyperglycemia treatment, you are also preventing heart failure, and this happens whatever is the ejection fraction of your patient. So you don't have to be a cardiologist to understand whether the patient is at risk or not. Just having diabetes is at risk, and with that, with the SGLT2 inhibitors, you are able to prevent also heart failure. So at the very end, I think that really SGLT2 inhibitors are the miracle of the future. They simply use something that is normal, is physiologic. When hyperglycemia is there, the excessive glucose is lost with urine, and this is able to somehow reduce the glucose concentration. This is something natural that we have in our system, but given SGLT2 inhibitors, which are almost natural, they come from the apple tree bark, we are also able to increase the glucose loss, and with this mechanism to preserve insulin secretion, and this has been demonstrated to reduce insulin resistance because of the removal of glucose toxicity, and to lose weight. And really unexpectedly, we are also able to protect our patient from chronic kidney disease and protect our patient from heart failure just with an SGLT2 inhibitor. So I really believe that, and this happens also in patients without diabetes. So really, I believe the SGLT2 is the next metformin. You usually give metformin in the very beginning. I think that you should start with SGLT2 inhibitors as soon as diabetes diagnosis has been done. Thank you for your attention.
Thank you so much, Professor Andrea, for such an elusive presentation. Now it's my... now I would like to call upon stage Dr. Katrina Conte. I think she's already been introduced yesterday. And she would be talking about sarcopenic obesity and the clinical relevance of muscle mass loss during the weight loss. Over to you, ma'am.
Good morning, everybody. Thank you. So, as we all know, the new obesity management medications allow us to achieve a huge weight loss, which is unprecedented and approaches what we can see with bariatric surgery. So this is very good. But weight loss with these drugs has been associated with some loss of lean body mass up to 40%. And so this has created concerns, not just in the medical community, but also among regular people. So people read in the news about the dangers of these drugs as for loss of muscle mass, weakness, sarcopenia, and they're concerned. So what should we tell our patients who come to us asking about this concern, about this issue? Let's look better into this problem. So first of all, there is some confusion regarding the terminology. What are lean and fat-free mass? Sometimes these terms are used interchangeably, but these are two different things. So first of all, we have two main compartments, fat mass and fat-free mass, which is everything but fat. And fat-free mass includes lean soft tissue, which is organs, fluids, including muscle, and the bone mineral content, the bone mineral component. So fat-free mass comprises lean soft tissue, which is organs and muscle and fluids, and muscle is pretty much half of lean soft tissue. So when we read reduction of lean body mass, it's not just muscle, it's lean mass, okay? And these are two different concepts, muscle and fat-free mass, because fat mass and fat-free mass are measured by DEXA, for example, at the molecular level, regardless of where these molecules are in the body. So DEXA just tells us how many fat molecules and fat-free molecules are in the body anywhere, whereas muscle and adipose tissue are tissues, okay, so at the tissue organ level. And skeletal muscle comprises fat-free mass, is mostly fat-free mass, but there is also some fat molecules in muscle. And adipose tissue is as tissue, it's mainly fat molecules, but there are also some fat-free molecules in adipose tissue, the stromal tissue, for example, okay? So fat mass does not equal adipose tissue. These are two different concepts. Fat-free mass, lean body mass does not equal skeletal muscle. And there are only few techniques that can actually measure muscle. And these are the MRI and the CT scan and ultrasound to some extent. So lean mass and fat-free mass include skeletal muscle, which is approximately half of the lean soft tissue, but also other tissues. DEXA, which is what is used in the studies, measures lean mass and fat-free mass, not muscle. And there is no definite consensus on how muscle data should be interpreted, meaning in absolute terms or in relation to body mass, which is quite different. And there are very few data on changes in skeletal muscle during treatment with incretin-based obesity management medications. So we read about lean mass, fat-free mass, but it's not muscle. There is no actually data on that. So my next question is the proportion of lean mass lost with GLP-1 based drugs greater as compared with other weight loss interventions? So is this more severe, worse than with other interventions? So let's compare the loss of lean body mass with the obesity management medications and diets. So it's pretty much the same, up up to 38%. There is a huge variability, of course, because studies use different measurements, different techniques, but up to 38% of the weight lost with diet is lean body mass. So similar to what we see with incretin medications. And the same for bariatric surgery, up to 44% of the weight loss is lost as fat-free mass, okay? So similar data. In general, the greater the weight loss, the greater the loss of lean body mass. So if you lose more weight, you will also lose more lean body mass. And this is, for example, an example with tirzepatide. So there are different categories of weight reduction, okay? So as the weight loss increases, the loss of fat mass increases and the loss of lean mass increases. But look at this, the loss of lean mass is much smaller as compared with the loss of fat mass. So when people lose weight, they mainly lose fat mass. So body composition eventually improves because the proportion of lean mass is greater eventually at the end of the intervention. And the proportion of weight lost as fat-free mass, as lean body mass, is actually similar regardless of the amount of weight lost, okay? So in absolute terms, you lose more lean mass, but the proportion is similar. So lean mass loss occurs with weight loss. The greater the weight loss, the greater the lean mass loss, and the amount of weight loss as lean mass is similar across interventions. Next question, is mass enough to define skeletal muscle? So we are concerned about sarcopenic obesity, but let's see what sarcopenic obesity is actually. Sarcopenic obesity is defined by a reduction in muscle mass, an increase in fat mass, but also a reduction in muscle function. And actually, this is the first step for the diagnosis, a diagnosis of sarcopenic obesity. So a reduction in muscle mass is not enough to diagnose sarcopenic obesity, okay? We need to perform very simple tests that we can really perform in our outpatient clinics, measuring upper limb strength with, the hand grip strength test, or lower limb strength with simple tests such as the knee extension test or the chair stand test. Okay, so we don't have much data on objective measurements of muscle function and strength during the studies with incretin-based obesity management medications. So let's look at what happened with other interventions, diet and bariatric surgery, which we have seen yield a similar loss of lean body mass. So as for diet, hand grip strength, so upper body strength, pretty much the same, not significant change. Lower body strength, there is a reduction, okay? There is some reduction in the strength of the lower limbs. Let's see what happens with bariatric surgery. So similar results with hand grip strength, slightly significant reduction, and in absolute terms, a reduction in lower limb strength, but if we normalize the strength to the body weight, so strength per, the body weight, actually there is no change. So in relation to the body mass, strength is not changed. There is even a trend towards improvement, okay? And look at the data from the studies. So again, we don't have these objective measurements, but tests like questionnaires were administered to patients, patient-reported outcomes were measured, and so there are also domains that test physical function. So, and this is very important because this is how patients feel. So they ask patients, do you feel better? And actually there was an improvement consistent in all the STEP trials, this is semaglutide, in people treated with semaglutide as compared with placebo. There were improvements in physical function, and this is also interesting. So two different questionnaires, but similar results. Those people with the poorest physical function at baseline were those with the greatest improvements in physical function. And this is also reassuring, very reassuring. and this is with tirzepatide, the greater the weight loss, the greater the improvement in physical function, which is also reassuring. And we do have an objective measurement of physical function, which is the 6-minute walking test, which was done in people with heart failure with preserved ejection fraction. And these are people who are highly symptomatic, okay? And there was an improvement. They were able to walk more, to function better after weight loss with these drugs. So even in people who are highly symptomatic with heart failure, there was an improvement in physical function. Let's look at what happens. So we have seen that with weight loss, with these drugs, physical function improves. Okay, let's look at what happens when people regain weight. We know that when people stop these drugs, this is the step 4 trial, so people were on semaglutide and then they were randomized either to continue semaglutide or placebo, and those on placebo, of course, regained weight. And those who regained weight had a worsening of physical function. So physical function improves with weight loss, and it worsens with weight gain. Another important quality of muscle is, the fat content in muscle, because these can have detrimental effects on health, both metabolic and mechanical, okay? So it negatively impacts health. So let's look at what happens with these drugs. We have data with liraglutide, and there is a reduction in intramuscular fat. And the same with tirzepatide, a reduction in the content in muscle fat infiltration with tirzepatide as compared with insulin in people with type 2 diabetes. And this is also reassuring. So muscle mass, muscle function, and muscle quality are all important characteristics that correlate with physical performance and health outcomes. And in general, weight loss has a neutral or beneficial effect on physical function, and it is associated with reductions in muscle infiltration. So, is lean mass loss a reason to avoid incretin-based obesity management medications? Based on what I've said so far and on the benefits that we know that are associated with these drugs, and not just, of course, in terms of physical function, but also in terms of cardiovascular and cardiorenal protection, actually I would say, well, no. I mean, it's a very good balance in favor of the benefits, so we should use these drugs. But are there any other concerns? Are there particular categories of people we should be concerned about? So we know that people in the real world are different from people enrolled in clinical trials, diverse populations. I mean, in the real world, there is a wider age range, so we treat people who are maybe older than those who are participating in trials, and so people with more severe obesity. So I think there are a few categories we should be somehow concerned, or we should pay particular attention. For example, older people, because we know that muscle mass and strength decline with age, and particularly strength. You know, the decline in strength, men, women, black, whites, is much greater than the decline in muscle mass. And it's been postulated that the loss of lean mass equals a decade of human aging, and this has raised concerns, okay? But let's look at what happens to muscle mass and strength with weight reduction, okay? So this is on the left-hand side is the same data, so reduction in muscle mass and strength with aging. And this is what happens with calorie restriction. So there is a reduction in muscle mass, but there is a slight increase in muscle strength. With exercise, non-significant reductions in both. And when you combine calorie restriction and exercise, there is a reduction in muscle mass, but there is a huge improvement in muscle strength. So aging is different. The reduction in muscle mass with aging is different than the reduction in muscle mass that we see with intentional weight loss. People with severe obesity. So we know that people with obesity actually have greater muscle mass because they need more muscle to carry a heavier weight, okay? So it makes sense, it's perfectly physiological. They grow more muscle mass because they're heavier than other people, but the heavier the person, the smaller the relative contribution of the lean body mass to the weight gain. And why is this? Because people with severe obesity, they don't move much, okay? So they don't use their muscles. So they have reduced muscle mass in comparison with people who are lighter, okay? So that could be people with severe obesity, with sarcopenic obesity could be a concern. And sarcopenic obesity is somehow worrisome because it has detrimental consequences on all the organs in the body. So it's associated with frailty, metabolic abnormalities, cardiovascular disease, reduced quality of life. So we should prevent it. Clinical trial participants are different from real-world patients. Some populations might be at risk for sarcopenia, and particularly older people, because muscle strength and mass decrease with age, so they have lower muscle mass at baseline, and people with severe obesity who have relatively low muscle mass. So how can we prevent the loss of muscle mass? We should know, of course, the factors that are associated with muscle loss, for example, aging, or pre-existing low muscle mass sarcopenia, for example, in elderly people, or people with chronic conditions such as type 2 diabetes, for example. And weight cycling is also a possible concern. And we know that adequate dietary protein, and we will hear about nutritional strategies in people treated with these drugs in the next lecture. Adequate dietary protein can help maintain muscle. Exercise, particularly resistance exercise, is a powerful tool to preserve muscle mass, so this is important in these people who might be at risk. And possibly the new medications. In the afternoon there will be a lecture on the BELIEVE trial on bimagrumab, which is a drug that is in development for the preservation of muscle mass during weight loss. So my key take-home messages are sarcopenia and frailty as a consequence of weight loss are unlikely in most people, okay? So this shouldn't be a concern. Of course, we can optimize the composition of weight loss, but we should not be so concerned about this issue in most people. Some populations, for example, older adults or individuals with severe obesity and other conditions at risk for sarcopenic obesity may be at risk, but we have tools to prevent it. So adequate nutrition and resistance exercise combined with anti-obesity medications or bariatric surgery help optimize body composition during weight loss. And so this is something we should bear in mind. And I thank you for your attention.
Thank you so much, ma'am, for a wonderful talk. Moving forward, we have a next talk on nutritional priority for GLP-1 receptor therapy in obesity. To deliver the talk, I would like to invite Dr. Shagun Bindlis, ma'am. Ma'am has already been introduced yesterday. Over to you, ma'am.
Good morning, everyone. Thank you very much, Dr. Conti, for wonderful overview of the sarcopenic obesity. So we just heard how sarcopenic obesity actually led to the frailty, disability, and mortality. So now we are going to talk about the flip side. So basically, I'm not talking something new. You have heard about from lot of lectures, but I'm going to give you a clinical framework about from the lifestyle medicine and the longevity medicine perspective. So which will be very helpful for the clinicians in their practice. We do have one or two overlap in the slides, so I will skip that one and go a little faster, but we'll focus on more on the nutrition priorities. So we all know the rising obesity and diabetes burden is there in India and globally, and GLP-1 therapies are effective, but they're not standalone solutions, and we all discussed why. And nutrition and lifestyle determines the long-term success. So I want you to think from the metabolic health challenge perspective. So aging isn't just how long we live. It's also about how well our metabolic factors function. And this is a very well-known fact that this less than 12% of middle-aged adults are actually metabolically healthy. And when you think about the metabolic syndrome, overall, we are not talking about the biological clock. We are talking about multiple factors which are basically kind of correlated with your epigenetics, it can be genetical or environmental. All of them basically are speeding up this metabolic syndrome or causing the aging. So there is a word and term which we use now from lifestyle medicine perspective called inflammaging. And inflammaging is a metabolic health decline, and this is a hidden pathway to the disease. So now when you talk to the patients, your perspective about the inflammaging, they just get very curious. What does it mean? So all of this, when we put together, when we tell patients about metabolic syndrome, it's very hard to put it together, but when you put it in the picture format and you put it together in the form of we talk about insulin resistance all the time, visceral fat, blood pressure issues, dyslipidemia, poor sleep, processed foods, and sedentary lifestyle. And sedentary lifestyle, we all know, is a secondary, like it's a basically second part. Nowadays, it's almost equal to smoking. That all actually leads to these metabolic dysregulation. It causes these inflammatory pathways to activate, and in turn lead to all the muscle mass, belly fat gain, sexual dysfunction. Cognitive decline is one of the very important factor which we have seen, and cardiovascular strain and early mortality, even the cancers. So lifelong health risk definitely can shorten the lifespan. So now I always put my patients' own stories in my presentation. So these are some of the real patients. 42-year-old on GLP-1 loses 20 kg, but returns with fatigue, hair loss, constipation. Is it a healthy weight loss? Then we think about a 22-year-old. This is a patient I actually just saw before taking a flight. She is my patient for a long time, and in June, I started her on GLP-1s, and there was within a 3 months span, she lost almost 40 pounds of weight, not from June, sorry, April. And the way I saw this coming from BMI 35 to 20 was so brutal, I thought, in her case, and I was just so totally shocked. So will I consider myself a success or a failure? So weight loss is not the whole story. That's what is very important to explain to these patients. And I'm very much worried about this 22-year-old who lost so much of weight in 3 months of time frame. So Dr. Conti has already shown this slide. I'm not going to focus here, but I wanted to tell about when Ozempic came, at that time, even like 10 to 15% of weight loss was very good, and people were very happy about it. Now, as we are our obesity toolkit is actually broadly expanding. If you think that, it's like scary good weight loss. It's not, it's definitely scary. So you compare it with the bariatric surgery to retatrutide, which is possibly be there in the market next year. We will, if we put together, we are almost comparable now to the bariatric surgery. So that's the reason from lifestyle medicine, we combined Obesity Medicine Association and ACLM, which is American College of Lifestyle Medicine. So I was very lucky to be part of this joint advisory paper, which was published in 4 different organizations. And our goal was to bring a customized approach to the inflammaging. So because metabolic health is equal to biological age management. So pharmacology starts the journey, nutrition sustains it. And how does it do? We all know that we have risk versus challenges with the GLP-1 therapy. So we have some of these side effects which we really need to address, and that's what we are talking about. And some are the hidden side effects which the patients don't even tell you about. So constipation is very underestimated. Skin issues, we heard about Ozempic face, Ozempic butt, and there is like so many Ozempic related side effects which people were coming in later stage, because you not only lose fat from one part of the organs, you can also lose it from the fat and different part which will actually make you look more aged. So, so that's the reason if you really look at this from lifestyle medicine perspective, we have a framework of 5 A's. So it is called assess, advise, agree, assist, and arrange. So this model actually comes from there. We have put it into the eight sections based on this 5 A's framework, and we have put this nutritional priorities to support GLP-1 therapy for obesity. So I will go to these each and every block combined with like 2 blocks together. So our first one starts with assess, and assess consists of patient-centered assessment, and where we always start with dietary screening using 24-hour recall method, baseline labs, and ruling out nutrient deficiencies, which is again very commonly missed. Personalized to vegetarian or cultural context. Cultural context is very important as well. Every ethnicity is different. Then we have to discuss the nutrition checklist before even prescribing the GLP-1, and multiple factors has to be evaluated, whether these patients are even eligible for these medications or not. Second framework is about advice. So we go over GI side effects and the preferences. So our cultural aspect addressing the preferences, emphasize on nutrient-dense, minimally processed foods, and set expectations. So setting the realistic expectation right from the beginning. So every patient who comes on these medications, what are they worried about? They're worried about plateau. They don't want to plateau, and that makes them to go advance the medication to the next dosage, thinking that they're just going to plateau, they will go through the weight gain, and nobody wants to see that. So there's a lot of pressure on the clinicians to rapidly advance the dosage to the next step. So setting the right expectation from the beginning, that plateau is real and it can happen if any dose and at any stage, even if you reach to the biggest point, but we have to go step by step, also addressing the side effects on time. So I'm not going to go detail on this very, it looks a busy slide, but 2 points which I really want to tell from the clinical perspective is, so I just want you to think about the nausea, which is about 40 to 45% in the patients, very commonly missed actually because patients underestimate this nausea. So if the patient is on medication already, and if they inject on Monday, for example, they'll feel nauseous on Tuesday. If this nausea lasts for more than a day, do not titrate up. Even if they ask you, do not titrate up, stay at the same dose. If the nausea persists or is accompanied by vomiting, you reduce the dose. Again, patient doesn't want, they want to go on a Zofran or they want to go on a Reglan type of medications which will help with the nausea and keep advancing the medication, but higher you go on the medication dosage, definitely the side effects get worse. Another very important point which we definitely want to make sure that patient understand is that don't drink a lot of fluid with the meals. The fluid will solubilize the meal and increase osmolarity, which slows the gastric emptying. So we know that we want to drink more water, we want more fiber, and hydration is very important, but drinking it in higher dosage of semaglutide or tirzepatide can actually be not beneficial for these patients because it will increase osmolarity and slows the gastric emptying and make patient more sick. So mindful eating, being aware of being satiated is very important. So patients need to stop eating a meal the second they feel full. And if they force eat or they do not eat whole day and they eat a big meal in one time of the day, definitely it's going to cause the illness. So third one, we go to the deficiency where we already talked about prevention plus muscle or bone. So important thing is micronutrients and protein. So we always check for B12, vitamin D, iron, calcium. And hack here is the routine monitoring. We have to do the at least 3 monthly or 6 monthly monitoring based on how rapidly you're advancing the dosage. And be very mindful. In US, we have a lot of bariatric patients now who are actually, their diabetes actually has come back in 1 or 2 years, then they want to go back on GLP-1 and they have been able to sustain the weight loss. But those patients, we see these nutritional deficiencies a lot. So it's very important to be mindful about that. And then we also have protein, 1.2 to 1.5 gram per kg per day, plus resistance training. So this is the prescription you have to write. We have to explain what does 1.2 to 1.5 gram per kg per day protein means, plus how much resistance training is needed. Again, it is based on the patient's age, but resistance training, minimum of 2 times a week for 30 minutes is very, very important. And people, again, underappreciate the importance of resistance training that causes the sarcopenic obesity. So actually, we have gone through all this graph with Dr. Conti, so I'm not going to emphasize on it, but you can see in these graphs very clearly that how much difference is there between, we are not only losing the fat mass, we are losing the lean body mass as well. And what happens when stopping medication? So this one, Dr. Conti also told about the satiety hormone, and patient always ask this question, what happens when I start? So that's the fear they have. As soon as they're going to stop the medication, all the weight will come back, and they don't like that. So they definitely want to be on a maintenance therapy or taking the medication, because there is a concept of set point. So your body is very, very prone to the set point. If the patient has been on 200 pounds for a long time, and even if they lose the weight by taking the GLP-1 and they come down to, maybe they lost about 20 pounds and came down to 180, once they stop the medication, your body's normal tendency is to take you back to the 200 pounds, because that is your normal set point. So set point is also another part of setting expectation, that it takes, for body, it takes some time to understand and reset the set point, and that's the reason we see that rapid weight gain, and that causes more frailty and imbalance in weight management. So next step is the holistic integration model, where we use 7 pillars, where we call micro habits. Importance is sleep, 7K. So we don't want to tell about 10,000 steps anymore. Even there are a lot of studies that shown that even 7,000 steps are equal to 10,000. So people are actually more motivated to walk for 7,000. They think that it's more doable, because an average person who is working and sitting on his desk in a whole day, they are not even getting 2,000 to 3,000 steps. So when you start encouraging them that, okay, let's start with 3, now make it 4 or 5 and come to 7, because 10,000 in a day with a busy day is very difficult to achieve. So nowadays this theory has come from lifestyle medicine perspective, that let's start with the 7K steps, 7 hours of sleep, stress management, mental health, build social connections. Very important is social connections, family support, and limit the substance abuse. And pair this pharmacology with lifestyle precision. So we use the integrated model. If we put all this together, we have food is medicine, medically tailored meals, and cooking education is important. We use the group visits and telehealth. This was my part of contribution to this paper. We did see a lot of studies that how group visits and frequent check with the telehealth and nurses and support staff who is going to follow up with the patients, that actually helps with the compliance and actually also helps with the motivation to the patients to be sustainable to the treatment plan. Dietitian and lifestyle medicine collaboration, so it's always good to have a collaboration with the team, so multi-team approach. And then we have a pilot group programs that we use, that is digital tools, community engagement in urban and suburban settings. So we do a lot of health fairs, and we do like culinary teaching program, where we do encourage patients to learn how they can implement healthier lifestyle with higher protein in their diet in the community. So beyond weight loss, so I think this is a summary of this, that inflammaging is reversible. We really have to put our set point of the brain, that we have to start thinking beyond the weight loss, because everybody right now is so obsessed with the weighing scale. You would have heard from your patients that every morning as soon as I wake up, first thing I do is to go and step on the scale. And the scale is not real, and it's not giving you the right picture. So to start thinking beyond the weight loss, start thinking about your metabolic health. And it's when you combine this, our goal is not just the weight loss, but we want to delay this metabolic aging and preserve the health span. So my take-home pulse is that we 4 societies, we all came together, we put the 8 priority framework. This all, basically it's a one blueprint. Metabolic health is modifiable, aging is not. Preserve muscle, prevent deficiencies, personalize the care, go through the practical hacks are like fiber, protein timing, micronutrient vigilance, And then clinicians must go beyond the medications to guide the behavior, support, and long-term success. So GLP-1 therapy, if you think about it again, is without the nutrition, it is like flying without the fuel. So we definitely don't want our plane to fly without the fuel. So pharmacology prescribes the weight loss, nutrition sustains the health and the longevity. Thank you very much for attention.
Thank you, Dr. Shagun, for a lucid talk. May I invite all the speakers to be on the stage to address the queries of the participants, if there are any.
So this time, what we have provided the facility is, you can put your questions in the app and then they'll come directly to us. So kindly type your questions in the app so that we can have the question answer session.
Also, you can send the questions on a piece of paper. You have notepads and pens in
So,
your bag,
Dr.
so you
Andrea,
can send
we have
your
a
questions
question
on the
for
piece
you.
of paper.
So we have a question for you. In your view, should sarcopenia screening be a routine practice in managing obesity before starting weight loss therapy? And what should be the frequency of measuring it? What should be the frequency of screening for?
So there is no specific guidance, but we know, for example, from studies in bariatric surgery, that the greatest, so for bariatric surgery, the greatest weight loss and loss of lean body mass occurs within the first 3 months. So for bariatric surgery, we should monitor carefully, and nutrition is super important also in bariatric surgery. So the first months are the most relevant. For the medications, things are different because you increase the dosage slowly, and so you're not going to see such a rapid weight loss. So you should monitor probably after 2 or 3 months at the highest dose you're giving. So, but there is no specific guidance.
But
So
does that change with SGLT2 versus GLP-1s, and is it the same for all GLP-1s? I mean, the frequency?
Well, of course, for example, with liraglutide, you get to the highest dose quickly because it's weekly upscaling, whereas with the weekly medications, you change the dose every month. So it's different, yes, depending on the dosing regimen. So, for example, if you use liraglutide...
So where our approach should be different when the lean muscle mass is exposed to a greater extent? Should we stop the medications, or we look for some other means to increase the body mass?
So, first of all, to some extent, a loss of lean body mass, and which includes muscle mass, is kind of physiological in people with, let's say, normal, but for example, a young man with obesity. I wouldn't be too concerned about some loss of lean body mass because, again, as the weight lowers, they don't need that much muscle because they are lighter. And so, it would be energy inefficient to maintain that much muscle. But of course, for people who are losing a lot of weight very rapidly, nutrition is super important. Yesterday I argued against lifestyle, but of course, I was just playing the role I was given. Nutrition and lifestyle is super important, and there is guidance now because they did a great job.
Right.
So we should all bear in mind these indications and these recommendations. So I don't think we need to. Well, of course, if someone is losing too much weight and is not eating anymore and losing too much lean body mass, we should reduce probably the dose and also provide nutrition advice and recommendations as for physical exercise, particularly resistance exercise.
So,
Dr. Shagun, it was a great talk, by the way, and congratulations on the study. So, we believe that nutrition, again, is a very important factor, but then how do you counsel a patient? Because we know that when we start GLP-1 analogs, the primary loss is the fluid loss, which happens in probably in the primary doses of GLP-1s. And then again, the major fat mass loss happens probably when we start about 5 milligram of tirzepatide or when we escalate the dose beyond 1 mg of sema. So how do you counsel those patients? Because for them it's just overall fat loss, overall mass loss.
That's a very good question, and counseling has been a major part of our prescription nowadays, because over time we have learned that if we are not setting the expectation right from the beginning, it does not go well. So explaining all this, actually this framework, when we put together, our patients are connecting with that better. I show them this, we start from the 24-hour recall, I do all the labs and I tell them that this is where you are. And I think also the understanding about that, don't go obsessed with the weighing scale. Weighing scale is not a right measurement of your real weight. Weighing scale does not give you enough information about your muscle mass at all, actually. So that actually helps patients to understand, and when they do DEXA scan or the in-body scan, when they go in the outside world, we can show them reality about where we are standing now, and once you start the medication, we repeat it again in 3 months, then it really gives a very clear picture. So practically, it's not possible in every patient, but setting the right expectation from the beginning has really helped.
Thank you, ma'am. Question to Professor Adria. I would combine two questions. What is the mechanism of action of SGLT2 inhibitors in non-diabetic people who are non-diabetic? And second thing, how do you see the weight loss with SGLT2 inhibitor when we have GLP-1 receptor, which are very costly in India? So weight loss with SGLT2 inhibitors, and what is the mechanism in non-diabetic people?
Okay, in non-diabetic people it's very interesting because remember the nephron? What happens is that you inhibit the reabsorption of glucose, but also of sodium. Okay, so with this inhibition of sodium, more sodium arrives to the macula densa, and the kidney thinks they are going to lose too much sodium, so to prevent higher sodium loss, it reduces the glomerular pressure. Okay, and this reduction in the glomerular pressure preserves the kidney. So this is independent of diabetes or hyperglycemia. It's just more sodium going to the macula densa, which then reduces the glomerular pressure, and this preserves the kidney. And the other mechanism of action, which is close to this, is that there is a different water, let's say, administration in our body, meaning that I think it's experience of everybody that after 1 or 2 weeks, some of the patients complain that there is more urine volume, and this is because there is some water redistribution. And usually patients tell us that they lost a couple of kilograms in 1 week, and certainly that's not fat, because you cannot lose a couple of kilograms of fat in just 1 week. That's water, okay? And the gain is following this mechanism of action, is just following sodium, not glucose, and this obviously works also in non-diabetic subjects. So that's why this happens. My bad thing is that why I didn't think about that 30 years ago. That's my point, because when I was studying this mechanism of action at those times. About the combination of GLP-1 and SGLT2, I think it's not a major problem, actually, at least in our guidelines tells that should be the first combination, sometimes even without metformin. The point is that once you lower the glucose concentration again, less glucose is lost. So if you take a patient with high HbA1c, certainly there will be a massive glucose loss and a massive weight loss. While if you reduce the glucose concentration with the GLP-1 with some insulin, first you preserve, you reduce the risk of DKA because you have more insulin. And second, since the glucose concentration is lower, less glucose is lost, and so the calories loss is less. I'm sorry about the old yes, but so the combination I think is very appropriate, and at the moment I think is the best thing we can do to our patients. I think that again for our guidelines is give some metformin, but then start with this because for many reasons, for the mechanism of action, for diabetes treatment, but more importantly for prevention of all the cardiovascular events, kidney events, heart failure events, and everything that's for our patients are more important than just glucose concentration.
Thank you, sir. With this, we come to the end of this session. A big round of applause for all the three speakers for their deliberate.
Thank you, chairpersons and speakers. May I request Dr. David to hand over the mementos outside the hall to chairpersons and speakers. And one more announcement, few of the chairpersons have not taken their mementos, so you can collect from outside the hall. We have kept it over there. So may I request Dr. Bharat Sabu to please be here? And kindly download the Accd app also. The code is at the back of your badge so that you can have a proper question answer session.
So good morning everyone. Today we had an exciting round of quiz. We unfortunately had winners from that side of the hall only. So today I expect winners from this side of the hall. Let's see. So this is quiz number 5 of the event. Kindly scan and join. Twenty more seconds to join. Last 5 seconds, if anyone wants to join. The questions are all based on the topics which you have heard in this session only. So it's pretty easy. Okay, so we will begin. Answer quickly. What does SGLT2 inhibitor cause? Almost all are correct. Let's see the leaderboard, who is on the top. Neck to neck fight. 965, 964. May I know who is Tiger Baby? Can you raise your hand? It's not possible. They are not putting up the hand. Ashley is really close. Kathy is also close. Let us see. Again from that end. That is what I wanted to know. There is something out there. Question 2. Be quick. Little tough. It was clearly mentioned in slides, just a hint. Many missed. It was a tough one, I told you. Let's see the leaderboard. And this is the beauty of this game. It changes so fast. Now, where is this Heartstorm? Can I know? Please raise your hand. Although Casper was the fastest. Last question. What does DEXA does not measure? These are practical things, and actually it was very clear in that slide. No cheating, please. 27 has got it correct. It doesn't measure muscle. So, the winner, let us see. Now, where is this vote goat in blue color? Because there are two vote goats. Come forward. You need to match your icon with this. ये icon आपको दिखेगा. There are two vote goats. You can clearly see. One is in red and one is in blue. So we need the blue one. You are red one. You are blue one. Yes. It's not in colorblind. What's your name? He will come the overall score to you. And he can correct it very also from you.
So moving on to the next very, very important session of the day by none other than Dr. Mohan sir. Before we proceed for the much awaited session, we would like to honor sir for his exemplary work in the field of diabetes, and we congratulate him for being selected for the first EASD Diabetes Global Impact Prize. We are proud of you, sir. May I request you, sir, to be on stage? May I request Dr. David to be on stage? A big round of applause. Congratulations to sir. Thank you, sir, for your presence. So may I now request the chairpersons, Dr. Sunil Kohli, sir, Dr. Deepak G. Pandey, sir, and Dr. S.K. Agrawal to chair the session. Over to the chairpersons.
Good morning, ladies and gentlemen. It's indeed a privilege and pleasure to introduce Professor Mohan. I think he needs no introduction, but I think out of formality, I just have to announce that he's the chairman, Dr. Mohan Diabetes Specialty Center, and oversees a large chain of diabetes centers across 8 states. And I think all of us are aware of the amount of research work that is emanated from his clinics and research centers. He's received multiple awards, I think too numerous to count, over 200 I believe, and is a Padma Shri awardee, which is of course the 4th highest civilian award in the country, and has published I think over 1600 papers in reputed journals. Without wasting much time, he's going to speak to us on monogenic diabetes, I think less understood disease for most internists, and highly underdiagnosed, I would say. And I think he's going to speak to us and educate us about monogenic diabetes. Over to you, sir.
Thank you for the kind introduction, and congratulations to my good friend Dr. Makka and to Dr. Julia Madder, Kirti, and all the organizers for putting up yet another excellent show, ACCD 2025. Every year it gets better and better. I don't remember missing any of these events in the last few years. So I'm going to talk to you about monogenic diabetes and hopefully share with you some recent data as well, no conflict of interest to declare. So what is monogenic diabetes? Very often this topic is not discussed because we all know about type 1 diabetes, we know about type 2 diabetes, we hear about gestational diabetes, and sometimes all the other types get dumped under one other types and they are not discussed at all. They are not the commonest form of diabetes, but I hopefully will show you before the end of this talk why it's important not to neglect even rare forms of diabetes, because for the person whom you're diagnosing it, it's life-changing. So we can't say it's only 2%, so why bother about 2%, let's bother about 98%. For them it's 100% when you diagnose it. And the problem is that monogenic diabetes, because we don't think about it, is misdiagnosed 90% of the time, not only just in India but everywhere in the world. And the saddest thing is that if some of these monogenic forms of diabetes, you would classify them as type 1 diabetes, they'll unnecessarily have to take 4 times insulin injection throughout their life when they don't need it at all. And that's what makes me passionate about this. The first variety of monogenic diabetes is called as MODY, maturity onset diabetes of the young. I started my career quite early, and we won't go into that. When I was 18 years old, I actually joined my late father, the professor of, the father of diabetology in India, Dr. Viswanathan, and started working with him when I was in first year medical school. So when I came to fourth year, final year of MBBS, I read this paper by Professor Fayance and Robert Tattersall, where they described the inheritance of maturity onset diabetes of the young. Now, how did this complicated name come? For those of you who have not been in the field too long, you may not know that type 1, type 2 diabetes is pretty recent. Before that, it was called NIDDM and IDDM. And before that, in the 1970s, there was only one criteria used to separate type 1 and type 2 diabetes: age. So if it is below 40 years, it was called as growth onset diabetes, and everybody below 40 years was assumed to have what we call as type 1 diabetes. Everyone above 40 years was called as maturity onset diabetes. That is terms which were used. Growth onset, maturity onset. Only age was used. You can see how crude it was. Everybody below 40 needs insulin. Everybody above 40 doesn't need insulin. So at that time, in 1976, Robert Tattersall and Fayance, they published this paper and said, hey, hang on. We have got people who are young who don't need insulin. They've never taken insulin, they're doing well. So they described this inheritance and said, this cannot be called as growth onset diabetes. It cannot be called as maturity onset diabetes. So let's give it a new name. Maturity onset diabetes of the young. So below 40, but it's behaving like maturity onset diabetes. That is how the term MODY came. There's another paper which Tattersall also published, where he showed that this goes through several generations. Grandparents, great-grandparents, then the parents, then the child getting it. So just by drawing a family history, you can say who is likely to have MODY. Of course, it's not so simple as we will show you. So these were the criteria which they laid down in the 1975 paper. If somebody is below 25 years of age, considered very young at that time to get what we call as non-insulin dependent diabetes at that time, 3 or 4 generations transmission of diabetes, no ketosis, no beta cell autoimmunity, not needing insulin at all. And what's more surprising, no insulin resistance, no obesity. And therefore, that's not the classical type 2 as well. So they said this is a separate form of diabetes. Of course, Fayance was very excited about it. And there was a little bit of argument between Tattersall and Fayance because Tattersall said his cases don't develop complications, and Fayance said, no, mine do. So after they published their first paper, they didn't publish again together. So that was around the time when I was finishing my final year. I went back to my father and said, hey, this seems to be very common in India. We are seeing a lot of young people who don't need insulin because type 2 diabetes comes at a much younger age. And I said, this must be Modi. So of course it is not Modi, because Modi came much later when the genes were discovered. So in fact what happened was somewhere around the 1980s or so, 85 or so, they said there's nothing called Modi. It's all type 2 diabetes, NIDDM. This is all NIDDM. If it's not IDDM, it's NIDDM. So what is this Modi and all? So Modi was removed from the literature completely. But Fayance didn't give up. Tattersall left the field. Fayance didn't give up. He said, no, there's something peculiar about this. This is not type 2 diabetes. So he went on and then he described the first genetic mutation which describes Modi. By that time, I had got interested in this field, and of course, I published a lot of papers. They're not probably Modi at all at that time. They're non-insulin dependent diabetes occurring before 25 years of age. Some of them could have been Modi, some of them could have been NIDDM or type 2 diabetes, but we didn't have a genetic marker at that time. But Fayance was very excited by my work. He encouraged me, and I'm very happy to say that just 3 months ago, I visited the University of Michigan, where Professor Fayance worked, which is now called the Professor Fayance Center, and I delivered the Stefan Fayance lecture. He was my childhood hero, and to deliver a lecture at the University of Michigan as the first Indian to be invited to do that is one of the greatest honors of my life. And gave me goosebumps to go and say, because he was a very great mentor of mine, because I was the only one who believed in him. Nobody believed in him. And when Modi went away, he said, at least there's one person in the world who believes me, and that's you. And I said, yes, I believe in it because there's something different about this type. So we published a series of papers. Then came the genetics of Modi. So they described the mutation, and what's fascinating is that these are not associations. With type 1, type 2 diabetes, a number of genes, they're only associated with it. They don't cause it. Here, if you find a mutation, that is a cause of the disease. And then they found that Modi is not one disease, but they've described 14 different types of Modi. Later on, Modi 7, 9, 11, and 14 were dropped because they could not be reproduced by other people. But the other Modis remain. But if you know the first 2 or 3, it's sufficient. Modi 1 or HNF1 4 alpha and Modi 3 HNF1 alpha, they are the commonest forms of Modi. In fact, HNF1 alpha Modi 3 is the commonest form. And these 2 forms of Modi, they are thin people, but they respond to sulfonylureas, they don't need insulin, and these are the ones which are classically misdiagnosed as having type 1 diabetes. Modi 2 is even better, GCK Modi, because once you diagnose GCK Modi, you can stop all treatment. They are very mild. They will not develop complications in their lifetime. There will be no retinopathy, no nephropathy, and it's actually wrong to treat them unless they get pregnant. At that time alone, if a woman with GCK Modi, you have to give them insulin during the pregnancy. Otherwise, they don't need treatment throughout their life. And there are other forms of Modi. But the Modi 1 and 3 are the ones you should really focus on. So we started work on this. Once the Modi genes were discovered, we set up a genetics lab. We became the Monogenic Diabetes Center of India. ICMR recognized us. And then we started publishing series of papers of Modi 3, Modi 1, Modi 2, Modi 5. And then we did a comprehensive genomic analysis of all the Modi types and so on. But all these came just from one center. So it was my dream to have a pan-India Modi study. This took some time to actually set it up, and we had to get 65 collaborators from every nook and corner of the country, right from Kashmir to Kanyakumari, right from Gujarat, Maharashtra to Bengal. But we had 65 collaborators. And what was another ironical thing was that this paper got published on the day I delivered the Stefan Fayance lecture, that morning. So I had to introduce the slide that day and say, look, the dream has come true, and this is Stefan Fayance's blessing that it actually got published on the day when I have come to Michigan to deliver this talk. So these are the collaborators, as you can see, from all over the country. We had 65 collaborators as part of this, and this is the largest study. And here again, we had these 120 cases of Modi not just MODY, but other monogenic forms, but mostly MODY. And MODY 3, as I said, HNF1 alpha is the commonest in India. And on the plane here, I read a paper which was published yesterday from Japan, where they've done a whole Japanese study, same kind of numbers that we have, and it's identical in Japan. MODY 3 is the commonest, MODY 1 is the next, MODY 5 is the next, and MODY 12 is the next. The same 4 order in Japan. That paper was published yesterday. I read it on the flight. So we are having very similar types of MODY in the East, Japan, India. I've seen some reports from China as well. The other forms of MODY are extremely rare. And while we are looking for MODY, you'll also pick up other monogenic forms of diabetes. I'm not going to talk much about them in this talk, but somebody you think has type 1 diabetes, but when you do a genetic study, you find that they actually have maternally inherited diabetes with deafness or Wolfram syndrome. And some, unfortunately, have other syndromes like Walcott-Rollison syndrome. If you have Walcott-Rollison syndrome, that child will not live beyond 18 years of age. They'll die of liver failure or kidney failure. Type 1 diabetes is much better compared to these. So monogenic diabetes is definitely worth studying. But only some forms of diabetes, MODY, respond to sulfonylurea. So I put my PhD student Aarti on the job and said we have to find a way where we find out in a clinic when somebody comes to us who has these MODY, particularly MODY 3 and MODY 1. We call this as actionable MODY. So in this paper in Scientific Reports published 2 years ago, we looked at a large series of MODY patients who were confirmed by genetic testing, and then took a large number of type 1s and type 2s and studied all the clinical parameters and said, how do we identify when a young person comes to us? We can't do genetic testing for everyone. So how do we identify these people? So we used various parameters like age at onset, BMI, HbA1c. It took us several years to do that. Finally, it turned out that if you use a simple marker, C-peptide, it beautifully separates out type 1, type 2, and MODY. Particularly, the fasting also helps you, but if you give a meal, a mixed meal, and do a postprandial C-peptide, what you call as a stimulated C-peptide, it very beautifully separates out with a very high sensitivity and specificity. So if you have C-peptide below a particular point, it cannot be MODY, it has to be type 1. And if it's above a particular limit, it has to be type 2 because there's obesity, and therefore the C-peptide is much better. And if they're in between, you can say probably these are the ones who have MODY. We have just made a MODY calculator for India, which probably in the next year's ACCD I can show you. Just by putting in clinical parameters, in your clinic, you will be able to say who has MODY. But let me now pass on to something which is even more exciting, which was published earlier this year, which has been a mini breakthrough from our country. As I said, we get samples from all over the country. And so when we start looking for the various MODY genes, and this is a pancreatic beta cell. And if you see this, doesn't work? Okay. So the ABCC8 and the KCNJ11, these are the mutations which produce a type of diabetes called as neonatal diabetes and certain forms of, which is the point? This one, yeah? Oh, okay. Right. So if you look at the ABCC8 and the KCNJ11 mutation there, if you have a mutation there, what happens is insulin secretion stops. Why? Because for insulin secretion to occur, the potassium channel must close, and that will depolarize the membrane. The calcium channel will open, calcium will enter, and then insulin is thrown out. So that's how insulin works. And if you have a mutation there in the ABCC8 or in the KCNJ, you can get two types. One is called as a gain of function mutation, and the other is called as a loss of function mutation. If you have a gain of function mutation, what happens is the calcium doesn't enter into the cell, no insulin will come, and you get diabetes. This can occur just after you're born, and I'm going to talk about that, and that's called neonatal diabetes. It can also occur in adults, and we call it as MODY 12 or ABCC8 MODY. But the opposite can also happen. What will happen is the potassium channel is always kept closed, and therefore what happens is the calcium channel is always open, too much of insulin will come, then what will you get? You'll get hypoglycemia. So the child is born with hypoglycemia. Throughout life, the child keeps on getting hypoglycemia, which doesn't respond to glucose. You have to give the child diazoxide and so on. So that's called a CHI, congenital hypoglycemia of infancy. So when you have an ABCC8 mutation, if you have a gain of function, it's diabetes, and if it's a loss of function, it is hypoglycemia. But what happened was, we started screening, and we found some cases who came, adults with diabetes, who had ABCC8 mutation, but it was a loss of function mutation. We were completely foxed, because a loss of function mutation should have produced hypoglycemia and not diabetes. So first we thought we made a mistake. So we checked again and again, and we found no, it's correct. A loss of function mutation producing diabetes. So we contacted the best lab in the world for this particular kind of experiments, and that is the University of Washington at Seattle. So we went to at St. Louis, Missouri. So we collaborated with the Professor Colin Nichols there, who has a full setup there, and we said, we are finding this strange thing, can you confirm it? And he did a series of patch clamp experiments. It took us about a couple of years to find this. And he said, you're absolutely right. This is a new type of diabetes that you have discovered, where a loss of function mutation is actually leading to diabetes. Now, why would that happen? Now, if you look at this, a loss of function mutation, if you look at the gain of function mutation, it should have produced diabetes. Loss of function mutation, I told you, will keep the calcium channel open, and you'll get a lot of insulin. You should be getting hypoglycemia. And the gain of function should be producing diabetes. Now, why is a loss of function producing diabetes? The only explanation that we had is that in childhood, they went on putting out more and more insulin. Eventually, the beta cells died, and therefore they developed diabetes. So the loss of function actually got converted into diabetes, and this is the new type of diabetes that we discovered. We call it as MODY15, or a loss of function mutation of ABCC8, and this is a discovery from India, which we just published, and we wrote an editorial on it in JAPI as well. But now I want to move to something even more exciting. I briefly mentioned neonatal diabetes. Remember, KCNJ or ABCC8 gain of function mutation produces neonatal diabetes. Now this is very, very sad in one way, very exciting in another way, because these children are newborn. Before 6 months of age, they are diagnosed to have neonatal diabetes. It's actually of two types. One is a transient variety. We're not worried about that, because by the first birthday it's gone. The child is cured. The second one, which is more common, is the permanent one. The child will continue to get it. Now, how many physicians, if they see a child who's 3 or 4 months old, will think of neonatal diabetes? They'll think of type 1 and start the child on insulin. And that's what happened to this particular child. I've taken the permission of the parents and the child to use her name and to show her picture, because the parents are so grateful that they said, let the world know. Let my child, Ivana Das, become the torchbearer for neonatal diabetes in India. So this is a 3-month-old baby. She was referred to us from Kolkata many, many years ago. She was diagnosed to have diabetes when she was 2 weeks old, 15 days old. The physician there started her on insulin. Sugars didn't get under control at all. High dose of insulin, 14 units of insulin for a newborn child, not under control, so she's referred to a center. Now we have a policy that any child diagnosed before 6 months of age has to undergo genetic testing. So we did the genetic testing, and we found a KCNJ11 gain of function mutation. And this particular mutation causes neonatal diabetes, which responds to sulfonylurea. So we said, okay, let's stop the insulin completely, admitted the child, built up the dose of the sulfonylurea slowly, as you can see there, and then we brought down the dose of the insulin from there to 0 by day 4, and more importantly, you can see what happened to the glucose levels. Now in blue is the glucose level. When the child was on insulin, no response, sugars very high. Child was on sulfonylurea, sugars came down to normal, completely normal. On the 5th day, the child is discharged with no insulin and sent home with tablets. You may think, maybe for 1 week the child responded. This is a permanent response of a child who can completely go off insulin, okay? Now, this of course makes big news, and we had to go to the newspapers because people had to know that these forms of diabetes are there. Now, this is Ivana Das and her mother when they visited us in 2014. My son-in-law Ranjit and I were looking after this baby. When Professor Andrew Hattersley visited us in 2023, we said, let's show Ivana Das to him because he is the father of neonatal diabetes. So she came back when she is 9 years old from Calcutta. Of course, she gets complete free treatment at our Calcutta branch, and that's her when she is 9 years old. What's interesting is, from the day she left our hospital in 2014 till today, 2025, she has not had one single shot of insulin. Insulin completely stopped. Okay? Now, what does it mean if you put it into perspective? If she had continued her insulin, if she had not been referred to a center, if we didn't do genetic testing, by now she would have had 16,000 insulins a day. If you calculate the rate of 4 insulins per day into 365 days into 11 years, it is 16,000 times this poor child would have been poked and would have had no effect at all because it wouldn't have responded. Okay? She would have spent, if you had given the cheapest insulin available in India, she would have spent 2,14,000 rupees on that insulin. Okay? Cost of glucose monitoring, she would have had to do some glucose monitoring, another 1 lakh. So she would have spent 3 lakhs on that. And her poor father earns 20,000 rupees a month. So he can't afford anything. So we'd have to give the insulin, we'd have to give everything, the glucometers and everything, and still the sugar would not have got under control. Thanks to the genetic testing that we did, no insulin for 11 years, 16,000 insulins gone. The neonatal diabetes testing, which people charge 1 lakh abroad, we do it for 2,000 rupees, but that's only a notional cost because we have never charged any child for neonatal diabetes testing. We do it completely free of cost because when a child needs testing, we can't say pay 2,000 rupees. So as a service to the nation, we do it completely free of cost. So the cost of sulfonylurea, which she does, and she uses glibentamide, the cheapest of the sulfonylurea. She takes half a tablet in the morning, half a tablet in the evening. 8,000 rupees over 11 years is totally what they spent. She doesn't do any glucose testing because she says it's totally stable. I don't have to do any glucose testing. She doesn't get hypoglycemia with it. Beautifully controlled. And like a miracle it is. You can't even believe that such a thing can happen. And so the family saved 3 lakhs of rupees. If genetic testing had not been done, ladies and gentlemen, this girl would still have been on insulin and would not have got under control. So you may say, well, Ivana Das is just one child, one swallow doesn't make a summer, as they say, so why are you making so much a fuss about it? There must be, in my opinion, between 10 to 15,000 Ivana Dases in India who are not diagnosed, who are unfortunately still getting insulin. In fact, as a monogenic diabetes registry, we have now got some 2,400 cases referred to us, 432 have neonatal diabetes, 175 have neonatal diabetes syndromes. We think it's neonatal diabetes, worse than that. They have all kinds of diseases like Walcott-Rollison syndrome and so on. Some of them miraculously have much better forms of diabetes. For example, if you take the SLC, the second one shown here, this one, SLC1, it's thiamine responsive megaloblastic anemia or TRMA. If you give thiamine, the cheapest B complex, vitamin B that you can give, the anemia goes away, the diabetes goes away, they don't need any other treatment. Can you believe this, that such a thing happens? We have large series of cases of TRMA now. So what are all these children being treated as? All as type 1 diabetes. So it can be very good for some, may not be so good for some, but at least you'll know, and this is the basis of precision diabetes. Okay? The last one is something which I hate, CHI. If I get a referral of CHI, congenital hypoglycemia, it actually saddens me because that's very difficult to treat. Even with diazoxide, which is not even available half the time, octreotide, even more expensive. Even with all that, some of them don't respond. Of course, we know today, thanks to our library of genes that we have set up, we know which child will respond to octreotide, which child will respond to diazoxide, and which child needs subtotal pancreatectomy as the only cure for this hypoglycemia. Otherwise, this child will die. or they'll develop some brain disorders and so on. So that's a very tough one to treat. But the other three are very rewarding. So we set up the monogenic diabetes registry and all over the country, and one of the reasons I talk about this is all of you might have some cases like this. Before I finish, I just want to tell you one more story. What if you did not diagnose monogenic, the neonatal diabetes when the child was born? I'll tell you another story. So last year, we had a call from Madurai Medical College. So somebody had attended one of my talks, and he said, sir, you said that any child born below 6 months of age could have neonatal diabetes. I have a 19-year-old boy who has come to Madurai Medical College with a foot infection. We are giving him 4 times insulin. His sugars are not getting under control. His foot infection is not healing. But when I took the history, when were you diagnosed? The mother says at 3 months of age. Could this child have neonatal diabetes? And is it worth doing genetic testing now at the age of 19? We said, send the blood sample. So they sent the blood sample. Turned out that they had a KCNJ11 mutation. So we said, add sulfonylurea to that boy. The moment they added sulfonylurea, his sugar came down beautifully. They were able to slowly stop the insulin, and the foot infection healed. So even at the age of 19, it is still worth diagnosing neonatal diabetes. And all you need to do is ask a simple question to every patient who comes to you: when were you diagnosed? At what age were you diagnosed? Can't be simpler than that. And if it's less than 6 months of age, please send for genetic testing. We'll do it completely free of cost for you. So you may ask, in conference I've been asked a question, why even do this? Why not just stop insulin and give sulfonylurea to everyone? Don't do that, please. Because KCNJ11 and ABCC8 is only 50% of neonatal diabetes. There is GADA, there is GLUD, there is INS mutation, insulin mutation, and many others which will not respond to sulfonylurea. They need insulin. So only 50% respond. But to that 50%, it's worth it. And it's my estimation that there are between 10 to 15,000 patients whom we are missing. So I'd like to conclude by saying monogenic diabetes may be rare, but it's very important. And if we as diabetologists don't pick it up, who's going to pick it up? So every child diagnosed before 6 months of age, it's a miracle if they're able to go off insulin. Please think of genetic testing. Please think of us and send it to us. And of course, if you have some atypical form, you have somebody who thinks that they've got type 1 diabetes, but the antibodies are negative, C-peptide is present, some family history is there, think of Modi, you may be able to take them off. How do you send blood sample to us? You are very good at QR codes, so take a picture of this QR code, or if, like me, if you're not very good at QR codes, you still have an email ID, which you can write to us, and I promise you, we won't charge you 1 rupee for doing any genetic testing. And those are other contact details if you like. And finally, if you're not yet joined my WhatsApp channel, I need another 200 people to get 10,000 followers on WhatsApp channel. So the 200 here, if you join, I can celebrate my 10,000th follower on WhatsApp channel. Thank you very much.
Thank you, sir. Thank you, everyone. Thank you, Chairperson, sir. It was an excellent deliberation from you. Thank you. So may I request Dr. David to please hand over the mementos to chairpersons outside the hall. May I request Makar sir? May I request Makar sir to be here to announce the poster and oral paper presentation winners? Are the students over here?
Before I announce the winners for the papers, can we have Dr. Mohan's slide with the QR code on the screen so that people can take screenshot and scan the code also? Last slide of the presentation. Yes. Keep it there for a while. Keep it there. So, as I told you in the morning, we had the abstracts this time for free papers, and we had 24 abstracts. Top 5 were selected for oral presentation, and rest were taken up for posters. And then the evaluation was done yesterday for posters by a team of 4 people, 4 eminent professors, Dr. Amitesh, Dr. Amit Sharma, Dr. Saurabh Srivastav, and for the oral presentations we had Dr. Pooja, Dr. Amitesh, and Dr. Amit Sharma. And after the evaluation, we have got the details, and I am pleased to announce the prize winners first for the oral presentations. The first winner for the oral presentation is Dr. Romala Gautam. Is Dr. Romala here? Can I request Dr. Mohan sir? Dr. Mohan sir, can we have certificates from you for our abstract oral presentation winners? So Dr. Romala Gautam is the first winner for the oral presentation.
You also know that. So please. Congratulations. The second winner is Apurva Tiwari. Is Apurva over here? Third, Soumyabrata Deb. So, for the first winner, we are giving a cash prize of 20,000. The second, for Apurva, it's 15,000. And for the third winner, it's 10,000. Congratulations. May you shine bright in your life. Come. So moving on to the poster presentation, the first prize goes to Dr. Aditi Modi. We have cash prize of 10,000 for first presentation. The second goes to Pushkal Agarwal. It's a cash prize of 7,000. And the third is Dr. Shivam Sharma. Do we have Pushkal and Shivam over here? So no worries, we'll be sending the certificates and the prize to their respective addresses. So congratulations to this new young generation. Thank you, sir. Thank you, Makar, sir. Yes, thank you, sir. I think we can move to the next session, or we should take a break. It's already. So we'll take a short break of 15 minutes and we'll assemble after. Till 11:14, try to be here in the hall. At 11:15, we'll start. Few of the mementos were not distributed yesterday to chairpersons and speakers. Please try to collect. So an important announcement, please, those who have not checked out, kindly check out before 12 o'clock. It's a break, so you can go and do it if possible. So we are starting the session. May I request everyone to have their respective seats, please? May I request Dr. S.V. Madhu sir, Dr. Dhruvi and Dr. Sonika to please come to the stage and chair the session. So over to the chairpersons for the further proceedings.
Good morning, sir. You would want to start, sir? All right. So good morning, everybody, and welcome to our session. I have the honor and the privilege of inviting Dr. Strain, Dr. David Strain. He is a senior clinical lecturer at the University of Exeter Medical School, and he has an expertise in microvascular structure and function. Clinically, he runs a community service for the older adults with diabetes and cardiovascular disease. And with that, I will request Dr. Strain to, yes, please start with the talk, please. Thank you.
Thank you very much, and thank you for that very kind introduction. So, hearing from me again, I'm afraid what we're going to be talking about for the next bit after that wonderful state-of-the-art lecture from Dr. Mohan is back down to basics. We're just talking about how we should be managing our diabetes in our adults across the board. And the question that been set is, what should we be starting with? Now, we are long since past the days of starting with one medication, but how about do we go with this combination medications? These are my conflicts of interest that will be there not quite long enough. Before, a little bit of a reminder. We've seen this slide several times already. Poorly controlled diabetes is associated with increased cardiovascular risk. It's the biggest cause of blindness, the biggest cause of kidney failure. It causes the leading cause of disability worldwide. And we see this slide, but we tend to ignore the very first words on it. Poorly controlled diabetes causes all of that. Actually, today, well-controlled diabetes is associated with a long and healthy life. The Rotterdam study, which got everyone under control from the outset and maintained control, actually demonstrated life expectancy was marginally better in people living with diabetes because they were less likely to have hypertensive disease, less likely to have atherosclerotic disease, because they were getting their medications right from day one. So how do we go about writing this with our patients? The very first thing we have to do is convince our patients that investing in themselves is worthwhile. And this is one of the barriers that we face on a regular time. We have to convince our patients that they want to invest their hard-earned money in maintaining themselves. Now, to do this, I have very simple pictures. Very simple pictures. I show them this picture. I say, okay, today, if somebody gave you this car, when are you going to start servicing it? When are you going to start maintaining it? When are you going to start looking after it? Because if you do that from day one, if you start looking after the car on the day that you receive it, in 20, 25, 30 years' time, you have a classic vehicle. On the other hand, if you wait until the car is rusted, until it's broken down, until the engine's falling out, in 20 years' time, you've got that. Now, the reality is, you, today, are that brand new, fresh, shiny car. We've just diagnosed you with diabetes. We can start looking after you properly today. You can start investing in yourself. Or, we can wait until you're broken and then try and fix you. I promise you, it is much easier to replace the engine of a car than it is to replace your heart, your kidneys, your brain. Now, that works for our patients. Actually, as a scientific audience, we'd like to know a little bit more about why that is the case. And actually, the case for this is all about epigenetics. Now, epigenetics is a relatively new science. And therefore, I'm just going to take a moment to describe what epigenetics is, because actually, it's the science of a textbook. We're all born with the genes that are going to define the way we look for the rest of our lives. Dr. Mohan's just given a great overview of some of the genetic issues that can face people. But actually, your genes are just like a textbook. You cannot change the words in that textbook. But like any textbook, you can change the way the textbook is read. If you were to pick up your textbook of medicine with this audience, and you pick it up, I can guarantee you it will fall open at a page. Chances are the page it's going to fall open at is, well, it's going to fall open at either the diabetes or the endocrinology section. Well, your genes are exactly the same. You will change the way that your genes are read based on which ones are commonly read. You see, remember our DNA, our genes is DNA that's wrapped in circle and then into another superhelix, and then it's wrapped around proteins. And what we do is we change the way these proteins are figured. Your DNA can be changed with methylation. That's effectively, it's like putting a bookmark in the page. You put the bookmark in the page, and that page is one that you can open on a regular basis. If you stick a methylation, you stick an extra little molecule on your DNA will go to that page on a regular basis. The next thing you could do is you could break the spine of a book. You know, when you open a book regularly and you seal it right down the center, then the next time it falls open at that page. If you change the structure of your DNA, histones, that is the proteins that the DNA is wrapped around, then the DNA will more likely open at that page. The alternative thing you can do is just marker a few pens, maybe fold over the corner of a page, and you know that that's the page you want to go to. The way we do that in our DNA is we put RNA strands in there that will actually match up to that point, and that will hold open pages at that particular place. What we end up then doing is not changing the textbook, but changing the way the book is read. Now, diabetes does that to our DNA. What we see is hyperglycemia will activate one particular gene, the P66 SHC gene. The body detects the fact it's under attack. Remember, hyperglycemia is an attack to your cells. And when those cells are attacked, it activates a gene that causes reactive oxygen species to appear within the mitochondria. These reactive oxygen species then cause cellular apoptosis. They can cause glycocalyx changes, which causes vascular inflammation. They reduce nitric oxide, which will cause endothelial dysfunction. The hyperglycemia leads to all of those changes. Now, if that hyperglycemia stays there for a while, it will eventually change the protein, the SIRT1 histone, that P66SHC is sat on. It will change the gene that's a precursor to that, the P53 gene. What you end up with is a situation where the hyperglycemia has led to a structural change, not in the DNA, but in the proteins around it. Such that if you take away that hyperglycemia, you still have these legacy changes. This is the fundamentals of the diabetes legacy. This is the fundamentals of why it's so important to get it right first time. Now, this was the first gene that we described, but actually we have now seen that there are literally thousands of genes that get the transcription changes in chronic hyperglycemia. And this is why it's important to get it right from day one. Going back to our patient, this is why it is right to start cleaning and polishing the car on the day that you receive it, rather than waiting until the rust settles and then trying to fix it. So, how do we go about administering our first medication? Well, the first thing to think is, when are we going to give it? This is a study that we did quite a while ago where we looked at how we go about giving our first medications. And actually, when you look globally, only about a third of the world gives a first medication within the first month, globally. Here in India, you are actually the best in the world at giving that first medication on day one. In our global study, you were the best in the world at getting that first medication to the patient as you come. However, we then looked at how quickly we gave the second medication. And the HbA1c was highest here than it was anywhere else in the world before the second medication was given. So you're the best at the world at giving the first one, but then it takes a bit longer to get the second one. So maybe there then becomes an argument for, on day one, maybe giving multiple different medications. But again, there's the other issue there. How do we approach this? Which medications do we give? We want to give combination therapies that's going to improve adherence, so maybe fixed-dose combination therapies. We also want to give therapies that are going to treat the underlying disease. Now, hyperglycemia is not the disease. That's the symptom. That's like taking a patient who presents with a cough and pneumonia and green sputum, and you give them nothing but paracetamol for the fever, without giving them the antibiotics for the underlying pneumonia. We now understand what the underlying causes of diabetes is. It was the ominous octet, as described by Ralph DeFronzo, that we've now added in some inflammatory dysregulation, the microbiome dysregulation, and the changes to the neurotransmitter function. These are the disease processes. Hyperglycemia is the symptom. That's the fever. These are the disease processes that cause the underlying problem. So rather than just addressing the fever, how about treating the pneumonia? Rather than just addressing the hyperglycemia, address the underlying causes. Now, what are our options here? Well, metformin. Metformin, number one, will suppress your hepatic glucose production. It will improve glycemic control. It has impacts on the muscles, impacts on the fat tissue, and pretty much universally accepted. Plus, it's cheap. So we're going to go with that one first. Then what do we add into it? Well, the DPP-4 inhibitors were the next ones to come along. They will increase your insulin secretion, reduce your glucagon secretion. They change the way the gut interacts with food. They improve autonomic nervous activity. And if we give them early, they delay disease progression. We saw that in the Verify trial. If you give metformin plus vildagliptin on day 1, and for that you could read any of the DPP-4 inhibitors, if you give metformin plus DPP-4 inhibitor on day 1, 5 years later, over half of your patients were still fully controlled. So maybe that's another good thing to be adding in on day 1. But the next question is, do we need to give more than just those 2 medications? Because the metformin and the DPP-4, although it will delay progression, the disease still did progression. Even in the early combination group here that had the lower cardiovascular risk, that was still higher than it was in a non-diabetic cohort. So what else could we think about adding in? Well, we've got pioglitazone here. It is the forgotten insulin sensitizer. But low-dose pioglitazone, 15 milligrams, is incredibly effective. Now, it is associated with a bit of weight gain. It is associated with a bit of fluid retention. But if you mix it with a DPP-4 inhibitor, the weight gain is balanced out. If you mix it with metformin, you don't get that fluid retention. You don't see the cardiac complications. So actually, a low-dose pioglitazone into the mix may be seen as a suitable add-in if the patient is showing signs of insulin resistance. But you can't have any talk up here without talking about the new kids in the block. Of course, we have the GLP-1s, and we're hearing all about this on a daily basis. We've got the additional cardiac protection on them. Are we going to add this in on day 1? No. I'm sorry, you are not going to have a patient coming to you on day 1 and go straight for an injectable therapy. The one thing I can guarantee is they won't come back. Maybe if you're managing obesity for them, maybe if you're managing other things, but remember here we are talking about glucose control for our patient living with diabetes. On day 1, you're very unlikely to start the GLP-1. Of course, the other disadvantage with starting this on day 1, lots and lots of titration. The other medications we've spoken about, you can start them at the therapeutic dose today. This, you're months before you get to therapeutic dose. So let's move on to the other one, SGLT2. SGLT2 inhibitors, they do give you tremendous benefit if you've already got a cardiovascular event. But there's now growing evidence that says that they're also affecting the inflammation. They're affecting a whole host of other bits. They improve your Ang 1 to 7. They reduce reactive oxygen species. They will completely get rid of that fluid retention that the pioglitazones caused. They not only reduce advanced glycation end products production, but they are starting to reverse them. They improve your metabolic pathways across the board. So we're actually in a position that maybe we could be looking at not 1, not 2, but at least 3 tablets on day 1. They work synergistically with other medications. SGLT2 inhibitors and DPP-4 inhibitors actually use different pathways to control sugar. They use different pathways to improve vascular function, different pathways to improve gut function. Actually, the combination of DPP-4, SGLT2, and metformin is starting to show a lot of sense. Coming back to treating the disease. This is our disease. These are the 11 elements that cause hyperglycemia. As we were saying at the outset, when we are managing diabetes, if we focus on sugar, we are doing nothing more than looking at the fever of a patient with pneumonia. What we want to do in pneumonia is the antibiotics for the underlying illness. What we want to do for diabetes is treat the underlying disease. So on day 1, let's get that microbiome dysregulation sorted with some good lifestyle advice. Yes, sorry Katerina, lifestyle is still in there. And we've just been hearing about the nutrition components. We will improve gut health with good lifestyle advice. Let's get that metformin in to reduce the hepatic glucose production, improve the muscle, and also have an impact on the gut metabolism. Add in the DPP-4 inhibitor, which will give you that additional benefit. Think about the TZD, which will give you some anti-inflammatory effects as well as the lipolysis, but then add in your SGLT2 inhibitor. With that combination, you're managing the underlying disease. Coming back to our car analogy, if you're given a brand new car on day one, do you just clean and polish it? Or do you change the oil? Do you look at the filters? Do you fill it up with fuel on a regular basis? Or do you just do one element? If you are diagnosed today with disease that is affecting multiple different systems, do you want to just treat the symptom, or do you want to treat the underlying cause? The original question is, should we be looking at combination therapy on day one? Technically, it's not really combination therapy. What we're looking at here, find the underlying cause, treat the underlying cause, not the symptoms. The optimum way to start managing diabetes. We have a very clear evidence base that if we give metformin and DPP-4 inhibitor on day one, we are going to reduce disease progression. But that's not treating the whole of the underlying disease. Maybe think about adding in pioglitazone if you've got clear evidence of insulin resistance, triglycerides elevated, the typical body. Give this synergistic SGLT2 inhibitors, and hopefully keep our patients as healthy as possible for as long as possible. On that, thank you for your attention.
Thank you, Dr. David Strain, for a very wonderful talk. The art of medicine is not just adding years to life, but in adding life to years. And a teacher is one who ignites curiosity, and a speaker is one who answers it. So we are going to have a dual combination, and we are going to hear from none other than our Dr. V. Mohan sir. Sir is teacher of teachers. Can we have a huge round of applause for sir? And it is really a privilege, sir, that I am here to welcome you. He is a teacher, a wonderful teacher and a speaker to whom I think we can be sitting for hours together listening it without being fatigued. Sir is chairman from Dr. Mohan Diabetes.
I've just been introduced, thank you.
Yeah, so welcome you, sir. I think everyone knows you. You need no introduction. The stage is yours.
Thank you very much for that kind introduction, and thanks to Dr. Makkar for inviting me to give 2 talks at this session, back to back. So we have heard from the morning about all the newer agents, and we are lucky to live in an age when we have so many new molecules which are doing much more than glucose control. However, in this talk, I just want to say that glucose control is also equally important, because sometimes we tend to forget that. These are my disclosures. So we know that we have a huge problem of diabetes in India. 101 million people already having diabetes and 136 million people with pre-diabetes waiting to convert. Now, how can we be sure that each and every one of them gets equitable diabetes care? And if you're able to offer the best of the best care to all the 101 million people, we'll be very lucky. But unfortunately, that's not the case, and things like accessibility, affordability also come into play. Now, we're not just worried about the diabetes numbers, we're more worried about the complications of diabetes. And here are data from India, urban and rural, showing the millions of people. Those numbers that you see there are the millions of people. For example, with kidney disease, early kidney disease onwards, we have 25 million people. It's almost like Australia. So why are these people developing complications? That's because the ABC goals of treatment are not being met. A1C less than 7%. You can argue it should be 6.5, but I'm just putting a very loose kind of criteria, 7%. Blood pressure 140/90, and many people tell me it should be 120/70, 130/80. Why are you saying 140/90? I'll tell you in a minute why I put the figures a little higher. And LDL cholesterol less than 100. People say, joking, it must be 50, not 100. I'm just putting it at 100 for a particular reason. Because are we achieving these targets? So this we looked at in the INDIAB study, where we looked at those who already told us that they have diabetes. So INDIAB was done all over the country. Every state, every island in this country was sampled. And only those who told us that they are already having diabetes, that is self-reported diabetes, we then ask them, what medicine do you take, and what's your A1C, and what's your blood pressure, and so on. And shown here are the results. Now, if you look at the A1C, it's about 30% of people who have achieved that. Blood pressure control, that's a B, 40%, close to 50. And cholesterol is about 60%. So you may say only 30% have A1C under control. Even worse, if you look at all the three, A, B, and C, and those are less stringent criteria which we have said. A, B, and C, only 7% of people in India who, in a representative sample, free living people who are supposed to be taking treatment, supposed to be getting these under control, only 7% are under control. Why? Why are these targets not been met? Part of it, at least, is non-affordability of drugs, because 70% of people, unlike in the UK, where the NHS will pay for everything, or in Canada, or in other parts of the world, where insurance will pay. Only 15% of people in India have medical insurance. And that medical insurance doesn't pay for outpatient treatment, doesn't pay for medication, doesn't pay for diabetes. If you get a heart attack, yes, they'll pay for it, but not otherwise. So this being so, when we looked at the INDIAB data and asked people what are they taking, they're still taking the old drugs, sulfonylurea and metformin. And while I'm not at all questioning the benefit of the SGLT2 and GLP-1, these are wonder drugs. There is absolutely no doubt that they're brilliant, they are wonder drugs. But can everybody in India or in a low and middle income country afford it? Well, it's not the case as yet, even with the generic drugs which are coming in or may come in. Now, if you look at the ADA and EASD guideline, they're very clear that if you have cardiovascular risk, you use GLPs. If you have heart failure risk, you use SGLT2s. If you have CKD, then you use SGLT2s. And there's no argument about that. There are clear indications where you have to use the drugs. But what they also tell you is that glucose control is very important. Now, one of the problems which has happened is that with the advent of the newer drugs, the SGLT2s and the GLP-1s, there is a growing perception among doctors that glucose control is not important. As long as you give an SGLT2, it's fine. As long as we give the GLP, it's fine. Let's forget about the glucose control. We have learned from the DCCT, we learned from the UK PDS that glucose control is very important, but people are beginning to forget that in the enthusiasm of using the newer drugs. So while we use the newer drugs, let's not forget that glucose control is also very important, because we know that if you look at the hierarchy of the reduction in A1C, sulfonylurea and metformin still come right on top, despite the weight gain or despite the hypoglycemia and so on. These are the only drugs which people can afford. And even a 1% reduction in the mean A1C leads to 37% reduction in microvascular complications, 14% reduction in myocardial infarctions, and so on. And also, the other thing that we tend to forget is that when you do look at the CVOT trials, which have shown the benefits of the GLPs and the SGLT2s, included in that are people who are already taking sulfonylureas and metformin. So, the point is that glucose control remains central. And the importance of glucose control, rather than being exclusively based on organ protective therapies, is what, as a diabetologist, I feel that while the organ protection is very important, let's not forget about the glucose control as well. So we wrote this paper. Some of you will know Kamlesh Kunti and Stephen Kolajuri, Juliana Chan and others who have, Vanita Arora and others who joined us in writing this article in Diabetologia, where we said that, well, yes, please use all the newer drugs, please use them to their advantage, prevent heart disease, prevent heart failure, prevent CKD, prevent atherosclerotic heart disease, but don't forget about glycemic control. And we make a case by saying that glycemic control is still central in the hierarchy of priorities. We are treating type 2 diabetes, and while we may be only treating the glucose control, there is also an equally important thing to achieve. In fact, if you look at the ADA guideline, they talk about the glycemic control being very important, and they still talk about sulfonylureas having very high glycemia. This is from the ADA itself, and they're still talking about sulfonylureas being important. Then that brings us to the safety of sulfonylureas. Because the two main things we're worried about is weight gain. which again, the lot of the bad vibes that we got for sulfonylureas because the older ones, the glibenclamide and chlorpropamide and the older ones, whereas the newer ones have got somewhat better. So the more modern ones have not shown great problems with CV safety, although we keep talking about this. If you look at meta-analysis, are they likely to increase? And we know from the Carolina trial that even compared to a DPP-4 inhibitor, glimepiride didn't do much worse. So it was almost as good. So do sulfonylureas increase CV risk or all-cause mortality? That has really not been shown in many situations. And if you look at the comparative mortality risk of sulfonylureas, you will find that the modern sulfonylureas like glimepiride and glycoside have much lower mortality compared to the other sulfonylureas. And again, if you look at, compare it with metformin, there is no increase in mortality. Compare it with DPP-4 inhibitors or even SGLT2s. If you look at mortalities, if you compare the sulfonylureas, you're not seeing too much of difference there. What happens if you stop the sulfonylurea? Okay, you got the newer drugs and then you stop the sulfonylurea. In fact, I made the mistake of doing this on a patient who was on a lot of insulin, huge dose of insulin, and I said, what is sulfonylurea doing to this patient? And so I just stopped the sulfonylurea, and the A1C shot up, the sugars shot up, and when we reintroduce the drug, you again got it under good control. The only point I'm trying to say is that just because the newer drugs come, we don't have to throw out all the old drugs, particularly when half the people with diabetes in our country cannot afford. Even the sulfonylurea, they find it very difficult to afford unless we give it free of cost. So HbA1c definitely remains as a priority in many of the studies, which still should not forget about the importance of HbA1c when you treat control. The other point that I'd like to say is that how long have we had the newer drugs? We've had them for 5 years, 10 years maybe. But in the case of metformin and sulfonylureas, we've had them for 60 years. And for 60 years, we have not had such bad effects that these drugs have to be thrown out. Every time we talk about metformin, they'll say, oh, metformin produces this and metformin produces that. And every year we discover a new advantage of metformin. So metformin is again reborn again and again. So while it's very nice to get all the newer agents, we can use them in combination with these drugs in poor countries like ours, low and middle income countries. You may be wondering, when everybody is talking about the newer ones, why I'm talking about the old ones, because that's the only thing half of my patients can afford. And I'm not convinced that these drugs are so bad that they have to be banned or thrown away. And this was a paper I'm very happy to have published because it talked about the long-term survivors of type 2 diabetes. So when this paper was published in 2013, and I understand from the ADA that the Harold Rifkin Award was given to me for this particular paper. So we reported 50-year survival of people with type 2 diabetes, 40 years and 50 years. Everybody in this trial who were survivors had a minimum of 40 years. Many had 50 years or more survival. Well, it's difficult to get such patients in the West because the age at onset or age at diagnosis of type 2 diabetes is much older in the Western population. So when they get it when they're 50, 55, 60, to get 50-year survival in their countries is not so easy. But in India, we know we get diabetes, type 2 diabetes when you're 20, 25, 30. So if you had 50 years to that, you're only 70 years old. So you can get this. So what came out from this is actually the ABC, because we had a group of survivors and we had a group of non-survivors. Non-survivors were defined as those who died before they lived for 40 years and above. And when we had this large series, when we compared the two, turned out that three things were very important: blood glucose control, blood pressure control, and cholesterol control. And that's how the ABC mantra was developed. We then reported on a series of people who were actually more than 90 years old, and some of them are shown in this picture. If you look at this picture, we honored people who had finished 90 years of age and had at least 40 years of type 2 diabetes. And I hope you can spot the two people in the middle there who are not yet reached 90. One is me and one is my daughter. All others are above 95 years of age. I'd like you to talk about this man, the guy sitting here. He was 97, and at 97 he just published a major book. He was a chief secretary of Tamil Nadu, having served 2 chief ministers, and had worked in Delhi as a secretary to 2 prime ministers of India. And he was 97 years old, and he had just written his book, and he had presented his book to me. Many of them continue to live above 100 years, and 103, 104 when they passed away. We talk about type 2 diabetes, shaving off lives of people. That's what we're always told. 15 years, 20 years, you're told. But you can look at survivors who have lived for 50, 60 years with type 2 diabetes, crossed 100 years of age, and the point is that none of them had ever even seen any of the newer agents which we are talking about now. They only used metformin, and they only used sulfonylurea, and they lived to tell the tale. So while, again I'm saying I'm not at all against the newer drugs, I'm very proud to belong to an era when we're getting newer insulins, newer pumps, automated insulin delivery systems, fantastic drugs which can help you to lose weight, almost the same as bariatric surgery. Very proud to live in that. But we also have the other side of the coin where people cannot afford anything. They cannot afford even a sulfonylurea. They're earning 20,000 rupees a month, and for them spending 1,000 rupees a month on medicines is too much for them. So we still have to use the old drugs, use them judiciously. Don't use them if they have renal failure. Don't use them if they have very high risk. Don't use them if they're above 70 or 80 years of age, particularly the older ones like glibentamide. But use the newer ones like glycoside and glimepiride, which have been shown to be quite safe, because these are the only drugs which the majority of people in LMICs can afford. And don't forget that they're very powerful glucose lowering agents, perhaps even more powerful in that sense in lowering the A1C than the modern drugs. So glycemic control is paramount, and its importance cannot be overlooked. Thank you.
Thank you, Dr. Mohan. We've had 2 wonderful talks in this session. The first one reminding us of the need to use early combination therapy, and I think there was a strong case which was put out to say that hyperglycemia should not be allowed to last for a long period, and you should address all aspects of the pathophysiology right from the word go, and maybe a triple combination might be the way to go in future right from day 1. And the second talk, of course, Dr. Mohan reminded us that sulfonylureas are still to be prescribed, not to be written off, and glycemia is as important as the non-glycemic management of a type 2 diabetic individuals. So if there are any questions, I'm waiting for the cards if they arrive. Dr. Das wants to make a comment.
Write the obituary of sulfonylurea. You might have seen that paper that we wrote, exactly what Mohan said. We said modern sulfonylurea, we took that term from insulin. Modern insulin, so we take modern sulfonylurea, glycolazide, MR, and glimepiride. We said that two words we said, they are cardio-safe after the Corona trial, and they're glucose-smart. So that is still today reported at the glucose-smart and cardio-safe. And taking again cue from what Mohan said, we say they're contemporary classics like Ramayana and Mahabharata, which cannot be replaced.
I think what comes out of Mohan's talk is that, in the enthusiasm of newer developments, whether it be newer anti-diabetic agents or anything else, let's not forget what we've been doing over the years. That's, I think, the message.
There's just one question. What is the optimal dose of pioglitazone to be used by Dr. D.K. Gupta?
So I very rarely use above 15 milligrams, and actually we're getting more and more patients, so you'll get a synergistic benefit from only 7.5 milligrams added into the other medications. I'm taking the microphone, but I'm a different population. Dr. Mohan is by far expert. What would you say?
I completely agree with you. Lower the dose, the better, because there are a lot of side effects. Given the lot of benefits that you have, you should also keep the side effects in mind. And so the lower dose works, it's good. The lowest dose possible. Same thing goes for sulfonylureas, by the way. We don't want to give huge doses of sulfonylurea.
Just one small point. I think as long as 60 years before, Bedford survey, David, you've been knowing, Butterfield, Harry Kane, they said that on a trial that tolbutamide, the old sulfonylurea, is cardiovascular protective, and that still continues the concept.
Okay, I'm glad somebody asked a question on pioglitazone, just to remind us that that's still available and to be used. Some of people, we have forgotten about pioglitazone, just like the sulfonylureas. So with that, I think if there are no more questions, we had a wonderful session, and I, along with my co-chairperson, declare the session closed.
So thank you everyone, thank you chairpersons, and thank you speakers. So may I request Dr. Katerina to please hand over the mementos outside the hall to the chairpersons. So this workshop going on in the basement, if anybody wants, they can go and join over there. Now moving to the next very important and very interesting session of the day, I would like to invite the panelists, Dr. J.K. Sharma sir, Dr. Aravinda, Dr. Meenal Mohit, and Dr. Manish Gupta to be on stage, and Dr. Pratap Jethwani to moderate the session.
So good morning everyone. After hearing an excellent talk on early combination therapy and which kind of drugs to be used for type 2 diabetes management, and about the use of sulfonylureas, whether they are still relevant for our country or not, by Professor V. Mohan, we are going to talk about DPP-4 inhibitors, are they still relevant? And I welcome panelist Dr. J.K. Sharma, who is consultant diabetes specialist from the city of Delhi and currently treasurer of RSSDI, Dr. Meenal Mohit, endocrinologist from Jaipur, and Dr. Manish Gupta, diabetes specialist from the city of Delhi. So these are the aspects as far as DPP-4 inhibitors in type 2 diabetes management, they are concerned, that we will try to address in today's our panel discussion. So the first thing is the glycemic efficacy. I will ask Dr. J.K. Sharma, are DPP-4 inhibitors having same glycemic efficacy, or they are having less potency compared to other agents, and is it dependent on the baseline A1C levels?
Thank you, Dr. Pratap. Good morning to all. We all know that the most potent anti-diabetic or the oral hypoglycemic agent are the sulfonylureas. Everybody knows about that. And in the injectables comes the insulins. So we cannot compare DPP-4 inhibitors with the sulfonylureas and the insulins. But definitely after that, they are quite potent. Though the HbA1c reduction is somewhere around 0.6 to 0.8%. But when we talk of the use of these DPP-4 inhibitors, except for certain conditions, suppose there is advanced liver failure or kidney failure, then of course we should not use them. But otherwise, they are the drugs which can be safely used as of today, and they are definitely be used. The only thing is that patient selection. What is the state of the HbA1c? Whether the patient is de novo or we use them as the additional agent. Yes.
Okay. So I think there is enough data to show that DPP-4 inhibitors, they are equivalent to other anti-diabetic agents, and as far as durability and weight neutrality is concerned, they fare better than sulfonylurea, and when there is modest elevation of HbA1c around 8 to 8.5%, they fare better, they fare even equivalent to SGLT2 inhibitors. So the second question, in today's era, we not only talk about glucose control, but we also talk about glycemic variability. So let me ask Dr. Manish Gupta, is there any data to support that DPP-4 inhibitors have got a favorable impact on glycemic variability as compared to sulfonylureas or SGLT2 inhibitors?
Thank you, sir, for that question. So from this meta-analysis, they compared the DPP-4. They had 14 studies, which included 855 patients, and they compared the group with DPP-4 to other OADs. And the DPP-4s did good in controlling the MAGE. So by glycemic variability is defined as the mean amplitude glycemic excursions, which is directly related to the complications of diabetes, namely retinopathy, nephropathy, and even cardiovascular diseases. So that's why glycemic variability is assuming importance more than HbA1c alone. And DPP-4 inhibitors did show significant reduction in the MAGE values as compared to the other OADs.
Thank you, Dr. Manish. So after that, we will move on to the trial which was quoted by Professor David Strain also, that newly diagnosed diabetes, combination with metformin, how DPP-4 inhibitors they fare. We have got verified trial, and I will request Dr. Meenal Mohit to say something about verified trial and the use of DPP-4 in newly diagnosed diabetes.
Thank you, Dr. Pratap. So very good morning, everyone. Yes, it is one of the very popular trials, the verified trial. This was a trial which actually was the initiator or was the thought-provoking that we should always begin with a dual therapy and do not begin with monotherapy. So that was one of the ice-breaking trial here. And this trial was done with a gliptin, and a combination of gliptin plus metformin was given. And it was found that not only the primary OHA failure, but even the secondary OHA failure was delayed. So this was the trial where even the de novo, the drug naive patients were selected. And when even the HbA1c was as low as say 7, it was recommended to begin with a dual therapy and do not begin with monotherapy, do not proceed with the anticipatory therapy and stepwise therapy, rather hit hard, hit early. So verified trial gave us the data that you begin with a dual therapy, a combination of metformin with a gliptin, and that was the trial as shown by Dr. David Strain also, that trial gave us the data that if you begin with a dual therapy, not only the primary OHA failure is delayed, but even your secondary treatment failure or secondary OHA failure is delayed, your complication setting is delayed. So if you start with a dual therapy and you achieve a good glycemic control and maintain that good glycemic control for a pretty long time, especially in the early years, that gives you the legacy effect or the good metabolic effect. And that is why you are recommending most of your patients that we begin with a dual therapy.
Okay. So I think this is, as Dr. David Strain confirmed, that we should focus on pathophysiology, and that's why we require combination therapy targeting multiple pathophysiological defects, and this is one of the combination which can target many of the pathophysiological defects which are there in type 2 diabetes. So now I will focus on special population. So let's hear about what about DPP-4 inhibitors, particularly in CKD and elderly. Dr. Manish Gupta.
Sir, good question. Sir, as shown by trials and this meta-analysis study again, so in elderly population and in CKD, DPP-4 stood out, and it was a safe molecule to use without any major side effects when compared to the other OADs. And in fact, it did better by 0.5% HbA1c reduction across the board. That's the study I'm talking about, the meta-analysis with the RCTs. And they found out that it was very safe. The only caution being that we have to lower the doses across the gliptins except linagliptin. And across the board, you can use them. In hepatic conditions, you'll have to be careful with vildagliptins and, of course, Saxa also. So, linagliptin was safe across the board in whether you are dealing with the renal impairment or with hepatic impairment. So, I think they did well across the board. So it's safe to use, but you have to be careful of reducing the doses of which gliptin you're using and be aware in the elderly population. But in summation, it was safe across to be used in the special populations.
Okay. So, any comment, Dr. Meenal?
If I can add here, when we talk of elderly population, gliptins are specifically very popular. Number one, they are oral molecules, which is the win-win situation. Then they are weight neutral. And the biggest factor with the geriatric population is that they do not cause hypoglycemia. Specifically, if one of you might object that you must have witnessed hypo some odd some event maybe, but even in that case, those hypos will not be very severe hypos. If at all there is a hypo, it's a very mild hypo, which is manageable with some oral supplementations and just reducing the dose or maybe changing the dose from BD to OD dosing. So that is the biggest advantage when you talk of gliptins in the geriatric population. When you talk of the complications, as you mentioned, CKD or CLD, one very strange fact that has come to my notice, maybe it is happening with you, all of us, our nephro colleagues, they have mistaken the message that Lina is safe to that Lina is favoring CKD or improving CKD. So they are rather recommending Lina to every CKD patient. So the message should go very clear that Lina is, it can be used. It's not that it has to be used. So there's a difference. It does not play any positive role in the case of CKD if the GFR is less than 20. But yes, if the patient is already on Lina, you can continue with Lina. So that one message I really wanted to discuss on this platform.
I think all gliptins we can use in CKD, but only Lina where you don't require any dose modification. Others you need to modify dose as per eGFR. Otherwise you can safely continue even up to end-stage renal disease. And there is data with some of the gliptins on dialysis and in post-transplant also you can use gliptins. So we all know in our country the cluster classification shows that around 1/4 of individuals, even who are diagnosed to have type 2 diabetes, they are having severe insulin deficiency and they fall in this category of LADA. So can we use, is there any special advantage of DPP-4 inhibitors in LADA, Dr. Meenal?
So, Dr. Pratap, if I attempt this question like this, that to document whether the patient coming to us is a case of LADA, first of all, is a challenge. So what we do is we are treating them as insulinopenic population, type 2 with insulinopenia, or type 2 who are very strongly responding to insulins and resistant to OHAs, or OHAs are not working. If we go for C-peptide, maybe the C-peptide values are very, very low. So if that population we are talking of, so we have, before you initiate them on insulin, there are certain molecules which one of them is DPP-4 also, but yes, you always give them any insulin sensitizer, that is you can begin with metformin or thiazolidine diones. In that case, you may even use a gliptin and you can even use a GLP-1 RA if they are obese. But then to document as LADA, you need to have the antibody positivity to document that yes, this particular patient is a late onset type 1 diabetes or a late onset autoimmune diabetes for that matter. So if you have documented in that population, some of the studies have shown that if you are using incretins, especially because they are thin population, you will not like to use a GLP-1 RA, you would prefer beginning with a DPP-4 inhibitor, and DPP-4 inhibitors with their role to preserve beta cell have been found to delay the onset of insulin for some time, but eventually if they fail from DPP-4 inhibitor, rather we always prefer counseling them to begin with a basal bolus regime. But if the basal bolus regime or insulin is not something which is easily acceptable to them, then of course you can begin with a DPP-4 inhibitor in combination with metformin or in combination with SGLT2I or even in combination with thiazolidine diones. But again with a very word of caution that this is going to buy a very short time, because insulinopenic patient will ultimately require insulin and they will be switched over to basal bolus regime. Maybe in combination with basal bolus, you may still continue. These are the OHAs which you may continue, but we never recommend a sulfonylurea, and we can use with basal bolus a gliptin.
So there is some data to support that gliptin, they preserve C-peptide, particularly in people who are having LADA. So you can use them early in the course of the disease. So we all know that apart from combination with metformin, DPP-4 SGLT2 combination is very much widely used in our country. So I would like to ask Dr. J.K. Sharma, what are the advantages of combination of DPP-4 with SGLT2 inhibitors?
Thank you, Dr. Pratap. We all know that the SGLT2 inhibitors, the one single side effect which we all observe in a good number of patients is the genital infections. And we have to educate, we have to train our patient, we have to tell them about these particular infections. And in certain cases, we have to even withdraw the drug also. But if we have a combination of SGLT2 inhibitor with the DPP4 inhibitors, the chances, the incidences of the genital infections, that also goes down. And if you can see here in this meta-analysis from the various studies, it has been seen that the combination of SGLT2 inhibitor with DPP4 inhibitor is always preferred as compared to SGLT2 inhibitor alone. This is number one. And the second is that even the control of diabetes is also better in that case. So we should try, if there is no contraindication, that we use the combination of SGLT2 inhibitor and the DPP4 inhibitors. Possibly the mechanism may be that this enzyme inhibition is also at the level of the microorganisms causing the genital infections.
Okay.
Sir,
So-
if you allow me,
Yes.
I would really like to ask a question with all my seniors sitting in the house and maybe yourself. Is it really that combining, have you really in your clinical experience witnessed a decrease genitourinary infections? Because I find even the combination, with the combination also patients do come back with a lot of genitourinary infections, specifically the women population is more prone to genitourinary infections. And even if I use a combination, there is, the same challenge remains.
So I think the randomized control trial meta-analysis clearly shows that, and I think the real-world data which is being
RWE.
generated from India, the Genius study which is still under publication, it also says the same thing.
But
Where-
important thing is the patient education.
Patient education.
That is very, very important, whether we use it in combination or we use SGLT2 inhibitors alone. So if we train our patients, if we educate our patients, especially the female population, then it becomes very easy. Otherwise, the females, they think that there is some problem related to the gynecological department and they keep on going to the gynecologist. And if not now, earlier days, even our gynae colleagues, they were also, I will not blame them, but because of the overwork and everything, they used to treat these patients, and after about a month or so, patient not coming to the physician or the diabetologist, and when they come back, that this was the problem, and she has been going to the gynecologist for good number of weeks, and the moment you stop the drug, the things are under control. So we have to give a good education to our patient. In every follow-up visit also, we have to ask them, is there any problem related to this?
So you have to be proactive as far as asking about this genital
Yes.
infection. and
Another
other
thing that Dr. J.K. Sharma rightly said, which is not a clinical scenario that is very common, that withdrawal of the drug is important. You treat UTI, you treat the genital infections, but at the same time also withdraw the culprit. Because patients, most of the urologists, because sometimes the patient does not come back to us.
Yes.
They go to a urologist with urethral infections and they do not withdraw the culprit molecule, they just go on treating the UTI. So that is again a very important thing to consider, that you have to withdraw the molecule.
So counseling of patients is very important. You have to tell them to report back if they are developing any kind of genitourinary infection. This drug needs to be stopped.
And then it can be
And-
reintroduced.
Yeah.
And then again, if there's a repeat UTI,
Yeah, then you have to
then
be
please
cautious.
stop
Then,
it then,
then,
yeah.
then better not to use these molecules. So this meta-analysis clearly says that when SGLT2 are combined with or added to DPP4, there is a marked glucose lowering effect. But if the patient is on DPP4 and then you add SGLT2 inhibitors, there will not be much difference. So last but not the least, can we use DPP4 inhibitors in hospitalized patients? I think there is ample data now. This is one of the studies, CETA hospital study, which was done in USA, multi-center prospective open label RCT in 5 hospitals, where patients who were presenting with type 2 diabetes, admission blood glucose between 140 to 400, on anti-diabetic drugs or insulin less than 0.6 units per kg or less, they were either given sitagliptin with basal insulin or basal bolus insulin regime, and they concluded that you can give DPP4 with basal insulin, the glucose control will be same, hypoglycemia will be same, hospital length of stay, inpatient complications will be all same. So in the settings where, because basal bolus requires lot of involvement of the nursing staff and lot of glucose monitoring. So if that facility is not available, one can use basal insulin with gliptin for the control of mild hyperglycemia in non-critical settings in admitted patients. And the same data is also with linagliptin, that is Lina surgery study, non-cardiac surgery patients. Again, A1C less than 8, admission blood glucose less than 240, not on injectables at home. Lina with basal insulin compared to basal bolus insulin therapy, and the same outcome is there. And based on that, somebody has proposed, the people who are working in the field of in-hospital management of diabetes, they have proposed this guideline that if it is mild hyperglycemia, admission blood glucose less than 200, and patient is not on 2 or less anti-diabetic drugs, insulin naive, one can start with DPP-4 inhibitor for control of glucose in hospital settings, in non-critical care settings, and if required with basal insulin, and then supplemental insulin can be added. So I think we are coming to the final summary slide. So in spite of availability of newer molecules which are having cardiorenal protection, I think we already heard Professor Mohan saying that sulfonylureas, they are still relevant, and the same is there, DPP-4 inhibitors, they are still relevant in today's era in type 2 diabetes management. HbA1c lowering potential is almost equivalent to other agents, and it is larger in a background of modest HbA1c compared with SGLT2 inhibitors, particularly in CKD when SGLT2 inhibitors, they lose their glycemic efficacy. DPP-4 inhibitors can be combined with SGLT2 inhibitors for better glucose control without increasing the risk of hypoglycemia and with weight neutrality. Same way, older individuals, you have to prefer these molecules because of the safety profile and good glycemic efficacy, and we have seen that in LADA they have got some evidence to support that they preserve C-peptide. And in hospital settings, in non-critical care settings, if the patient is having mild hyperglycemia, you can combine gliptin with basal insulin or supplemental correctional bolus insulin for management of hyperglycemia, and you can very well use them with SGLT2 inhibitors for additional glucose lowering as well as for reduction in the side effect of SGLT2 inhibitor, that is genitourinary infections. With that, I end my presentation. Thank you very much to Dr. Makkar sir,
I would like
ESD team and the entire ACCD team for inviting me and panelists. And before I conclude, I will ask for a tip from each of the panelists, and then I will request Professor David Strain also to join and to say that how relevant DPP-4 inhibitors are in today's era in type 2 diabetes management, his views.
Thank you, Dr. Pratap. I would like to say certain things. We are not talking about the saxagliptin and the teneligliptin, because we all have seen that the hospitalization due to heart failure with saxagliptin was increased. The reason behind was different. It was in the patient selection. I am not going in detail about that, number one. Number two, when we come to the efficacy and the safety, efficacy of, if we compare these three, the sitagliptin, vildagliptin and linagliptin, efficacy of sita and vilda are practically at par, but in real world evidences, the vildagliptin is little more efficacious as compared to sita and lina. Third thing is that when we come to the cardiovascular safety trials, we all know that the TICOS trial which came with sitagliptin way back in the year 2008, and regarding the other two, the cardiovascular output trials are not that as compared to the sitagliptin. Regarding the renal and hepatic failure, of course with the hepatic failure, vildagliptin we should not use, rather all the DPP-4 inhibitors should be avoided if the liver failure stage is advanced stage, and in renal failure also up to a certain eGFR only we can use these. When we are using the vilda and the sita, we have to definitely reduce the dose, but lina we may continue it, but only up to a certain eGFR. So you have to decide what is the patient characteristics and which drug to use and monitor properly. Thank you very much.
One quick point on this efficacy, sir. Dr. V. Mohan's paper was also there, that the Asian population has more DPP-4 genes expression.
So they respond better
the
to DPP-4 inhibitors.
Inhibition works comparatively better in the Asian population, has been shown also by many papers, and that's the point, that it should be used
Yes.
much more in our
So
setting.
efficacy is better in Asians as compared to the Western people as per the data.
I mean, it is important to say that most of the regulatory studies that we're talking about were done in Western European, and actually,
Yes.
for that matter, they were done in very affluent Western Europeans. It wasn't even typical run-of-the-mill. As we say, Dr. Mohan has demonstrated increased DPP-4 activity in the Indian Asian population compared to the white European, and that's probably why in the EDGE study, which was vildagliptin, we demonstrated the HbA1c reduction here in India was about, on average, 1.3 to 1.5% compared to in the European population, it was 0.7%. Similar data are now here with sitagliptin. As you say, they've got very, very similar efficacy. The issue about cardiovascular outcome trials is a rather interesting one, because you've got to remember that the cardiovascular outcome trials, the first wave of them, were purely done to keep the FDA happy. They were never actually demonstrated, never aimed to demonstrate cardiovascular benefit. They were aimed to make sure that the FDA's target for cardiovascular non-inferiority was achieved. And that's why TCOS, SAVOR, TIMI, and EXAMINE, for that matter, were all relatively short studies. It's also why vildagliptin didn't even need to do one, because they'd already demonstrated non-inferiority at the point of coming to market. Those studies were never designed to show superiority. If you look at the analyses of either sitagliptin or vildagliptin data when it's used early, they do have a preventative role, but that's subgroup analysis or meta-analysis of existing data. What they don't do is take people who've already got existing disease and help reverse that process. So I think the role for DPP-4 inhibitors is very useful early on, particularly given that they are so relatively cheap these days. Fixed dose combination with the metformin, you're effectively getting one of the tablets for free. And using them early is a very sensible alternative at the outset. But as you rightly say, by the time someone's got heart disease, they've got renal failure, that's the point to think SGLT2s or GLP-1s.
So if we look at the pathophysiological defects that we are targeting,
Yes.
so if we look at the core 8, if we talk of the differenzo 8 octet, if you combine the FDC of metformin, SGLT2I and DPP-4 inhibitor, probably you are covering 7 out of the 8 defects.
Yes.
So 7 out of 8 pathophysiological defects, if you are hitting with one single tablet, which is of course an FDC of metformin, SGLT2I and DPP-4 inhibitors, I think you are doing wonders with no weight gain, no hypoglycemia, no beta cell deterioration, and you are getting a good glycemic control. It's a win-win situation, not a very pricey combination also, so it's an economical combination as if we talk of the Indian population. So economy is there, all win-win benefits are there, so I think it's a good benefit.
Yes. So there is one question, whether we have to start first SGLT2 and then add DPP-4, or first start with DPP-4 and then add SGLT2. I think this is related to HbA1c lowering. That is what the
No,
people
I think
they are
it's
asking.
more concerning the UTI problem, because it was initially claimed that if you prime the system with SGLT2I, with DPP-4 inhibitors and then introduce SGLT2I, the incidence of UTI is less. But the clinical or the real world data did not support that.
Even the
hypothesis.
glycemic efficacy, if you first start DPP-4 metformin or DPP-4 and then add SGLT2, the glycemic lowering will be better as when you start with SGLT2 and then add DPP-4. So first start with DPP-4 metformin and then add SGLT2.
I think it's very dependent on the patient in front of you, and when we have to go back to that, we have to consider what are the parameters that we're trying to do. If someone has any evidence of heart failure, if they've got any evidence of renal impairment, clearly an SGLT2. If they are very, very early in the disease process, DPP-4 becomes better. There are some patients that you might even consider going straight for a GLP-1 based on obesity. There are other patients that would not be able to afford these medications, and for those ones, the sulfonylureas come in. So I think the advantage that we've got today is we've got a whole host of different options available to us, and we can now get to a stage, different options, different patients. Let's make sure we get the right patient for the right drug.
Right. Thank you.
Individualization is the key.
So thank you very much, all the panelists. Thank you, Professor David Strain, for your expert comment, and thank you, everyone. I will hand over to the organizers.
So thank you everyone for an excellent discussion. I'll request the chairpersons to please collect their mementos from outside the hall, and I'll ask Dr. Das sir to please hand over the mementos to the chairpersons. Thank you, ma'am. So moving on to the next session. May I request Dr. Paras Gangwal, Dr. Deepak Gupta, and Dr. V.K. Goel to chair the session. So over to the chairpersons.
Very good afternoon, everyone. It's a great honor to chair this session on diabetes and its multifaceted complications. In this session, we'll have 3 talks by very eminent speakers who are very seasoned for this ACCD 2025. First is Dr. Julia Mader for how to handle diabetic kidney disease. Then second talk on MASLD by Dr. Katrina Conte. And third would be by Dr. Anuj Maheshwari. So let me welcome the first speaker, Dr. Julia Mader. So Dr. Julia is a global authority in diabetes and diabetes technology. Oh,
there has been
Dr.
a change.
Katrina first?
Yeah, no. Actually, Julia left. We swapped talks.
Okay,
so
all
she
right.
gave her talk yesterday, and I'm giving 2 talks in this session
All
this
right.
morning. So
let me welcome Dr. Katrina Conte, who is Professor in Internal Medicine at St. Raphael, Roma. He is Head of Obesity Research in Milan, Italy. She has a fellowship at the Center of Human Nutrition, Washington, under the mentorship of Professor Samuel Klein. And she is PhD in Experimental Medicine way back in 2016. So over to Katrina Conte.
thank you. I'm sorry for this change. So I'm talking now about obesity and insulin resistance in type 1 diabetes. So people with type 1 diabetes are thin, right? Well, this is not true anymore. We have heard yesterday already about obesity, excess weight in people with type 1 diabetes also. And we know now that the prevalence of overweight and obesity in people with type 1 diabetes is very similar to that in the general population. And so in this series, in different age groups, actually up to 30% of people with type 1 diabetes were affected by overweight or obesity. And weight gain is a known complication of intensive type 1 diabetes management with intensive insulin treatment. Particularly, weight gain occurs rapidly in the first year after diagnosis and more slowly after that. And of course, with the increase in intensity in the management of type 1 diabetes, and with excess weight gain, there is also an increase in the prevalence of the metabolic syndrome, which is associated with insulin resistance. And there is also an increase in metabolic dysfunction associated fatty liver disease, which is associated also in this population with several diabetes complications. So it worsens the consequences of diabetes. So what are the drivers and the consequences of obesity and insulin resistance in type 1 diabetes? Several, actually. This is a very complex relationship. So, as I mentioned, insulin-intensive therapy. Of course, we know that insulin is an anabolic hormone, and so it favors weight gain. Other factors are aging, of course, and the duration of type 1 diabetes. There are some hormonal changes, for example, growth hormone resistance, and so an increase in growth hormone levels, which also may lead to increased weight. And another important factor is hypoglycemia defensive snacking. We know that people who are on insulin, particularly people with type 1 diabetes, they are of course afraid of hypoglycemia, and so when they see their blood glucose levels going down, they start eating more in order to prevent hypoglycemia. And of course, the accumulation of excess weight, excess adiposity, resulting in obesity, is associated with, the same complications that occur in every other person with excess weight and excess adiposity. So there is hypertrophy of the adipocytes, shift in the adipose immune cells with a predominance of pro-inflammatory macrophages, and this eventually leads to the secretion of pro-inflammatory cytokines, chemokines, adipokines, and systemic chronic low-grade inflammation, which eventually leads to impaired insulin signaling. But we know that insulin resistance is present at the very beginning, right after the diagnosis. So it's not just the excess weight gain, there are other mechanisms. So these are longitudinal studies carried out with the glucose clamp technique. So this is at the beginning, 2 weeks after the diagnosis, and we can see that glucose, insulin-stimulated glucose disposal during the hyperinsulinemic euglycemic clamp is already reduced 2 weeks after the diagnosis. This means muscle insulin resistance, systemic insulin resistance. Then insulin sensitivity normalizes at 3 months. This is the honeymoon, so there is a tendency to restore insulin sensitivity, but then insulin sensitivity worsens again 6 months, 9 months, 1 year. It's reduced even at very high insulin concentrations. There is a reduction in insulin-stimulated glucose disposal, which means systemic insulin resistance. So what are, beyond excess adiposity, the other mechanisms that lead to insulin resistance? Well, there are many. Of course, genetics, genetic predisposition, lifestyle factors. Again, lifestyle is an important contributor to insulin resistance, gut dysbiosis and chronic hyperglycemia, so glucose toxicity, vascular complications that impair the microcirculation and the insulin delivery to the tissues, excess adipose tissue and adipose tissue dysfunction, increased circulating free fatty acids, of course, adipokine dysregulation, ectopic lipid deposition, which is a consequence of increased free fatty acid circulation, and also systemic inflammation, as I mentioned, and peripheral hyperinsulinemia. And this is something I will just stress two concepts. So during the physiological insulin secretion, most insulin is extracted by the liver. Insulin is delivered by the beta cells in the portal circulation, and there is the extraction of insulin in the liver, so part of it, most of it is metabolized by the liver, and then it enters the systemic circulation. When insulin is delivered subcutaneously, the liver and the pancreas, they don't see this insulin. So there is no hepatic extraction of insulin, and this makes the levels higher, and also the peripheral insulin extraction is lower in type 1 diabetes. And also, since the islets don't see this insulin, there is no negative feedback on glucagon, and so this may contribute to hyperglucagon levels, increased glucagon levels, which also contributes to hyperglycemia and insulin resistance. How can we measure insulin resistance in type 1 diabetes? So can we measure it? Of course, HOMA, IR, and indexes like that are not really reliable when you administer exogenous insulin. The best way of measuring insulin sensitivity is the hyperinsulinemic euglycemic clamp. But this is a very complex technique that requires the patient being for hours in a hospital bed with insulin infusion, glucose infusion, several blood draws. And so it's not something we can use in the clinic. Several indexes have been developed which are quite reliable. So the estimated glucose disposal rate and the search insulin sensitivity score, and these indexes have been validated against the glucose clamp and are very simple because you just need waist circumference and hip circumference, presence of hypertension, and then the A1C values in one case, and A1C and triglycerides for the CIS score. So these are very simple indexes that everybody can calculate to get an idea of what the insulin sensitivity in our patients is. And of course, we should not forget to make a formal diagnosis of obesity, because obesity is a concomitant disease in these patients. So we should also make a formal diagnosis of obesity. And again, waist circumference is very important, and there are different cutoffs from Western populations and people living in this area. And what are the clinical implications of insulin resistance in type 1 diabetes? So type 1 diabetes plus insulin resistance is now called double diabetes and is associated with higher BMI, worse cardiometabolic profile, and microalbuminuria. So we can see here that we have greater A1C values in people with type 1 diabetes and insulin resistance. They have higher insulin requirements and worse lipid profile, greater prevalence of hypertension, microalbuminuria, and of course that's the estimated glucose disposal rate, which is lower. So the lower the estimated glucose disposal rate, the lower the insulin sensitivity. And again, the EGDR, estimated glucose disposal rate, is associated, so the higher insulin sensitivity, so higher values of EGDR are associated with a reduction in the risk of retinopathy and nephropathy. And also here we can see how insulin resistance increases the risk of microvascular complications in type 1 diabetes. So it is important to be aware of this and estimate insulin resistance in these patients. And not just microvascular complications, also macrovascular complications. So better insulin sensitivity, lower risk of developing cardiovascular and any macrovascular complication. And this is true regardless of A1C values. So we can see here that even people with high A1C but high EGDR, so high insulin sensitivity, have lower cardiovascular disease, nephropathy, and retinopathy. So what can we do to manage obesity and insulin resistance in type 1 diabetes? There are diets we can use, of course. Dietary advice is always important. Carbohydrate restriction may help enhancing glycemic control by reducing postprandial glucose excursions, improving time in range, and lowering HbA1c. Although there are conflicting data on other parameters, such as lipid profile and body weight, and there might be adverse effects. So, you know, for example, ketogenic diets are very popular, but those are very, I would say, risky diets. They require experienced dietitians to be managed because they may be associated with a risk, increased risk of hypoglycemia or DKA. And most studies on these diets with low-carb diets are short-term, and there is considerable heterogeneity in these studies. So there is no definite consensus on this. Metformin is another option. It doesn't really improve glucose control, but it helps reducing weight, BMI, and also total insulin requirements. So metformin can be of help in this population. And bariatric surgery is another option for those who meet the BMI criteria. It helps reducing insulin doses and improving metabolic control. But of course, there might be some risks associated with these surgeries, increased risk of hypoglycemia, possibly ketoacidosis, nutrient deficiency, especially with malabsorptive procedure, and of course the complications of surgery that we see with any other patient. So weight management in type 1 diabetes is even more complex than in other patients with obesity. Diet and exercise, of course, have favorable effects, but there is some risk of hypoglycemia, which might influence defensive stacking. And of course, exercise, as I said yesterday, is very, very hard to incorporate in daily life. And weight regain is likely in people who diet, and this is true for all patient categories. Bariatric surgery, of course, is very effective in reducing weight, but there is a risk of increased hypoglycemia and DKA, and there is not much data about that. And then drugs, of course, may be helpful. Metformin is something we can relatively safely use, and we heard yesterday from Professor Giaccari about the use of the newer medications for the management of people with type 1 diabetes, and these can be, of course, of help, particularly I think GLP-1 receptor agonists for weight management and for cardiorenal protection as SGLT2 inhibitors. So my key take-home messages are obesity and insulin resistance are common in people with type 1 diabetes. We should not forget this. Obesity, glucotoxicity, lipotoxicity, hyperinsulinemia, and low-grade inflammation and lifestyle habits contribute to trigger and perpetuate insulin resistance in type 1 diabetes. And so some of these factors are modifiable, and we should act on them. Insulin resistance in type 1 diabetes can be estimated with surrogate indexes such as the EGDR, and insulin resistance increases the risk of micro and macrovascular complications independent of glycemic control, and this is also important to remember. Weight management is critical and should be multi-component, so we can use diets and pharmaceutical agents, and when indicated, bariatric surgery. But, of course, all these strategies require some caution and experienced healthcare professionals. And treating obesity and type 1 and insulin resistance in type 1 diabetes is as important as glycemic control to reduce long-term cardiometabolic risk. And with this, I thank you for your attention.
Thank you, Dr. Katrina. I think you will continue with your second talk, that is MASLD, silent driver of cardiovascular risk. As you know, it is being taught in our UG days that liver is the window to heart, and it's easy to detect fatty liver, a marker of insulin resistance, and these patients are at higher risk for cardiovascular disease. And Dr. Katrina will deliberate further on this topic.
Thank you. Hello again. So I have a question for all of you. If the liver of someone with obesity had a voice, what would that liver be telling you? Yeah, save me, help. It will ask for help, of course. Of course. And actually, we don't really listen to that, SOS that the liver is launching, because MASLD, metabolic dysfunction associated steatotic liver disease, is a silent epidemic. We don't really think liver when we see our patients with obesity or type 2 diabetes. So what it is, first of all, steatotic liver disease is a term that, well, it means fat in the liver. And of course, there are several potential causes of an increase of fat in the liver. We will focus today on metabolic dysfunction associated steatotic liver disease. This is the new nomenclature. So it's hepatic steatosis, fat in the liver, more than 5% of the weight of the liver, which is determined either by imaging or histology. Alcohol consumption should be low, okay, so should be not a contributing factor to increased fat in the liver, and there should be at least one of the metabolic criteria, which are pretty much the same for that we use for the diagnosis of the metabolic syndrome, so overweight or obesity, prediabetes or diabetes, hypertension, dyslipidemia, and with low HDL cholesterol. There are also other entities, like a new entity that has been recently defined is METALD, which is a mix of alcoholic liver disease and metabolic liver disease, and depending on the intake of alcohol, there might be a predominant alcohol-dependent component or a predominant metabolic component. And then there are other etiologies of fatty liver, which are more specific, and I will not talk about today. So we will focus on MUSCLE-D, which is an umbrella term that encompasses several aspects of this condition, spanning from isolated steatosis, which is more than 5% of fat in hepatocytes, so it's just a simple fatty liver, and MASH, which is steatohepatitis, which encompasses steatosis, ballooning, inflammation, and also fibrosis. And then up to 25% of these patients go on to develop liver cirrhosis with diffuse fibrosis and severe dysfunction. And in some of them, up to 7% will develop hepatocellular carcinoma. And MUSCLE is becoming a major cause of liver transplantation because it is very, very common. So this is the global prevalence of MUSCLE-D. It's really high. Like 1/3 of the population in this region has fatty liver disease, which is really impressive. And I also found more specific data. So these are data, the prevalence in information technology employees in India. This is a major industry in India, so there are many people who do this kind of job, and it's a sedentary job with very long working hours. So the prevalence here in this population was super high, like 50% of people in the age group 30 to 40, so young people, were diagnosed with fatty liver disease, mainly males, okay? And older people had a lower prevalence, also higher in males. And the degree of the proportion, I mean, the amount of fat was really high. So the proportion of people with grade 2 or grade 3 MUSCLE-D, which is the proportion of fat. This is grade 3 is more than 2/3 of the liver are full of fat, was really, really high. And this is another study in people with type 2 diabetes in India. And here the prevalence of liver steatosis was 76%. And almost 1/3 of them had liver fibrosis. And of course, steatosis was more severe and fibrosis was more prevalent in people with obesity. And MUSCLE-D is underdiagnosed and underestimated in clinical practice. These are estimates from Europe, data from Europe, and it's been estimated that the prevalence that is reported in studies is 1/6, and maybe even more likely only 1/12 of the real estimates, okay? And the incidence that is reported is 10 times lower than what is expected. And this means that doctors don't screen, we don't screen for fatty liver. What is the pathophysiology of MUSCLE? I will just briefly touch upon this. It is very much related to overnutrition and increased adiposity. So increased adiposity, as I mentioned in the previous lecture, leads to systemic low-grade inflammation, insulin resistance in the adipose tissue, which increases lipolysis and the amount of circulating fatty acids in the bloodstream. And this overloads the liver, which needs to handle this amount of free fatty acids, and it tries to do that by using fatty acid beta oxidation, but this, of course, also leads to the production of reactive oxygen species, and the liver cannot oxidize all of these lipids, and some are converted into lipotoxic intermediates, and some are accumulate in the liver, and this leads to inflammation in the liver and fibrosis, oxidative stress, insulin resistance in the liver, which means increased hepatic glucose production and increased de novo lipogenesis, so the liver also makes up fat. And this has detrimental systemic consequences. Okay, and weight loss until recently was the only tool we had to manage muscle D, and a weight loss of 10% results in improvement in the amount of fat in the liver, and it reduces hepatic insulin resistance, improves the adipokines, improves insulin resistance, of course leads to weight loss and improvement in insulin resistance in muscle, and also improved insulin secretion. And muscle is not alone, as it's been mentioned, it's associated with not only cardiovascular disease, but also cancer, pancreatic cancer, breast cancer, stomach, colorectal cancer, and atherosclerosis, stroke, myocardial infarction, so several cardiovascular consequences. Cardiovascular risk, it's been estimated that muscle is associated with an increase of up to 80% in cardiovascular risk, both fatal and non-fatal cardiovascular events. And what is really worrisome is that this is even higher in younger people. So this is a study in people from Korea who were aged 20 to 39 years, and this is the exact age of those IT employees. The median age in that study was 38 years, okay? So younger people are at increased risk. It doesn't matter if they are young, they are at high cardiovascular risk. And muscle D and cardiovascular disease have common drivers, common pathogenic mechanisms, systemic inflammation, insulin resistance, dyslipidemia. So we should treat aggressively, because we have seen how muscle D worsens all of these aspects, okay? So what do the guidelines say? There are the new European guidelines that were issued last year. So first step is lifestyle management. I'm sorry here I have to say that, but I'm just joking, of course. So weight loss is super important, as I mentioned, because it can lead to improvements in steatosis and even in inflammation in the liver and even in the amount of fibrosis. So diet quality is important, physical activity is also important, and weight reduction is important even in people with without excess weight. Okay, there are a small amount of people who develop muscle D even with a normal BMI, and weight loss is also important even in that people. And then as for drug management, until like a week ago, there was only one drug approved for the management of MASH, which is resmetirom, which is approved in the United States, and I believe it's in the process of being approved and used here in India. In Europe, it's not yet approved. And as we will see, like last week, also semaglutide was approved by the FDA in the United States for the treatment of MASH. And then the guidelines tell us what to do in people who have type 2 diabetes. They suggest using GLP-1 receptor agonists, SGLT2 inhibitors, metformin when renal function allows it, and in people with decompensated cirrhosis, we should use insulin. Of course, aggressive management of atherosclerotic dyslipidemia with statins is also recommended, and for obesity, GLP-1 receptor agonists and bariatric surgery when indicated, okay? So, incretin therapy in muscle D has the beneficial effects of weight loss, and probably even more, because we know these drugs have pleiotropic effects, and they also have cardiovascular, renal. We have heard a lot about that, and so these are the drugs we should use for weight management in these patients. But as I mentioned, semaglutide has recently received an indication for the treatment of MASH in people in the United States because of the ESSENCE trial, which showed resolution of MASH without worsening of liver fibrosis in more than 60% of patients, and reduction in liver fibrosis without worsening of inflammation in a third of patients treated with semaglutide. So far, this is the only drug besides resmetirom that has received an approval for an indication for the treatment of MASH. And treatment with GLP-1 receptor agonists is also associated with reduction in cardiovascular events and portal hypertension events in people with muscle D. So this is also important to remember. And now I have another question. How many of you routinely screen for muscle D in patients with obesity or type 2 diabetes? So a good number, but not all of you. And it's a shame because, again, it's an important disease. You know, many people just think, well, it's just fatty liver, it's a benign condition. It is not. We have seen how much it can lead to increases in cardiovascular risk. And it's super simple to screen for muscle. We should just calculate the FIB4, which is very easy. We just need age, AST, platelet count, and ALT. So transaminases, platelets, and age. It's super easy to calculate, and based on the values, we should either refer to a pathologist when it's above 2.67, or just reassess for every 1 or 3 years if it's low, and when it's intermediate, we should intensify the management of comorbidities and then reassess at 1 year, and depending on what the value are, then proceed with this algorithm. And what's holding us back from screening for muscle D? So lack of knowledge, and again, it's our responsibility to be aware of the consequences of muscle D. And sometimes we prioritize other medical issues because we believe, again, it's not that bad. I mean, it's not a severe condition. There is lack of concern about the consequences of muscle D. We are also sometimes afraid of overburdening patients with information and medications, lack of time, and sometimes also the lack of access to tests like the FibroScan, for example, for screening for fibrosis. So my key take-home messages here are: metabolic dysfunction-associated liver disease is prevalent, steatotic liver disease is prevalent, but often underdiagnosed. It is associated with fatal and non-fatal cardiovascular events, but also chronic kidney disease, some types of cancer. We should think liver when we manage people with obesity and diabetes, and the new incretin drugs really are game changers because they shouldn't be used just for weight and glucose control, glycemic control. They have several beneficial effects, including resolution of steatohepatitis and fibrosis in these patients, and we should be aware and advocate for better care and access. And with this, I thank you for your attention.
Thank you, Dr. Katrina, for a very excellent talk on MASLD. When we talk of diabetes, we talk of diabetic complications, and a comparatively lesser talked about complication of diabetes, that is a musculoskeletal complication of diabetes, will be taken up by Dr. Anuj Maheshwari. I invite Dr. Anuj Maheshwari. He has been awarded many awards, and he has many orations to his name. He has more than 100 publications and presentations in diabetes, hypertension, and its complication in index journals. He is the past Vice President of National RSDI and is Governor of American College of Physicians, and at present he is the President-elect of National RSDI. Over to Dr. Maheshwari, please.
Also, please post your questions on the app or pass your questions on the paper.
on musculoskeletal complications of diabetes.
Thank you. Thank you, chairpersons, for the kind introduction. Thank you, Dr. Makkar and team ACCD for this invitation. So I shall be talking next 15 minutes about the musculoskeletal complications in diabetes, which is now becoming very common. As far as what I understand, there are three main important reasons of increasing prevalence of musculoskeletal complications in diabetes currently. One is people are living longer. We could increase the life expectancy in our population because of what all the problems related to frailty, related to musculoskeletal, which are usually supposed to be in the older age, they have started becoming more and more visible. Second, we have started using some medications which are bringing up these problems little earlier. I shall be talking in my presentations about that medications also, which have been very much popular for various reasons, what has been just discussed, but they are also increasing the frailty, especially the people, those who are carrying the normal weight, especially the people, those who are of the older age. So these are the two important issues. And third is that rising prevalence of the diabetes itself rising, its complication, and obviously all complications are visible more, including the musculoskeletal too. The across India studies consistently report a high prevalence of musculoskeletal disorder among people with diabetes ranging from 35% to 64%. In North India, there has been a study which has reported even higher prevalence of 50.7% with osteoarthritis 20.3% as the leading condition. Another study which has shown that musculoskeletal disorder, 44.8% of the cases with osteoarthritis 22% and frozen shoulder 12.2%. A study in the South reported the highest prevalence at 64% with limited joint mobility syndrome affecting 28% of the participants. This is one more important study which has shown the musculoskeletal disorder in 35.5% in patients with diabetes. Most common is the osteoarthritis knee, constituting 14.8%, and showed that longer diabetes duration and higher HbA1c markedly increases the risk. Individuals, those who are having the diabetes for more than 10 years, had a 2.62 times higher odds of the musculoskeletal problems than those with less than 10 years. Individuals, those who are having the higher HbA1c, more than 6.5%, had a 3.4 times higher odds of musculoskeletal problem than those with HbA1c less than 5.7%. So if we look on the overview, musculoskeletal problems can be spreaded out in a way that some of the problems of the soft tissue like limited joint mobility, carpal tunnel syndrome, stenosing tenosynovitis, which is also known as the trigger finger, Dupuytren's contracture, adhesive capsulitis. Joint-related problems like diabetic neuroarthropathy, gouty arthritis, bones, osteoporosis, fracture, diffuse idiopathic skeletal hyperostosis, and muscular problem, diabetic amyotrophy, which is very commonly known as sarcopenia, and diabetes muscle infarction like myonecrosis. Risk factors, of course, the female gender on the higher risk of that, followed by those who are of the higher age, especially more than 50 years of the age, obesity, and people, those who are having the nephropathy. If we look for the pathophysiology, advanced glycation end products are in the cornerstone of this pathophysiology of sarcopenia related to the musculoskeletal disorder, including sarcopenia also. Non-enzymatic products of the reaction between glucose and sugar derivatives and protein lipids and their formation, accumulation, building up in the tissues, including bone, cartilage, muscle, tendon, ligaments, nerves, and activating these receptors for the advanced glycemic end products, inducing the inflammation, increases the problem more and more. And ultimately, with the fibrosis, we see the structural changes adversely affecting the biomechanical structure by causing forming and collagen cross-linkage. These mechanisms are responsible for various diabetes-related conditions, including osteoporosis, osteoarthritis, sarcopenia, tendinopathy, neuropathy, and joint stiffness. So as we understand very well, age-induced inflammation, meta-inflammation, these are the important reasons which are underlying these musculoskeletal complications. Adipose tissue function as an endocrine organ, producing biologically active molecules like adipokines that interacts with the endothelial cells and macrophages, resulting in chronic low-intensity systemic inflammation. If we look for the clinical consideration, fibroproliferative and microvascular complications are linked with each other, and most of the time we see that latter should be examined if the former are present. Means if the fibroproliferative is there, then obviously the microvascular complication must be there. Strict glycemic control prevent the onset of the complications and or delay the progression but not completely reverse them. Initial conservative treatment seeks to control pain and limitations of the motion. Surgery is possible if a response is lacking or when irreversible deformity develops. So currently there is no treatment that reverses the pathological disease progression, emphasizing the importance of prevention. Like diabetic ketoarthropathy is the only diabetes-specific musculoskeletal disorder with a prevalence of 3.5 to 58%. Such a huge prevalence window is there with diabetes. It is more common in type 1 patient. Skin thickening, flexion contractures of the finger, easily recognized by the prayer sign, finger rigidity, skin thickening can be explicit. Many of the times could be differentiated with the scleroderma, and significantly it limits the hand functions and aggravated the polyneuropathy. You can identify them very nicely and very easily by the prayer sign as well as the tabletop signs. Dupuytren's contracture and trigger fingers are some examples which are more common in diabetic females, Dupuytren's contracture, while trigger fingers are also common in diabetic females, may appear on both hands and multiple phalanges, scar nodules or palms, and results in flexion contracture due to the shortening of the palmar fascia, further deteriorates the hand function that very commonly seen in Dupuytren's contractures. On the other hand, the trigger finger is characterized by the painful catching or locking during the finger movement, results from thickening of the tendon sheath. Carpal tunnel syndrome in diabetes affects 8.8 to 29% of the diabetic patient compared to the 2% in the general population. So you can understand the huge variation which is coming up in the diabetic patient, which is more than 4 times and sometimes more than 10 times as compared to the general population is there. So a lot of diagnostic challenges remains with this. Difficult to differentiate from polyneuropathy. Polyneuropathy presents with glove-like paresthesia, and clinically we can examine through the phalanx test, renal sign, electroneurography, ENG can be the beneficial. Treatment could be surgical. Polyneuropathy requires pharmacotherapy. Both conditions may coexist in diabetic patient. Adhesive capsulitis of the shoulders. Again, it is very commonly seen in our day-to-day population, commonly what we call it as a frozen shoulder. It has a higher prevalence among patients with diabetes, ranging 20 to 40% as compared to the 3 to 5% in the general population. So again, you can say 10 times higher prevalence in the patient, those who are having diabetes. More common in females, often bilateral. Periarticular soft tissues gets inflamed, often provoked by minor trauma and overexertion. Clinically presents at the glenohumeral pain, reduces the range of the motion. Night pain is disturbing. Most of the time it is not allowing to sleep properly. Shoulder immobilization is there, leads to the frozen shoulder. Adhesive capsulitis of the shoulder, like again is a common entity. Most cases of this adhesive capsulitis resolve over the time. Physiotherapy and oral analgesics may accelerate the symptom relief. Local corticosteroid injections and hydrodilation are useful in many of the patients. Specialized therapy could be done by the physical therapy focusing on range of motion exercises. Diabetes evidence more severe symptoms than general populations and require early and frequent intensive management. Of course, surgical intervention helps sometimes. Scleroderma adultorum of Buschke. Buschke type scleroderma is a scleroderma-like disease presented in diabetic patients, often misdiagnosed despite being detectable by simple palpation. Key features are firm, non-pitting, edema commonly developing in the neck, spreads to the shoulders and back. Progressive form may link may limit the range of the motion in shoulders, associated with higher prevalence of the dyslipidemia, stroke, and venous thromboembolic events. Diabetic amyotrophy, which is also very commonly seen nowadays as a diabetic sarcopenia. Diabetic amyotrophy, also known as the diabetic lumbosacral radiculoplexus neuropathy, is primarily associated with type 2 diabetes, likely due to an immune-mediated inflammatory disorder leading to ischemic neuropathy. And differential diagnosis must be ruled out spinal nerve compression, tumors, hemorrhage in the pelvis, and diabetic muscle inflammation. This neuroarthropathy, which is again very commonly, and we all understand it very well since from our MD days, Charcot arthropathy. Charcot arthropathy is having the prevalence ranging 0.1 to 7.5% in diabetic patient, and when it is combined with the neuropathy, we can see 29 to 35%. Its prevalence rises dramatically in those who are having the diabetic peripheral neuropathy. It affects the foot and ankle joint. Symptoms include painless joint swelling, warmth when touched, instability and deformity is there. Physician should suspect diabetic neuropathy when a unilateral warmth, swelling and edema develop in a patient with diabetes of long duration and neuropathy. Gouty arthritis, it is again an inflammatory form of the arthritis characterized by the deposition of the mean monosodium urate crystals in the joints due to hyperuricemia. Gout and diabetes interact in that each condition increases the incidence of other, reflecting the correlation between hyperuricemia and insulin resistance. Osteoporosis and fracture risk. Osteoporosis is a skeletal disorder characterized by the compromised bone strength due to decreased bone mass and microarchitectural damage, which increases the risk of fractures. I think you all understand. What is the incidence in the type 1 and type 2 diabetes? Bone mineral density decreases in type 1 patients. The relative risk of the fracture in young and middle-aged adults with type 1 diabetes is 1.88, means ranging between 1.52 to 2.32. Type 2 diabetes, again the BMD increases or normal it remains in the type 2 patient, yet the relative risk for any fracture was 1.31 higher. This paradox makes the risk of assessment challenging. Large community-based observational studies showed that a fracture risk was 24% to 63% higher in patients with poor glycemic control compared to those with low hemoglobin HbA1c. Relative risk for the hip fracture in patients who were diabetic for more than 10 years was 1.19. Let's talk about the medications. The medications which are being used very commonly nowadays having multiple benefits, but they are known to increase the medication and they are known to increase the fracture risk, like thiazolidine-dione. SGLT2 inhibitor. In the CANVAS study, the canagliflozin caused hip bone loss and increased hip fracture risk. However, the cadence that showed no increased fracture risk, dapagliflozin and empagliflozin did not increase fracture incidence in other studies. Conversely, the incidence of fractures did not increase in the cadence trial. Dapagliflozin and empagliflozin did not increase fracture incidence, but empagliflozin 3.9% and 3.8% as compared to the placebo and empagliflozin groups respectively. If we talk about the DISH, which is again commonly seen associated with the type 2 diabetes, it is ossification of the anthesis primarily affecting the anterior longitudinal ligament of the spine, must be differentiated from spondylosis, ankylosing spondylitis, and other seronegative inflammatory spine disease. Diabetic foot, you all know about the sensory neuropathy, bone joint abnormalities, vascular disease, immune dysfunction. Osteomyelitis is again commonly seen with the diabetes patient. Osteoarthritis and diabetes is having very good connection and togetherness. Osteoarthritis and type 2 diabetes frequently coincide among the elderly individual. Let's come over to the early detection. How can it be really done? Because it is the only key. Treatment is never very satisfying, and most of the time treatment does not give a good relief also. Prevention is the key. We should go for the regular screening, proper diet, weight management, physical therapy, glycemic control, pain and inflammation reduction through the NSAID or corticosteroid as and when it is needed. Multidisciplinary approach is included. So conclusion and future direction. It is important to consider the clinical characteristics, diagnosis, and treatment of the musculoskeletal complications when comprehensively managing diabetes. Early evaluation and management of the musculoskeletal problems in patients with diabetes reduces pain, improves quality of life, and minimizes morbidity and mortality. Development of the specific guidelines for managing musculoskeletal complications in diabetes is needed. Improved risk assessment tools for early identification of the high-risk patients are also to be developed and must be available for the application in the treatment and diagnosis. Thank you very much for your kind listening.
Excellent talk by Dr. Anuj sir. I think we need to stand up. We decided in the morning that after every session, speaker has to be greeted by a standing ovation. So thank you everybody for that. So I think we had two excellent sessions in which we have moved from numbers and diabetes management to the organs. That protecting organ is very important. And these two organs which have been covered by both our speakers, the liver and the skeletal and bone health, are often not taken well care. So I'll request both my speakers to be here on the dais to answer the audience questions and queries. I think we'll need to invite direct questions from the audience from the floor because we don't have anything on the app or so any questions from the audience? How is it possible that the bone and the liver do not invite any question on diabetes? So, yeah. I can see you, sir, please.
That fatty stage, we diagnose the fatty liver, it should be 5%, is minimum less than 5%, then 5%, then more than 10% and so percent. So this criteria is based upon the histopathology or what? How we diagnose 5%, 10%, 15%, 20%?
Diagnosis. So the only, let's say, definitive diagnosis of muscle D and fibrosis is by biopsy. But of course, it cannot be performed in every single patient. It has some risks associated with the procedure, so they do it in studies, but they are tending to abandon that because also with MRI now and MRS, you can estimate the content of fat in the liver and also the fibrosis. So we are moving forward, non-invasive diagnostic tools for muscle D. The other thing is, of course, ultrasound that can estimate. Is not maybe the most precise tool for that, but that's what we have. So, and the fibroscan for the estimation of fibrosis, so you can stage fibrosis and steatosis by the fibroscan. So we have these are the tools we should use to diagnose and stage muscle D.
So, since I have been advised not to take audience questions directly, people can pass on their questions on a paper, only then I'll ask, or you put the questions on the app. So till that time, I have few questions with Dr. Katrina. Regarding your first session on insulin resistance in type 1 diabetes, so what other strategies do we have? Do we use pioglitazone, metformin or SGLT2 to take care of insulin resistance in type 1?
So metformin can be used, and it has some effect on the reduction of insulin requirements. So it acts on weight, it reduces weight, and it reduces insulin requirements. So it improves somehow insulin sensitivity. And SGLT2 inhibitors, they are not indicated for the treatment of type 1 diabetes, but as Professor Jacari mentioned yesterday, they have cardiovascular and renal benefits. So, I mean, I believe we could use them with those indications, and there are going to be studies, more and more studies for this population. And I definitely use GLP-1 receptor agonists in people with type 1 diabetes with the indication for obesity management, because this is, I would say, a comorbidity of type 1 diabetes. They have type 1 diabetes and excess weight, and with an indication for the management of excess weight, I think we can definitely use GLP-1 receptor agonists, which have benefits on weight, but also, again, cardiovascular benefits and pleiotropic actions on different tissues and organs.
Dr. Maheshwari, there's a question for you. Musculoskeletal system dysfunction, it comes before, they are there before the symptoms appear. Is it too late? So it should be the protocol to take care from the beginning of diabetes. The lifestyle modification should be adopted. Your comments on that?
Yes, you are very correct, and this I have mentioned in my presentation also while I was giving the talk, that prevention is the only thing what we can do if we really wish to have the musculoskeletal disorders to be corrected. Because when you go for the treatment, then it's no treatment is 100% satisfactory. And surgical intervention also may not give you the relief which may last for a very long time. The lifestyle modification, weight reduction is definitely the key, but whenever you do it with the help of medication, then it also starts the muscle loss with you with a certain level of the medication, as I discussed, pioglitazone, like SGLT2 inhibitor. Although a lot of work is going on, we cannot say surely 100% that SGLT2 inhibitor is giving rise to the sarcopenia or it is causing the muscle loss. But there could be a lot of things with, like people have stopped their diet. Our diet is very less in protein content. People are usually reducing the diet overall, and they also reduce the protein content of their diet also. Continuously taking these medications which are reducing their weight, reducing their muscle mass most of the time, then it is clearly creating a big problem with more rise in the musculoskeletal complications.
Thank you.
Next question is for Dr. Katrina by Dr. D.K. Gupta. He is asking the indication of pioglitazone in diabetes and MASLD dyslipidemia.
Pardon me?
Role of pioglitazone in diabetes with MASLD and dyslipidemia.
Yeah, so pioglitazone may be used. There is no specific indication, but yeah, of course, it can be used. The problem with pioglitazone is always weight gain, of course, which is most water retention. So it should be used with caution in patients who have a risk of heart failure, for example. So there are some categories we should maybe pay more attention.
So if patient has no heart failure, then pioglitazone is effective in MASLD with diabetes?
For muscle, yeah, it can be used, but still, I mean, the newer, so it's good. It can be used, and until recently, it was one of the few drugs which had shown some benefits. But the guidelines that don't even mention pioglitazone now in the algorithm for type 2 diabetes. They encourage the use of SGLT2 inhibitors and mostly GLP-1 receptor agonists, because these drugs have shown benefits, particularly incretin-based drugs. Semaglutide is the only one that has a phase 3 study, because these results, the Essence study is a phase 3 study, and the results I have shown are preliminary, I would say, intermediate results for MASH and fibrosis, but the study is going on for liver-related outcomes, so development of cirrhosis mainly is going to be the primary outcome. And the other molecules also have favorable results in phase 2 studies. So this is why so far semaglutide is the only one with an approved indication in the United States by the FDA, and this is, I mean, something that happened last week. So pioglitazone may be used, and also it depends on the context. For example, in countries or contexts with limited resources, it could be a good option, a viable option. But again, the drugs with the most solid results are incretin-based drugs.
But most trials with pioglitazone are 45 mg, which we do not use so commonly in our practice. How much is pioglitazone used in your practice and what dose do you use?
So in my practice, I use it at low doses, but since these drugs, like the new drugs, are reimbursed by the government in Italy for diabetes, for type 2 diabetes, we use a lot of these new drugs, so we tend to use less. But pioglitazone is a very good drug. I mean, it's a very effective drug with several benefits. It's beneficial for insulin resistance, so it's a wonderful drug. But we tend, since it's, again, it's reimbursed by the healthcare system in Italy for people with type 2 diabetes, it's maybe easier to use them than in other contexts.
So few quick fires for you, I mean short answers. Statins and MASLD, what is the statin recommendation in MASLD?
Oh,
Do you have any specific guidelines for that or any caution issued for them?
No, unless the patient has liver cirrhosis.
Already
we're over, yeah. So we should just treat to target the, lipids and...
So we can declare the
all
session
right,
closed and we can have an informal discussion.
All right, thank you so much.
We have plenty of questions today with you.
With that, we conclude this session with a big round of applause for both our speakers.
So thank you, chairpersons and speakers. And I'll request the chairpersons to please collect their mementos. And I'll ask Dr. Vinod Kumar, sir, to please hand over the mementos to the chairpersons outside the hall. And we'll break for lunch. And I'll request everybody to be here in time, maybe around 2:10, so that we start in time. So thank you, everyone. So we have plenty of questions. You'll be dealing with them.
It's good when
see, when it's an interactive one, we are always short of time. And actually, it's a very interactive one.
Yeah.
So
The post-lunch session. I would now like to request the chairpersons, Dr. RPS Makkar, Dr. Sushil Chauhan, and Dr. Seema Shahi to please come on the stage and start the proceedings.
Moving on to this session, I would request Dr. Professor Andrea Giacare to please come on the stage. Sir is a very well-known personality. We've been listening to him since yesterday. Over to you, sir.
Hello. So hello again. I will try to show you what's coming in the next future for the treatment of type 2 diabetes. It's really impressive. I mean, I think that we already have many drugs, but really the future is a surprise. And I don't know if they will all come really to the market, but really the things that are coming are impressive. Mostly, they are based on GLP-1. And we know very well that GLP-1 medicines are now the basis of treatment of type 2 diabetes and weight loss. But also, because of the trials, we know that it's able to reduce MACE, cardiovascular events, heart failure, diabetic kidney disease, cardiovascular death, really this sort of association between heart and kidney and cardiometabolic disease. Also, again, there are these benefits established in the various trials, but we already know that something is coming next, the metabolic liver disease, which we learned from Caterina Conte before. We know there is some evidence on peripheral artery disease, and also there is research ongoing on Parkinson and other neurological disease. So really, it's something that is coming through very strongly and even beyond diabetes. Well, in these years, we've seen many new things around GLP-1 medicines. To me, it seems really yesterday when we had the first peptide agonists like liraglutide. Then we had something new with the oral peptides. Like we know that I think we also have here in India semaglutide inside the pills in order to be absorbed. Further, we will have a peptide multi-agonist. We already have Mounjaro, but it's just the first of a long series, and we will see all of them. We know that Lilly and other companies are trying to put on the market oral small activators of the GLP-1 receptors, which are not peptides. And this means they are completely different in terms of absorption and much easier to be taken by the patients. But the future is also antibodies modifying the activity of the receptors, so also of the peptides, cell-based therapy, meaning that we can modify some cells and eventually try to modify their activity in terms of GLP-1. Gene therapy probably will come in the future, and also maybe some gene editing. So really, the future is there. I hope to see all these things, but imagine if you can, for example, really find what is the gene that determines type 2 diabetes and trying to edit that gene with these new medicines that will come in the future. I don't know if they will come, but certainly they are really interesting for our future treatment of type 2 diabetes. Well, it's really complex. We have many receptors. I'm not going through all of them, but you will see GLP-1, GIP, the glucagon, amylin, and so many, and they are widely distributed inside all these organs. You see GLP-1, GIP, and the glucagon, and so on, and so that we can actually really combine these medicines in order to treat not just diabetes, but also obesity. We have cardioprotection, reduction of atherosclerosis, reduction of kidney disease, metabolic liver disease, the problems with the adipose tissue, and also sarcopenia. We'll see that something is also on sarcopenia, and even osteoporosis. So really, it's not just one drug for one disease, but really several drugs to several different diseases. And really, I mean, this is a new medicine that we have to study, a new textbook that we will need to develop to really understand the future of these drugs. And these are trying a combination of these medicines. We already know some of them, tirzepatide, for example, but we know that cagrisema is coming. We already learned something about orforglipron. And what I will show you in the next slide is, are the promising results that these new drugs based on GLP-1 will determine in type 2 diabetes, at least the trials that have been published, because you know that trials are published when the results are there and are positive, but I'm sure that research is really going on in several other peptides other than this that we can see in literature. So probably one of the most interesting will be orforglipron, developed by Lilly. Again, this is a GLP-1 receptor agonist, not different from the others in terms of efficacy, maybe actually a little bit lower than other GLP-1 receptor agonists. But the point is that it's not a peptide. So this means that you not to take in the fasting state, like for example with oral semaglutide, you can take whenever you want, just like metformin or any other drug. And this is makes things much easier for our patients, and you'll see that there is a major reduction in HbA1c from around 8 to 6.4, and also a major reduction in body weight. Again, we don't know how much of this efficacy on HbA1c is due to the body weight, but still, these are GLP-1 receptor agonists, so they also stimulate insulin secretion. This is the first, which probably come very early, but the advantage is no need for fasting. Another one is cagrisema, which has been developed by Novo. We don't have many data on this, but you will see again the HbA1c, which goes really to very good levels. It's around 5 point something. Okay, so really efficacy is high. The point is that within the trial, they also observed the body weight reduction, but the body weight reduction was a little bit less than what's been shown with the tirzepatide. And so because of that, for some strange reason, the value of Novo as a company went down because, I mean, tirzepatide was assumed to be better than this cagrisema. Both are injectables, no major difference. The more body weight loss with the tirzepatide, so Novo went down. But after that, amycretin came out, and you will see that really the amount of body weight which is lost with amycretin, which is a combination of GLP-1 and amylin here, okay, an agonist of both receptors, you will see that the body weight is really largely reduced. So this is a very, very preliminary experiment. So you will see down here, it looks like it's keeps going down. If the trial was continued, it's close to a weight loss of 25%. And the curious thing is that after that, Lilly actions went down and Novo actions went up. So really, it's not just medicine in type 2 diabetes treatment, but also, I mean, the value of these companies, which it changes around the research they are doing. So major weight loss, but we need to further data, especially in type 2 diabetes. Another actor of this scene is glucagon. As diabetologists, we always thought that glucagon is a bad molecule for type 2 diabetes because type 2 diabetes is characterized by increased glucagon, and we think that this glucagon is responsible for an increased hepatic glucose production and therefore for an increased glucose concentration. But still think that glucagon is the hormone for fasting, trying to remove calories from the body in order to be used. So it might be very useful in terms of body weight. And here you will see that, again, there is a major reduction in HbA1c, down really almost 2 points of HbA1c, 2%, and also the body weight goes down very well. And you will see here that the higher dose is much better than semaglutide 1 milligram. So again, the glucagon, which was considered something was bad, probably has a major effect. Since it removes calories mostly from the liver and probably might be useful for the fatty liver or whatever the name you want to give to this disease. So again, it's the future also to give some glucagon to our patients. Another one is the combination of the three, glucagon, GIP, GIP, and GLP-1. And the advantage of this seems to be that there is a major reduction in fat mass, much more than a lean mass. So the concern that we had in terms of losing lean mass probably might be removed or might be less important with retatrutide. There are still other molecules coming out. Another one which I think is very interesting because I'm curious to compare this tirzepatide. This is maritide or maridebart cafraglutide, very strange names. The point difference here is that this is the combination of GLP-1 receptor agonist and a GIP receptor antagonist, not an agonist like tirzepatide. This is an antagonist. So in one way you combine GLP-1 with a GIP agonist, and the other way we combine GLP-1 with a GIP antagonist. And you see that the results are pretty similar in terms of body weight, and the interesting part is also that these drugs can be administered every 4 weeks. You think just 1 month you obtain probably the same result. There's no direct comparison. So, but what is kind of difficult to understand, how comes that if you combine GLP-1 with an GIP agonist and an antagonist, you get the same results? There have been many explanations on this. One of these is that it is thought, especially from Dan Drucker, that when you have the combination of GLP-1 receptor agonist and GIP agonist, there is a reduced appetite, but these two actions actually, they compete, so that some of the activity on the GIP receptor determines a reduction in the GLP-1 receptor agonism. So at the end of it, the reduction in appetite might be lower because of the combination of these two agonisms. So in the case of the antagonist, what happens is that probably with the antagonism, you remove even the endogenous GIP. Because of the removal of the endogenous GIP, the GLP-1 receptor agonist seems to be more active. It is just a theory, but still, I mean, it's trying to explain how comes that an agonist and antagonist get the same results in terms of HbA1c and body weight reduction. Another interesting theory is that when you link to the GLP-1 receptor, there are actually two major streams of action, and one of these is then able to increase the CAMP in a very high level, but the other one actually determines some kind of receptor desensitization. For at the end of it, then the CAMP is not that much increased. So they are trying to develop new GLP-1 receptor agonists which prefer the right part of this picture. So in this case, rather than combine two different peptides, moving more on the G protein action of this agonist, you try to remove this thing and try to enhance the action of the GLP-1 receptor agonist. So again, this is theory. Drugs are coming. One of these is a cnoglutide, developed, I think, by a Chinese company. Again, you will see a major reduction in HbA1c, but this is the only one which has been actually compared with another GLP-1 receptor agonist, this dulaglutide. You will see at least in terms of efficacy in reduction of HbA1c, both are very efficient, but there is no major difference between these two, dulaglutide and the cnoglutide. So at least in terms of type 2 diabetes, maybe this difference of a specific CAMP increase through the GLP-1 receptor agonist may be not that interesting. Other things are coming. For example, this bimagrumab is an antibody blocking activin type 2 receptor, and apparently is able to reduce body weight, but does not reduce the lean mass. So this, again, might be very interesting, especially for our lean diabetic patients, and might be really good. And again, it should be administered every 4 weeks. So again, might be very easy for our patients. So you see, the future is very full of things, but I think again, the most important, interesting thing for diabetes in general, not just type 2 diabetes, is this new insulin. I don't know if it will ever come to the market, but it's very interesting because you will see, it's not animated, but you can see on the right, there are two parts. In one part on the left side here, we have that in this microcycle, glucose, when the glucose concentration is high, determines a divergent part of these two molecules, so that the insulin molecule is very active in stimulating the insulin receptor. But then, if the glucose concentration becomes low, then these two molecules become close, and the insulin agonist does not work anymore. So we have an insulin molecule that works only when hyperglycemia is present. So imagine you inject insulin, but this insulin is active only in presence of hyperglycemia. And really could be a major revolution. This has been tested just, at least in the publication, animals. It worked very nicely. I don't know if it will come to humans, but maybe this might be the future for the treatment of type 2 and also, I think, for type 1 diabetes. So the future treatment of type 2 diabetes is certainly full of innovations, including smart insulins, and I hope really that they will come to the market, but I'm not sure they will all reach actually the market, but certainly a new journey is undoubtedly beginning. Thank you for your attention.
Thank you, sir. Thank you for the wonderful talk. We'll have the question answers by the end of the session. You may send them.
Thank you, Dr. Andrea Giaccari. After that fascinating look into the future of how diabetes is changing, we have the next speaker, Dr. David Strain. And please join me in welcoming Dr. David Strain. He's going to talk about the technological advances in diabetes management, especially the role of digital tools and artificial intelligence. Over to you, Dr. Strain.
Thank you very much, and we are now in the home stretch. I'm glad. Thank you for bearing with us. It's such a privilege to still have so many people in the audience. So over the next 15 minutes or so, I'm going to be talking about AI in healthcare. Now, I'm going to be honest, AI didn't exist when I went to school. Didn't exist when many of us in the room who are of a similar vintage to me went to school. And therefore, I'm actually going to take a little bit of time to talk about what AI actually is. Artificial intelligence quite literally means it's a computer system that tries to mimic human intelligence. And there's many different forms of AI around there. We've all got a bit of AI in our pockets. Many of us will already have AI in our homes. Some of us on our wristwatches. But it is pervading every part of our life. It is already there. Quick show of hands. How many people have a smartphone? Yep. So you've got AI in your pocket. How many of us have got Alexa or Home Hubs or one of those sorts of things? Yep, AI is already in the house. So it's no great surprise that AI is finding its way into healthcare. But this comes with challenges. AI is only as good as the programming that went behind it. Now, many of us are using it already. Things like voice notes. When we're doing when we're creating our notes, we'll have ambient listening. Do we ever think about how that gets to where it is and what data we are sharing in order to get there? So there's lots of different types of AI, and this is something else that comes on. We say AI as if it's one similar thing. It's not. There are lots and lots of different types of AI. There's the machine learning. That is, the computer will learn based on its own outcomes. It will then say, I achieved that outcome if I did this. Therefore, I will do that more often. The problem with this is if you get the outcome wrong, it can potentially reinforce incorrect behavior. We then have our natural language processing. Anytime any one of us says, hey Siri, I love saying that just to see how many of you go, shut up. If you go, hey Siri, or if you talk to Alexa or talk to anything, so that's just using natural language processing. It's the same way that we can dictate notes that go straight from our dictaphone onto the computer in front of us. Again, massively useful. Many of our typing skills is not necessarily the speed it would need to be to do that. But all of the data that you're dictating, you're sharing. Very little of what you say stays private. How often have you had a conversation in the home about potentially needing a new vacuum cleaner, car, whatever, and the next thing, the next advert you see on your phone is for the vacuum cleaner that you've just, how did it know? Quite literally, the processing within your device isn't sufficient to interpret it. So it uploads, puts it through a central processor, and puts it back down. Who's listening to that? We then have computer vision. Now, computer vision is actually something that we have had for quite some time. 2017 was the first active computer vision took place where retinal screening was taken over in the UK by a computer vision process. We now are looking, we upload our photographs, we then run it through the computer. That tells us whether it's got diabetic retinopathy, pre-proliferative retinopathy, and the stages going forward. Now, there's some tremendous potential advantage with this, because that can be programmed into something as simple as a phone camera. You can then wander around Tanzania or one of the other similar countries. For that matter, you can work in rural parts of India where you may not necessarily have access to the high technology screening. And a simple phone camera can do the retinal screening for you. That's been taken one step further. Actually, have a look, if you haven't already, at the Y Health team outside. They are using very simple light going into you, bouncing around inside, reflecting off you to calculate things like your cholesterol. The near future will be having that your tissue perfusion, finding out how good your microcirculation is just from a photograph. We then got things that we're probably more familiar with, the expert systems. What that basically is you've told the computer what to do. If you say, this patient comes along, their HbA1c is this, their age is this, their creatinine is this, I would normally give that patient linagliptin, GLP-1s, SGLT2, whatever it may be. And the expert system learns from you and therefore does things the way that you would want it. Now, that's different from the recommender system, that one down at the bottom. Recommender system is the one where it looks at a big data set, takes that big data set and said, look, we gave these patients with that thyroid function, that HbA1c, that creatinine, other things that you might not even think about. And it will work out what would have happened. Those recommender systems are actually better than we are on most counts, providing it's had the right education going forward. And then there's other simple things. There's robotics. Robotics are everywhere. The entirety of the Saudi Arabian pharmaceutical service has been taken over by robotics. Pharmacists no longer order their own drugs. The computer orders the drugs, then brings it into when it arrives, it sorts it out, it puts it into its little cubicle, and then will take it when you put the order in. Originally, that was met with fear by those pharmacists. Now they love it, because the pharmacists no longer have to spend all of their time doing the very boring admin. They can now spend far more time with the patients. They can spend far more time doing that medicines education that we are dependent on them to do in order to make sure they get their medications to the right person at the right time. Now, AI is transformative. There is absolutely no doubt about that. If you look where it's auditable, it's been able to demonstrate massive changes. It can pick up bank fraud within 0.3 of a second. Before you've got the fourth digit into your PIN number, it can tell you whether that's fraudulent. As a result, banks have saved absolute billions going through all those things. Algorithmic trading makes people an absolute fortune. In e-commerce, when we go on Amazon, around 60% of Amazon purchases are made based on an Amazon AI algorithm looking at your mobile phone activity, looking at your internet searches, looking at your previous purchases, and then it will make recommendations. It is not a coincidence that Amazon recommends just the thing that you are looking for, possibly a tad more expensive version. And Amazon have estimated 60% of their purchase power is bought by those AIs. When it comes to fleet rerouting, we have seen that from DHL and UPS that now use AI algorithms in order to make sure they get their trucks to the location as fast as possible. And all of these things are straightforward in everyday practice. The issue is, how do you audit that in healthcare? Actually, when it comes to it, what are we delivering in healthcare? Because we've spent a lot of time over the last 2 days talking about disease management. We spent a lot of time in the last 2 days talking about what happens when a patient is living with obesity, what happens when a patient is having a heart attack with diabetes, how do we best manage the kidney disease in diabetes, what is the best way to avoid these other complications. We have spent very little time talking about delivering health, more about treating disease. The problem then comes, if you want to implement AI in healthcare, how do you actually know it is delivering what you want it to do? It's the age-old problem. The real benefit of delivering health will never, ever be seen. You will never see the heart attack that you prevented because it was prevented. You will never see the patient who didn't go into dialysis because they didn't go there. You don't see the stroke you prevented. You don't see the dementia you prevented. And when we then want to start auditing how the AI is delivering its service, as we do with every other field of healthcare, how do we go about doing that? So the starting point is seeing where we are now and seeing what this technology actually offers us. And the very first place that I used AI in my own practice was in creating the rota. I work in quite a busy hospital. I have around 21 consultants in my department. I have, on average, 40 resident doctors. Well, that's not true. On average, about 6 resident doctors on site and 40 scattered around doing other things or on nights or on shifts. And then I had all the requests coming in for holidays, annual leave, I'm getting married, I've got this exam and those sorts of things. It was a massive headache. Simple program, put it in, I don't deal with it anymore. The AI is far better than I ever was at creating these rotas. It gives me more time to be sat with patients rather than sat in my office trying to work through all those things. With the added advantage that if people don't get their homework, don't get their annual leave, I say, computer says no. Not my fault, blame the computer. There's so many other places that we've been able to implement this. I get summary care records now. When an entire admission, the computer will go through it and will give me an overview of the last 3 or 4 days in hospital in a single page. And that frees up me to be talking to patients, spend more time chatting with them going forward. So AI is there. It's nice, it's simple, I can see what it's doing because I've asked it to do. The example I gave about visual. Retinal screening is so much easier. And the important thing about retinal screening is the only thing it really needs to be able to do is accurately tell me that something is normal. That's the only thing I'm dependent on it. Because if it's normal, I'm not going to do anything else with it. If it tells me that someone's got retinopathy and they haven't, it doesn't matter. Because I'm going to see them, and I will have a look at them. And if I have a look at them and it said they've got retinopathy and they don't have it, I can reassure them. The false positive rate it's about 1 in 80. The false negative rate, that's the important one, is right down at 1 in 1,000. So only 1,000 people with any disease will ever be told there is nothing wrong with them. It has a real potential to facilitate screening in rural parts of India. This can be built into any smartphone. So places where you might not have the full retinal camera, you can quite easily get them to look into a camera and have a quick look at what's going on in the back of their eyes. We heard yesterday about the bionic pancreas, this automated insulin delivery. The bit that fits with that Julia did touch on, is that the system learns from you. This cannot be handed around because the system itself learns what happened to you when you did this. It will know that in your response, this is most likely to happen. And everybody's bionic pancreas, doesn't matter which one it is, will have very slightly different programming within a month or so of them wearing it. That does not mean we are out of the system, though. We still have to be in there to advise our patients how to use it. We still have to be involved in this to make sure that they understand that they've got the right insulin, that there aren't any problems. We should never allow the black box technology to take over. Diabetic foot ulcers is another screening tool where we can actually get much better screening. And the advantage here is there are many places in the world where diabetic foot ulcers could be treated much, much sooner if we could identify them, and therefore we could get to them much earlier. The phones on our wrist can predict our cardiac risk by looking at beat-to-beat variability. It will tell you what your heart rate variability is and therefore what your autonomic status is. That is the single biggest predictor of heart failure from all of the AI technology. If we know that it's coming, we can do something about it before it arrives. We're seeing more and more adjuncts and programs that can help with obesity care because, to be blunt, we don't have the time that the individuals need. But we can be cloned. Dr. Makar himself has been cloned. And his information can be then passed on to hundreds, if not thousands, if not hundreds of thousands of people could benefit from those decades of, that 2 or 3 years of experience, because clearly Dr. Makar isn't old enough to have decades of experience, he says, on a very, very loose wire. We have the ways of interpreting the results that we can get our metabolic associated fatty liver disease from very, very simple algorithms. And I've gone through all of these that we've been able to identify the role of these AI in these medical conditions. However, I fear for future generations. We can work with that because we've done it. We know what background retinopathy looks like. We know what normal looks like. We know the best way to manage obesity, and we know if the computer gets it wrong. We're seeing more and more people that are now looking to AI where we used to look to the wet labs. We're seeing more and more drugs coming through AI drug discovery. And then we start to say, how are we going to make this going forward? Well, the digital twin is the first step towards that. A digital twin basically takes you, it clones every parameter about you, and then it uses every other algorithm that's ever been put. What would happen if I did this to the individual? What would happen if I did that to the individual? It will create about 10,000 copies of you, give you 10,000 different treatments, and figure out which one works best. Actually, the digital twin technology inspired the bit in the Avengers, the Endgame. I don't know how many people watched it. You know, where Doctor Strange does that thing and he tests 14 million different outcomes and said there's only one that they beat Thanos? That was effectively the process of the digital twin. And that's what we can do in a computer in seconds. So how do we get there? Well, as I said, there are lots of problems. The first problem is the legacy of the IT systems. How many of you in the room know that your computer system can talk to the computer system just down the road, or can talk to the computer system in the hospital or the primary care? They can't. They're not interactive. They don't work between them. Even in the National Health Service in the UK, the so-called National Health Service isn't national, because it's lots and lots of disparate units going forward. There's the need for investment, the need for the regulatory hurdles, and there's the need for caution. We have to be aware that AI is only as good as the information it's based on. I know I'm in my last minute, and in my last minute, I just want to try a little experiment. Everybody take out your phone. Take out your phone. God, it's not very often you get told to do that in a lecture. Take out your phone, ask whichever digital information that you've got, whether it be Siri, whether it be ChatGPT, Gemini, do it now. Ask it to generate a random number between 1 and 50. Do it for me now. Don't tell anyone, just have a quick look. Okay? Have you all done it? Yeah. How many of you is not 27 or 37, depending on whether you're Siri or ChatGPT? Two people in a room this size did not get those two answers. And that's because that's what the computer has been taught to say when it's asked for a random number. It doesn't create a random number, it does what it's being told to do. With our AI systems, it will only do what it has been taught, which means any inherent biases, any inherent stigma, any inherent problems with the historical treatments is what the computer's learnt from, and therefore, without us as a central part of it, AI will fail. And on that note, thank you very much. Thank you for forgiving me for the extra 30 seconds. Thank you.
Friends, we have not received any questions on the chat, so I request all of you to please note down your questions and send them on a piece of paper, so that then we can have all the questions answered in the end. Over to the third speaker, the very reason why all of us are here, Dr. B.M. Makkad, sir. Sir is Director of Dr. Makkad's Diabetes and Obesity Center, New Delhi. He was the past President of RSSDI, many accolades to his credit. And sir will be rightly speaking on the future of obesity management drugs. Sir, over to you.
Thank you, Sushil. Good afternoon, friends. It's indeed once again a great pleasure to see so many people post-lunch session also and interested in science. So I am going to speak on future therapies for obesity management, and I don't have any disclosures for this presentation. See, first thing that has changed recently is that we have stopped thinking beyond 5 to 10% weight loss, which we were thinking that it is important to improve the cardiometabolic risk. And we are looking at weight loss going beyond 15 to 20%, which can help us not only in improving cardiovascular risk, but cuts down CVD mortality, can give remission of diabetes, and even improve heart failure. This was because with medical therapy, we were hardly achieving 10% weight loss in majority of patients. But with the newer therapies that are there and are in pipeline, we are looking at weight reduction going in the range of 25 to 30% also. So what has changed dramatically, in recent past? It is the GLP-1 receptor agonist and the company that we have witnessed a revolution in last 1 decade. We know we have, semaglutide and tirzepatide already approved in India. I'll be having some overlap on the slides, of Professor Andrea, but I will try to avoid the overlap. So just to, give you a basic understanding of the energy homeostasis or the appetite regulation, we have neurohormonal pathways which increase appetite and which decrease appetite. And if you look at this, see, the pro-hunger hormone is only ghrelin, and all other hormones are trying to induce satiety, but this overpowers them most of the time. And then we have pathways which are acting, on feeding and gastric emptying and also on the hedonic eating. These pathways are also having crosstalk between each other, so they are not acting independently. So the prototype GLP-1, we had liraglutide, which was approved for weight loss, acts on GLP-1 receptor in brain, stimulates POMC card pathway, stimulates MC4, and leads to decrease in appetite. Now let's have a look at the evolving therapies. The first understanding for these evolving therapies came from bariatric surgery, which we interpreted as an intervention which increased the postprandial levels of multiple enteroendocrine hormones. And this led to the notion that if we combine these enteroendocrine hormones, we can have good therapies for obesity. And we have number of them in pipeline which are generally based on GLP-1 or GIP pathway. We have GIP agonist, antagonist, glucagon, amylin, peptide YY, and these all are being developed either alone or in combinations. And the aim is to enhance or complement the GLP-1 effect on weight loss and metabolism. Then we have number of smart molecules in pipeline with multiple receptor recognition. They have balanced effect or selective biased effect towards one receptor. We are also looking at tri and tetraagonists, and now recently we are looking at pentaagonists also. And we have combination of GLP-1RA with monoclonal antibodies. We have GLP-1RA with protein pyruvate kinase activators, and we have some genetic interventions also in pipeline. So looking at the GLP-1RA therapies, we now have semaglutide, which is much more potent as compared to liraglutide, which was the first GLP-1RA approved for management of obesity. And it is very well studied in STEP trials, which showed that semaglutide, management for obesity can, I don't know why this slide is not showing bars, but shows there is significant reduction going in the range of 17% in people with obesity as compared to placebo. And almost 85% achieve more than 5% reduction, 50% achieve more than 15% weight reduction, and third achieve more than 30% weight reduction, 25% weight reduction. Not only that, people who lost more than 10% body weight also had A1C going down by 2%, achieving remission of diabetes. There was improvement in cardiovascular risk factors, and the weight was sustained over 2 years period if the therapy was continued. And we have sustenance data. We have the CV outcome trial, which is the largest CV outcome trial with a GLP-1RA, looking at 17,000 plus patients, showing significant reduction in 3-point MACE with 19% reduction in all-cause death, 22% reduction in kidney disease development, and 73% reduction in risk of developing diabetes. Then we have the dual agonist. We already have tirzepatide in market. We are using it. It combines the benefit of both GLP-1RA and GIP. Something, as simple as GLP-1 is increasing nausea, GIP reduces nausea, GIP improves the fat deposition, while their GLP-1 is causing lipolysis. GIP promotes deposition, of fat in the subcutaneous tissue rather than the ectopic sites, also increases the insulin sensitivity and energy expenditure. Very well studied in SURPASS studies for diabetes management, and the SURPASS studies showed that not only there is a significant A1C reduction, there is significant weight reduction going in the range of 12%. This led to development of tirzepatide in SURMOUNT studies for weight management, and SURMOUNT studies clearly showed that it gives you a significant weight reduction with 5 milligram going up to 16% and with 15 milligrams going up to about 22%. Again, huge number of patients achieving weight loss targets, more than 80% patients achieving 15% weight loss and more than 25% achieving more than 50% weight loss. Significant reduction in cardiovascular risk factors, and we recently have the follow-up of SURMOUNT trial, 3 years follow-up data, again showing significant reduction sustained at the end of 3 years. As many as 80% people are, sustaining a weight reduction of more than 20% at the end of 3 years. Then we have combination therapies which are being developed around GLP-1, GIP, glucagon, amylin, and PYY. Largely, these are combining the synergies of different molecules, like GLP-1 is giving you reduction in appetite but increases nausea. GIP cuts down nausea and increases lipid deposition but prevents ectopic lipid deposition. Amylin gives you a decrease in appetite but increases the osteoblastic activity and improves bone health. PYY increases energy expenditure, glucagon also increases energy expenditure, and all these molecules are looking a combination with GLP-1 or GIP or a combination of more than 2 molecules, which is like retatrutide that we already have in pipeline. So I will touch on some of the molecules. The interesting thing is most of these molecules in development, large number of these are giving you weight reduction going beyond 15% and large number of people achieving more than 10% weight loss with these molecules. Then the number of people achieving weight loss of more than 15% is also more than 50% of the people achieving with these molecules. Not only that, there is significant reduction in A1C, so if we are looking at diabetes population, we are looking at significant remission of diabetes. Then we have combination of different molecules like CagriSema, which is already in pipeline and the initial data has been presented. Amylin we know is a co-secreted, it's a peptide co-secreted with insulin from beta cell and plays an important role in reducing appetite. So CagriSema is a combination with cagrilintide with semaglutide, and we have the initial data. Amylin basically is acts on the area postrema, reduces glucagon secretion, increases satiety, improves leptin and insulin sensitivity, and the initial studies with combination showed a weight reduction going in the range of 20% at 24 weeks. And the trend was still downwards. And this was followed by the recent presentations of, the recent clinical trials, which is REDEFINE 1, which looked at semaglutide, cagrilintide, and a combination of 2 in people with diabetes, and showed that there was a significant weight reduction which with a combination. I don't know why it is not showing a line here. So combination gives you a weight reduction going in the range of 22%, and a significant number of people are achieving weight reduction more than 20 to 25%, and the number is as much close to double when you are using the individual molecules. Another thing is there is significant reduction in the visceral fat mass which is happening in these people. Then we have the phase 3 trial looking at CagriSema, which is redefined 2, again looking in people with diabetes and obesity, and showed much better weight reduction as compared to the molecule, single molecule. Pointer is not working there. So 16% weight reduction with CagriSema in people who are, using combination therapy. Majority of people achieved more than 10% weight loss in CagriSema arm, with almost 20% achieving more than 30% weight loss. It is being studied in number of trials, even looking at MASH, obstructive sleep apnea, hypertension, heart failure, and chronic kidney disease. Then we have oral amycretin, which is a combination of oral GLP-1 and oral amylin, and this is also being studied. This is a first unimolecular GLP-1 RA amylin co-agonist with subcutaneous and oral formulations, which are both available. And if you look at the trend of weight loss, it is actually going downwards at the end of 36 weeks very clearly, with significant number of people achieving weight loss going more than 20%. This is in, under study in multiple trials like Redefine, Reimagine for type 2 diabetes, and MAs is only amycretin. Then we have oral GLP-1. We recently got data from, oral, orforglipron, which was the first phase 3 study was presented at the ADA meeting this year only. And this is basically a non-peptide oral agonist, which is a chemical, which is first in class. It is biased towards G protein activation, and initial studies have shown that you can achieve a weight reduction going in the range of, the A1C reduction going in the range of 2%. And if you look at the weight reduction, again, there is almost 10% weight reduction with people with diabetes, and the studies in obesity, which is, phase 2 data overview, shows that there is 15% weight reduction in people with obesity with oral orforglipron. Then we have the tetrapeptides. We had the data with retatrutide presenting last 2023 in ADA meeting, and this was a study which looked at once weekly injectable triple hormone agonist, GIP, GLP-1, glucagon receptor agonist, which is retatrutide, and this was the study looking at efficacy and safety of this molecule. Multiple doses ranging from 2 milligrams to 12 milligrams were studied. Fantastic results at the end of 24 weeks, 18% reduction, and look at the end of 48 weeks, 24.2% reduction in people who were getting 12 milligrams dose, which was close to 26 kilos. 100% people achieved more than 5% weight reduction, 90% achieved more than 10%, 80% achieved more than 50%, and almost a quarter lost more than 30% weight loss, which is as good as bariatric surgery. Then we have combination molecules which are combining not only the GLP-1 and GIP. There is a combination between GLP-1, GIP, amylin, and calcitonin, looking at improvement in bone health. And we all know sarcopenia is a major issue when we are looking at weight loss, and we had a beautiful presentation from Katrina in the morning. So we have unimolecular tetraagonist, which is combining the synergies of GLP-1, GIP, amylin, and calcitonin, improving bone health and cutting down the weight loss, the sarcopenia. This year we also had another beautiful presentation on this molecule numbered NA3931. This is a novel quadruple agonist of GLP-1, GIP, IGF-1, and glucagon receptor. And this is an oral molecule. Small drug molecule, which is first in class. IGF-1 helps in preserving the muscle mass. And this is a full agonist of all 4 receptors. It is not partial agonist, it is full agonist of all 4 receptors. And Not only that, it gives you a weight loss going in the range of about 25%. If you are combining with tirzepatide, you are looking at a weight loss going with almost 30%, 35%. And IGF-1 regulates the skeletal muscle protein synthesis, and we know this is beneficial here. So we have fantastic data coming up with this molecule. I am not going to go into details of survodutide because Professor Andrea covered this. There is another molecule with similar, agonism called mazdutide, which data is already there for phase 2 study, and again looks very promising. Then there is focus on the lean mass preservation, and we know sarcopenia is a big challenge, and we know that if you look at the GLP-1 based studies, the weight loss almost 30 to 40% can be lean mass loss. And we have bimagrumab, which is a monoclonal antibody, which is being combined with the GLP-1RA to cut down the muscle mass loss. Again, covered by Professor Andrea. So initial studies showed that not only there is weight reduction going in the range of 10%, but there is also increase in muscle mass when you are combining bimagrumab or using bimagrumab. And once it is being combined, there is data from BELIEVE study now, which is going to be discussed in the clinical trials period. So I will not go into details of this. Then we have pyruvate kinase, activators. Pyruvate kinase enzyme regulates the insulin secretion, and now it is being shown that it has action very similar to GLP-1RA and improves the not only glucagon, it has synergy with GLP-1, but important thing is it has similar synergy in weight reduction. So it acts similar to, a synergistic molecule with GLP-1RA in brain in cutting down appetite, and in diet-induced obese mice, the studies have shown not only it gives you a significant weight reduction when combined with liraglutide, there is preservation of muscle mass. And if you see, the combination therapy can actually allow the mice to achieve the normal body composition. It's as good as achieving normal body composition without any excess fat mass. Then it is being looked at in combination with the, because of its potency to increase muscle mass, it is being looked at in combination with GLP-1, GIP, glucagon, tirzepatide, all these therapies. Then we have genetic interventions. We can have gene silencing, splicing, and RNA editing, but we have interesting molecule called silencing RNA inhibigene. So it's a silencing molecule which has been studied in mice and recapitulates the human genetic data to demonstrate its beneficial effects. So what happens is, once there is human inhibit loss of function, it is associated with a normal metabolic profile. And study, hypothesizes that if we silence the inhibigene messenger RNA in hepatocytes by more than 50%, we expect to recapitulate the healthy metabolic profile in people who have loss of function. So what this gene does is, this suppresses, it is a lipolysis suppressor. And in healthy individuals, there is increased albumin-bound free fatty acids, but there is, with this gene, there is suppression of activin E receptor, which suppresses the lipolysis, lipogenesis. It increases the lipolysis. Overnutrition is associated with increased expression of activin E, which suppresses lipolysis and promotes lipid deposition. With combining this silencing mRNA with GalNAc, it produces a molecule which suppresses the activin E activity and leads to increased lipolysis and weight loss. And the study has been shown not only that it reduces weight loss, even after you stop therapy, there is sustained weight loss going up in some duration. But it's a short-term experimental study, so we don't have much data. Then we have interesting molecule called maridutide, which has been studied. So this is basically a long-acting peptide antibody conjugate. So this combines GLP-1 receptor agonist and GIP. And if you see, this is two molecules of GLP-1 and one monoclonal antibody which is antagonist of GIP. And in the double-blind study, it showed significant reduction in weight, significant reduction in weight even in people with diabetes, and people with diabetes, there is significant reduction in obesity. So my last slide is there. We are looking at something called quintuple agonist, which is in experimental study. This is, copy from one of my friend's slide. Tim Muller is there. So he showed that if we have a peptide conjugate with the steroid, it internalizes, the steroid molecule dissociates, regulates the nuclear expression, and you can achieve weight loss going to 40%. This is experimental data. This will come in some time. So we are looking at vaccine-like drugs. You inject every year and you prevent obesity, but there is a long way to go. We are closing the gap with bariatric surgery, but we have to be cautious because we are also seeing, that there can be side effects. Danuglipron was withdrawn because of the liver side effects. We have the neon data coming. We have, gingivitis coming up as one of the complications and so on. With that, I conclude my presentation, and I would like to invite you all for the AOCO meeting, which is happening on 19th to 21st of December, this year only, at this very venue. Thank you so much. My apologies. I killed 2 minutes extra, I think, because there was issue with this, pointer. Thank you so much.
Thank you so much, sir, for such an enlightening talk on the newer molecules. Now, I would request all the three speakers, Dr. Andreas, Dr. David, kindly come on the stage.
So we have a couple of questions from the audience. The first question is to Dr. Andrea Jaccari. What role do you see emerging technologies like beta cell regeneration and immunotherapy playing in the future management of type 2 as well as type 1 diabetes? Role of beta cell regenerating therapies and immunotherapies in type 1. We have teplizumab in type 1 therapy. Are there developments in this field?
I really think that the future is there. I just hope to see it. I mean, that's meaning that it comes to the next future. But we are very aware, for example, in type 2 diabetes, beta cells are there. Simply, they are not working. So finding a way to make them working again is probably the future. And what we need to understand is why they become sort of, let's say, silenced beta cells, meaning that the endocrine part of the cells are there, simply they are not able to respond properly. I mean, we discovered that with the GLP-1 receptor agonists. We had patients are not responding to other therapies. Then with the GLP-1 receptor agonist, we were able to stimulate the beta cell to produce insulin. And I'm sure there will be something that will try to make these cells go back in their history. And I truly believe that the future is to understand what happens not at the end, not when diabetes is already there, but before that, meaning that we know that the major reason for type 2 diabetes is the family history, meaning that we all have very obese patients, very high risk for diabetes who do not develop diabetes, while we have lean type 2 diabetic patients, meaning that the major reason for type 2 diabetes is insufficient insulin secretion for a certain amount of insulin resistance. And we can understand this, as soon as a boy or a girl is born, because there is some genetics there. So trying to understand where is the risk, trying to correct it before it develops, I think will be the future, and I'll really be hungry to see it in my life. That's my hope.
Thank you. We have another question, and this time it is to Dr. Strain. Dr. Strain, and this is a question that everybody fears. How do you see the impact of AI on the job security of doctors? Because everybody fears that, they are going to take up our jobs.
I think the day that the computer takes over from us is a very, very long way away. There is so much we get from being in a room with a patient that you cannot replace with a machine. We have the empathy, we have the ability to communicate, we have the ability to get all of that information. We all know that medicine is not just about the numbers. There's the other bits. You can actually get the scent of a patient as they walk into the room gives you information. The way that they walk, that perception, that's not going to disappear. What I do worry about, though, is a lot of these skills are not being passed on to the next generation. There are so much black box technology that's going on where the computer can look at everything and make a few recommendations after we've provided that information. But we understand it. We know how it's come to that conclusion, and it's just made our job a little bit easier. The next generation haven't had the experience we've had, and there is a real risk that if we end up in a system where the computer is making the recommendation to somebody who doesn't understand how it got to that recommendation, that we could see the mispractice being perpetuated and then self-reinforced. So I think we have a long time sat in our seats with the patients, and the computers are just going to make our life just that little bit easier.
But do you see the jobs going away in the near future? No, you don't.
No, I think it's going to be a very long time before a patient would rather have a chat with Alexa than they would have a chat with a person.
Perfect, perfect. And we have the next question to Dr. B.M. Makkar, sir. How do you see the increasing focus on personalized medicine impacting the development of new diabetes therapies? Dr. Strain mentioned in his earlier talk that you have to combine 3 or 4 drugs to attack the diabetes from various perspectives, from various mechanistic points of view. Do you think you see a personalized medicine getting into the way in developing new therapies?
So I think we are already moving towards personalized medicine. We are looking at, heterogeneity of diabetes, and we are looking at what is better for which category of people. And we are also looking at genotype analysis, suggesting which molecule will work better with whom. So we are already in an era of personalized medicine. And also, once we start discussing with the patient and look at patient preferences and make suggestions depending on the patient profile, we are already doing that personalized medicine. But we are going to get more and more technology support to improve our personalized approach in diabetes and obesity management. That's my take.
There's a question from Dr. D.K. Gupta. When we have side effects with combinations of GLP-1 receptor agonists and GIPs, especially of severe diarrhea, severe GI intolerance.
I didn't get the question. Sorry.
When we have
using diarrhea with tirzepatide.
When I use
Diarrhea.
Loose stools.
Loose
GI
stools,
upset.
GI intolerance. So do you stop the medication? If you do, how soon can you restart it?
I try as much as I can to give these drugs, especially not the tirzepatide, mostly with the semaglutide. We will see the SURPASS outcome trial next ESD, especially if the patient needs some cardiovascular prevention. So even if the patient is lean and not obese, I insist to give semaglutide, and apparently it will be the same with the tirzepatide for cardiovascular prevention. And it's just like, for example, when you give a statin and there's some pain in a muscle, and you have to try it. You try to resist, try to do your best, because it will save your life. So I really insist in these cases. In other cases, I just lower the dose and then try again to increase it later on, because more or less all the patients are used. I mean, we see also in the normal, in patients who can really resist to the side effects. After a while, you will see that the reduction in hungriness or things like this become lower, and I think it's the same also for other patients. Really, I really insist very strongly for cardiovascular prevention.
Sir, last question for anyone can answer, but you alluded to the talk for future for type 2 diabetes management. You spoke at length about GLP-1 RAs. Is there nothing to talk about now on DPP-4 inhibitors and SGLT2 inhibitors? The decade is over, and we have now the entire century focusing on GLP-1 RAs?
Well, you know, is that the point is that it's really such an unknown area. I show you that there are at least 10 different receptors. We can activate differently and contemporaneously, and sometimes the same receptor can be activated differently by different peptides, oral peptides. So it's really so intriguing, this future, that it's really something that is, I mean, I'm really curious to see what will happen. Because besides that, think that they start to develop a new drug, but if the results are not good, they immediately stop it. And who knows how many ideas did not come to our knowledge because they stopped even before than that. On the contrary, I believe the SGLT2 will be, actually is next metformin. Diagnosis SGLT2 to all of diabetic patients. And if there are infections, just recommend to wash themselves.
Thank you very much, sir. I think we had a wonderful session. A big hand for all our three speakers.
So thank you everyone for an excellent session. May I request Dr. V.K. Goyal sir to hand over the mementos to the chairpersons outside the hall. So let's take up the quiz. Kindly scan it. You can use the code also or scan. Be fast. So for the first question, be ready. Be fast. So who is Maverick? May I know? Let's move to the second question. Can we have the result? Can I know who's the winner for the 2 questions? Carl. Got it. Let's move to the 3rd question. You have to be really fast. Let's see the result. No award for David. So I think Carl is the second. So may I request Carl? Yeah. So I'll request Dr. Sunil Kohli sir to please hand over the shield to Dr. Carl outside the hall. So a big round of applause for him. Now moving to the last session of the day, but a very interesting one. May I request the chairpersons, Dr. Amitesh Agarwal, Dr. Anjali Bhatt, and Dr. Pooja Aralia on the stage and chair the session.
Good afternoon, everyone. We begin with a talk by Dr. Neeta Deshpande. Ma'am will be telling us about the recent advances in GLP-1 receptor agonists and their benefits with their combination therapies. I'll just take a minute to introduce ma'am also. She's a diabetologist and a bariatric physician at Belgaum Diabetes Center, Children's Diabetic Center, and she has multiple publications and books to her honor.
Thank you so much. It's a pleasure to be here again this year for this very lovely meeting and great scientific program. So I thank Dr. Makkar for inviting me yet again. So I'm going to be talking very briefly about the BELIEVE study which was presented this year at the ADA. And all of us know that GLP-1 receptor agonists are here to stay. They've taken the world by storm and all of that. But we also know that the weight loss reaches a plateau during year 2 of treatment, and if you stop the treatment, the weight is regained. All of us know this part of it. However, we also know, and we are very concerned, and you've been reading everywhere, what happens with the weight loss. Now, it's not only with GLP-1 receptor agonists, but any weight loss is associated with a reduction in fat mass that we know and that is desirable. But there is also a reduction in lean mass that is most undesirable, as you can see. And if you see in the step 1 study, you can see that 60% of what was lost was fat mass, which is good, but 40% was lean mass, and that is something that we don't want. Some amount of lean mass loss is inevitable. However, we want to minimize it as much as possible, and we try to look at ways and means to do this, and that is very, very important to us. Now, why is it important? Because as you can see the hazards ratio, if you look at the left side, you can see that as fat mass increases, the rates of death increase, while on the other hand, as fat-free mass increases, you can see that the rates of death go down. It's as simple as that. So fat-free mass, which is actually skeletal muscle mass, is extremely important to us for a variety of things, for metabolic health and also for protection against early mortality. Now, this is a very important slide that I want to point out too, and that is weight cycling. So whenever anyone comes to us and we want to prescribe GLP-1 receptor agonist and you take the history, you find that this person has had several attempts at weight loss, mostly by lifestyle modification. So weight cycling is the yo-yo effect, and if you look at the categories, you will see that the top left panel, the muscle mass keeps on reducing with each cycle of weight loss and weight regain, whereas the grip strength, which is a surrogate marker of muscle strength, that also keeps on decreasing. And if you look at it in a proper perspective, for sarcopenia, you find that if somebody has had one cycle at weight loss, yes, there is 9% of sarcopenia. If somebody has had 2 to 5 attempts and regain, then there is 24% chance of sarcopenia, whereas if more than 5 cycles, it's a huge 50%, which means that with every weight loss cycle, you're accumulating fat and you are becoming sarcopenic. And therefore, all future obesity therapies should aim to improve body composition. That is most important. That means all the obesity therapies that are going to come in the future, they're going to be looked at very, very closely for what they do to fat mass and what they do to muscle mass to maximize functional, metabolic and energetic benefits. And there should be individualized treatments, of course, for sarcopenic obesity and the elderly. Now, this was a lecture, beautiful one, presented at the ADA, where he talked about targeting the activin myostatin system to influence muscle and adipose tissue and function. So this is the crux of the matter, and from this targeting came the study called the BELIEVE study, where what they did was ACT receptor 2 blockade. They found that ACT receptor 2 blockade, which is done by the molecule bimagrumab, which is a monoclonal antibody, it enhances fat loss and preserves lean muscle mass during semaglutide treatment. So if you look at day 7 and day 13, and if you look at all of these from top to bottom, you will see that there is placebo, there is bimagrumab, there is only semaglutide, and then you will see the combination of semaglutide and bimagrumab, which comes out trumps in terms of % change in fat mass weight and lean mass weight. So if you look at the second part of the thing, you will find that if you use a combination, you will see that the third line, you will find that the lean muscle mass loss is minimized when you use a combination of semaglutide and bimagrumab. So that is a very, very important finding that came out, and that was the genesis of the BELIEVE study. So the BELIEVE study is a phase 2B clinical trial investigating a novel combination therapy approach to address muscle mass preservation, something we're all looking at when you're using GLP-1 receptor agonist, and this you want to do during weight loss. So if you had to combine both of these for obesity treatment, would you achieve at least minimizing muscle loss? So this was the study background and rationale. The background was the muscle loss problem. So loss of muscle mass, we know, is an emerging concern with GLP-1 agonists for weight loss, and lean body mass is estimated to account for, in different studies, between 15 to 40% of total weight loss from GLP-1 receptor agonists. So bimagrumab seemed to be the solution because it blocks activin pathways and increases, actually I'm going to show you the data, it actually increases muscle mass while decreasing the fat mass, and hence it could be complementary to GLP-1 drugs. And the BELIEVE study examines whether combining these mechanisms can produce superior body composition outcomes, something that we're all looking at. So this was the study design. It was randomized, double-blind, placebo-controlled, multi-center study with 507 adults with obesity or overweight. And there were 9 treatment groups. I'm going to show you those groups very shortly. The primary study was for 48 weeks, went on for 72. And bimagrumab is given IV at weeks 4, 16, 28 and 40, and semaglutide obviously is subcutaneously weekly. And there was an open label extension to 72 weeks. Placebo and bimagrumab 10 mg was switched to bimagrumab 30, and DEXA scan and body composition was done using the DEXA scan. So these were all the different groups that were there in this particular study, where you had bimagrumab in all these doses that you can see, and even in combination, and the semaglutide doses were, as you can see on the right hand panel. And what did they find? They found that in the phase 2, the first part, not the open label part, the first part of the 48-week study, bimagrumab increases muscle mass and decreases fat mass in overweight, obese individuals, as you can see very, very clearly. If you look at the right hand panel, it is just that they have just compared the placebo and bimagrumab, and you can see very clearly that fat mass is reduced with bimagrumab. And if you look at the body composition on the left hand panel, you will find that if you compare only semaglutide and bimagrumab, and if you look at the last, the brown columns, you will find that semaglutide reduces muscle mass, whereas bimagrumab actually increases muscle mass. So this is only a combination. They have not looked at the combination in this particular slide. But now looking at the results in a combined fashion at week 72, where it was the extension phase, you will find that bimagrumab, the weight loss was 10.8, semaglutide 2.4, but when you look at the combination, you are getting 22%, which is quite phenomenal. Fat mass versus muscle mass change. So if you look at the combination, the fat mass loss was 45%, and if you look at with the combination as against bimagrumab and semaglutide, and if you look at the muscle mass change, you will find that there is an actual increase with bimagrumab. So the key finding was that almost 93% of weight loss was from fat mass with the high dose combination, compared to 71.5% with semaglutide alone and 100% with bimagrumab alone. So proportion achieving more than 30% fat mass reduction was 94% if you use the combination, versus 36.4% with sema and 50% with bimagrumab. So you can see that the combination works synergistically and beautifully to reduce fat mass and increase or preserve muscle mass. There were additional metabolic benefits such as visceral fat reduction, reduction in inflammatory markers, extremely important, 83% in the high dose combination group by week 48. Adiponectin was increased, and lipid profile, there was a transient increase in LDL cholesterol with bimagrumab, returning to baseline by week 72. Safety profile for bimagrumab: muscle spasms, diarrhea, acne, and early transient increases in ALT and lipase. And of course, sema, we know what it is. Combination groups, it was similar. 9% of treated participants discontinued due to adverse events over 72 weeks, which is quite small. Most importantly, the last part on the panel, the biology of activin receptors is extremely complex. Please remember that. It is very hard at this point to predict all of the possible safety concerns. Phase 3 studies are going to give us all those results. So there are potential clinical applications to be using it as an adjunct to GLP-1 agonist. Alternative may be to incretins for people who can't tolerate GLP-1, maybe as maintenance therapy. So these are all the potential ways in which we can use it. So basically, the BELIEVE phase 2 study was essentially proof of concept. Does it enhance muscle function? We don't know yet. So the key takeaways: superior weight loss if you use the combination, optimal body composition. Combination therapy resulted in 45.7% fat mass loss while minimizing lean mass loss 2.9%. Complementary mechanisms, muscle preserving effects of bimagrumab. Next steps: phase 3 studies are needed to further evaluate efficacy and safety of this promising approach. So thank you all for a patient hearing.
Thank you so much. Thank you so much, Dr. Neeta, for that. There is a small change in the sequence. We would like to have and it is my pleasure personally to invite Dr. Sanjay Agrawal to allude to us to STRIDE study. I don't know how to introduce to you, sir, to the audience, because we all know him so very well, and being so active in RSSDI and his clinical practice, I guess I'll hand it over to you.
Thank you very much, Anjali. Thank you very much, Dr. Makkar, for inviting me for this wonderful meeting, which year after year draws so many nice people to come and listen to great academics. Since the time is limited, I'm straight away going to get into the talk. We often talk about, cardiovascular events, stroke events, but rarely do we really talk about peripheral vascular disease, which we know is also a very important component of diabetic complications that we tend to see in a day-to-day practice. So if you look at the overall prevalence, we have about 237 million people who live with peripheral arterial disease globally. And the numbers have doubled from 1.5 to 5.6%, all the way from 1990 to 219. There's a high prevalence in women as compared to men, and it increases with the age. And not only that, the concomitant prevalence in people with diabetes is about 13 to 30%. So clearly, it's about a third of your people who come, patients with diabetes who come to you, do have some form of a peripheral vascular disease that we really need to screen. Often patients have no symptoms, or patients have a lot of claudication pain or rest pain, which often tends to get ignored, and we need to screen our patients for peripheral vascular disease, although asymptomatic, or anybody who comes to us with effort-related leg pain. They should be screened for presence of any peripheral arterial disease. Not only that, if you have stenosis in one vasculature, you also have to screen for stenosis in other vasculature. So if you have a stenosis in peripheral vascular disease, you need to screen patients for their coronaries and cerebral circulations, because you have concomitant stenosis that may occur in other vasculatures. So the peripheral arterial disease has got an increased risk of amputations, infarctions, strokes, or deaths, and it impairs the quality of life. Now, this is the grading that is there, a classification of grading for claudication pain, by which we sort of classify the extent of peripheral arterial disease somebody has, but in interest of time, I'm just going to show the slide to you. But what are the unmet needs that we see of peripheral arterial disease in patients with diabetes? They're underdiagnosed because often we are not looking at it, we're not screening for peripheral arterial disease, and often pain perception that we get because of peripheral neuropathy additionally that the patient may have, the pain may get masked because of neuropathy that the patient may have. Also, there could be an altered sensation that the patient may experience, or no sensation at all. And 50% of the people of more than 50 years of age were not even aware that diabetes is a potential risk factor for peripheral arterial disease. Second thing is, of course, poor prognosis. So if somebody has a severe peripheral arterial disease, they have worse outcomes in terms of morbidity and mortality, and often patients come to us with non-healing ulcers, deformities of the foot, Charcot's foot, and so many other problems that the patient may have, because you have a vasculopathy and a neuropathy that tends to coexist often, and patients may have all kinds of problems in relation to the extremities. And the last part is, of course, you've got limited treatment options. So you don't have too many. You give pharmacotherapies in terms of pain relief, and if the pharmacotherapy does not get you the desired pain relief, you only have revascularization as an option that you tend to use. Now, that could be a percutaneous intervention, or it could be a surgical option that the patient has got. So the key question right now occurs is, do we have tools which we can use for delaying or preventing peripheral arterial disease by modifying the disease process itself? These are some options that we've got, and one of the major options that we've got is use of GLP-1. And all the way right now, what we've been looking at is GLP-1s for improved glucose metabolism, weight loss, lowering blood pressures, lipid profiles are improved, and reduce inflammation, which causes a severe risk reductions. So these are all in the domain that we do understand, and there's enough data to show this. What we are also looking at is, does it really help in patients with peripheral arterial disease? And that's where basically the rationale for the STRIDE trial comes in. What we do understand is the GLP-1 analog like semaglutide, it improves the peripheral arterial disease because of anti-atherosclerotic effects, which has the potential for reducing acute limb events and improving the functional capacity. Now, here's a sort of different trials that have actually had certain populations of people with, included for peripheral arterial disease, but the largest population that was included is in the STRIDE trial, which looked at patients with diabetes and peripheral arterial disease. The primary outcomes that were looked at was maximum walking distance. Did it increase? Did it sort of cause a pain-free walking distance that improved? And what was the quality of life that the patient had got, which was looked at from the quality of life questionnaires. And there was almost all patients who were included in the trial had peripheral arterial disease. So the investigational drug that was used for intervention was once a week semaglutide. This was the trial design. They looked at 792 people with diabetes, age more than or equal to 18 years. They had diagnosis of diabetes of more than or equal to 180 days prior to screening. A1C was less than or equal to 10%, and arterial disease was diagnosed with intermittent claudication. And they looked at, of course, at the end of 3 months, also they looked at pain-free walking distance of more than 200 meters on flat treadmills, maximum walking distance of less than or equal to 600 meters, or an ABI of less than or equal to 0.9, or a TBI of less than or equal to 0.7. So these were the inclusion criteria. They had a 8 weeks dose escalation and then a maintenance period for 44 weeks and a follow-up of 5 weeks. So total treatment duration was 52 weeks. These are the outcomes that were looked at. The primary outcome was, of course, change in maximum walking distance at a constant load treadmill from baseline to week 52. And secondary confirmative outcomes was follow-up in the change of maximum walking distance at week 57, change in the quality of life as judged by the questionnaires from baseline to week 52, and then change in pain-free walking distance on a constant load treadmill from baseline to 52. There were also supportive secondary outcomes that were looked at, like A1C, body weight, ABI and TBI, lipids and systolic blood pressures. So these were the other sort of outcomes that were looked at. This was studied in 108 sites. There were 792 participants, as I said, and obviously there were 20 countries that were involved in the study as mapped out in the slide. What are the results? The primary outcome, you had 13% improvement in the maximum walking distance when compared to placebo. The benefit of once weekly semaglutide was consistent across all pre-specified subgroups from baseline to 52 weeks. So if you look at the age, gender, region, A1Cs less than or equal to less than 7.1 or more than or equal to 7.1, or BMI, which was less than 28.6 or more than or equal to 28.6. You find consistently across all the subgroups, the benefit was seen with once weekly semaglutide. Not only that, they had a higher amount of responder rates in terms of maximum walking distance or sort of quality of life. So they had almost about a 50% improvement. So the responder rates were high, as well as the quality of life that was seen was almost in about 37% of the people as compared to placebo. So that had a good responder rate when you looked at once a weekly. So the summary of primary outcome was that once weekly semaglutide with 1 milligram was consistent across all pre-specified subgroups of age, region, sex, A1C and BMI. And there are high responder rates with once weekly semaglutide of 1 milligram, which emphasize the clinical significance of the results. What about the secondary outcomes? So you had, when you looked at all the way up to 57 weeks, the earlier data was of 52 weeks, you had 8% further improvement with maximum walking distance. This was the secondary outcome. If you look at the health-related quality of life, as VascuQL6 questionnaires from up to week 52, you find that there was great benefit with semaglutide, and this was, the p-value was significant. And then if you look at the pain-free walking distance, that's PFWD, there was 11% improvement with semaglutide as compared to placebo at the end of 52 weeks. What about the other primary and secondary outcomes that were listed as compared to placebo. So this is just a summary of what I said earlier, and this is a forest plot. You find that the p-values are significant. So maximum walking distance at 52, 57, and pain-free walking distance at 52 weeks. If you see all of them on the right side of the unity line, which signifies that this was clinically significant, and the quality score was also significant. So the summary of the secondary outcomes was that once weekly semaglutide was confirmed for change in walking distance at maximum walking distance at week 57. There was a superiority of once weekly semaglutide as was confirmed with the change in the quality of life questionnaires at week 52. And there was a superiority of semaglutide 1 milligram against placebo, which was confirmed for change in pain-free walking distance at the end of week 52. This is the last part of it, of course, of summary of exploratory composite endpoints, where we talk about that how many people required rescue treatment and if the semaglutide failed. So as compared against placebo, there was a very low percentage of people who required rescue treatment either by pharmacotherapies or by surgical revascularization when the people were on injectable semaglutide once a weekly. This was a summary of the supportive secondary and exploratory outcomes. So whether it's body weight, ABI, A1C, all of them tended to improve, and which I think there are other collateral trials which have shown similar results. So the overall conclusions are that STRIDE met its primary and key secondary objectives by demonstrating a favorable once weekly semaglutide 1 milligram on both walking ability and patient-reported symptoms, and it impacts the intermittent claudication much better in terms of quality of life questionnaires when compared to placebo. There was safety data was in line with the known profile of once weekly semaglutide 1 milligram, and there was no unexpected safety findings that were identified. And the trial results support a favorable benefit risk ratio of once weekly semaglutide 1 milligram in people with diabetes and peripheral arterial disease in relation to intermittent claudications. Thank you very much for your patient listening.
So thank you so much, sir.
Questions at the end.
Yeah. We'll move over to the next presentation now. The next presentation. Next presentation is
Sir
on.
would be traveling, so if there are any questions for Sir, could you please write it on a placard and pass it to us, or write it in the app?
Thank you.
Yeah, thank you, sir.
So now we invite Dr. Nilakshi Dekar, who will be speaking on the Redefine. She is a practicing endocrinologist based in Guwahati, Assam, and we are eagerly looking to listen to you.
A very good evening, everyone. Thank you to the organizers of ACCD 2025, BM Makkar sir in particular, for giving me this opportunity to be in this prestigious scientific event. We are coming to an end of this extravaganza, scientific extravaganza, extensive scientific extravaganza, which we had in the past 2 days. The topic that I have been assigned is speaking on CagriSema, the redefined trials. So let us have a look at So CagriSema is a combination of cagrilintide and semaglutide. So how does amylin analogs act on the energy intake and expenditure? So we are aware of GLP-1 receptor agonist, and then we have amylin on the other hand, which exerts broad metabolic effects across the appetite and glucose regulation. So what is amylin? It is the second beta cell hormone which is co-located and co-secreted with insulin from the pancreas with a T-half of 15 to 20 minutes, and it acts mainly on the area post-trema in the brain. It reduces the pancreatic glucagon secretion, increases satiety, decreases the rate of gastric emptying, counteracts the decrease in energy expenditure which comes with any weight loss procedure. It also improves the insulin sensitivity and the leptin sensitivity. So we see that amylin has multifactorial effects. When we talk about appetite regulation, it decreases appetite, decreases energy intake, decreases the food reward, increases satiety, and partially restores the leptin responsiveness, which is not seen in obesity. It increases the responsiveness to leptin, decreases glucagon secretion, and improves insulin sensitivity. In the GI tract, it decreases gastric emptying, and thereby it makes us feel full, decreases gastric acid secretion, and in the kidney, it inhibits systemic oxidative stress. It also has an effect on the bone, where it inhibits bone resorption and leads to bone formation. So CagriSema comprises of amylin analog and a GLP-1 receptor analog, and CagriSema is in clinical development for obesity and type 2 diabetes. So it's the distinct dorsal vagal complex circuits that mediate the effects of semaglutide and cagrilintide. How does CagriSema cause weight loss? Though obesity may not be an easy equation of decreased energy intake and increased expenditure, yet CagriSema works on this basic pathway, decreases the energy intake and increases the energy expenditure that takes place. It was found to lower the body weight and fat mass in diet-induced obese rats. And there are studies with this combination that is going on. So let us have a peek into the REDEFINE trials. So redefining treatment of obesity with cagrilintide and semaglutide combination, that is what REDEFINE stands for. It is a phase 3 trial, so there are two trials, REDEFINE 1 and REDEFINE 2, which are in focus now. So REDEFINE 1 is a phase 3 trial which evaluates CagriSema in people with obesity. Inclusion criteria in this trial were male or female above the age 18 years with a BMI of more than 30 or BMI of more than 27 plus one comorbidity. Exclusion criteria in REDEFINE was the presence of diabetes, either type 1 or type 2. And this was the baseline characteristics. Patients had a mean average body weight of 106 kgs, mean BMI of 37, 114 centimeter. Around 67% were female and 32% were male, where the mean age was 47 years. One of the key unique features of REDEFINE 1 was that we know in any trial, you are made to go up to the highest dose of the product that is being evaluated. But in REDEFINE trial, so some flexibility was allowed. There were 4 arms of patients. So in one arm, CagriSema was tried, in the other arm, only semaglutide, and in the other, cagrilintide, and in one placebo. And in the CagriSema arm, there was a mean weight reduction of 22.7% compared to 16.1% with semaglutide and 11.8% with cagrilintide. So it was seen that greater proportion of participants reached the more than 25% threshold of weight reduction with CagriSema. Almost 100% of the patients in the CagriSema group achieved minimum weight loss of more than 5%. And even in the greater than 30% category, almost 23% of the patients who were in CagriSema, they achieved greater than 30% body weight loss. And this was twice the amount with monotherapy, that is either semaglutide or cagrilintide alone. When the body composition was looked into, it was more of fat mass reduction of almost 67% or 70% compared to 30% lean tissue mass. So it was more of fat reducing compared to lean mass or muscle reducing. And then we have the REDEFINE 2 trial. So that was REDEFINE 1 in patients with obesity, where it was the effect of CagriSema was tried. REDEFINE 2 was similar study of cagrilintide and semaglutide or CagriSema in patients who had diabetes. So there were 2 arms. In one arm, were included patients who received CagriSema, and another was the placebo arm. And it was seen that more patients in the CagriSema arm reduced their body weight. That was close to 15.7%. There was a significant weight reduction, and also there was a good HbA1c reduction, which was minus 2.1% in the CagriSema arm compared to placebo. Apart from reducing the HbA1c, CagriSema in REDEFINE trial also showed decrease in glycemic variability and improved daytime glucose stability. There was low incidence of hypoglycemia despite weight and glucose lowering with CagriSema. So there are other parameters which also showed improvement as observed from REDEFINE 1 and 2. So there was a reduction in the systolic blood pressure which was close to 8 millimeter, diastolic blood pressure reduction of close to 5 to 6 millimeter of mercury. So it achieved, and on an average, a very good BP reduction also. There was a reduction in LDL, improvement in the HDL, reduction in the triglycerides in these REDEFINE 1 and 2 with the CagriSema combination. The safety of CagriSema is like the established adverse effects of any other GLP-1 receptor or GLP-GIP currently that is available. Most of them were related to the GI tract, and it was nausea, vomiting, feeling fatigued, sense of asthenia. These were the common side effects, and no other red flags were observed. It was seen that nausea, vomiting was highest during the time of dose escalation, and they gradually tend to fade away when the patient develops tolerance to this. So this, in the last part, we'll see the global phase 3A trials with CagriSema. So REDEFINE 1 was the use of pregnetinide and semaglutide in patients with obesity. REDEFINE 2 was use of CagriSema in patients with type 2 diabetes and obesity. There are also other REDEFINE trials. So REDEFINE 3 is a CVOT trial which evaluates the cardiovascular, it's a non-inferiority trial. The objective is to confirm the non-inferiority of CagriSema compared to placebo in patients with obesity and diabetes. Then there are other regional REDEFINE trials like REDEFINE 5, which was done to look for weight management in East Asian population, particularly Japan. REDEFINE 6 is weight management in China. And then REDEFINE 4 is another trial which looks into it's a head-to-head trial of CagriSema vis-a-vis tirzepatide. So where CagriSema would be looked as to its effects on weight and HbA1c reduction as against tirzepatide. Then REDEFINE 8 is a long-term effect of CagriSema on weight loss in patients with obesity. So what are the long-term effects of CagriSema in patients? This was a very long duration study. And REDEFINE 9 is the use of low-dose CagriSema. So we have a CagriSema combination of 2.4 versus 2.4 for REDEFINE 1 and 2. In REDEFINE 9, they aim to look for the effects on obesity and HbA1c reduction with CagriSema 1.7 is to 1.7 milligram. So with these peek into the various REDEFINE trials using CagriSema, we conclude that CagriSema comprises the amylin analog pregnetinide and the GLP-1 receptor agonist semaglutide. In REDEFINE 1, CagriSema improved the body weight, the waist circumference, the body composition with more fat loss compared to muscle loss, and was well tolerated with people with obesity. There were no red flags as regards the adverse events. In REDEFINE 2, CagriSema improved the body weight, also reduced the HbA1c close to minus 2.1%, as well as there was improvement in other cardiometabolic factors like reduction in systolic blood pressure close to 10 millimeter, diastolic blood pressure close to 5 millimeter, with an improvement in the lipid profile, reduction of LDL, reduction of triglycerides, and improvement in HDL cholesterol. There is also an ongoing Reimagine program which will investigate the effects of CagriSema versus a range of comparators in people with type 2 diabetes. So with that note, I thank you for the patient hearing.
Ma'am is here. Ma'am is here till the end of the session, so we can have questions. And you write the question on a paper and pass it on. Can someone help sir with the pen and paper?
Our next speaker is Dr. Jasjeet Wazir. Sir is presently the Director of Division of Endocrinology and Diabetes at Medanta, the Medicity at Gurgaon. Welcome, sir.
So, can I start? Okay, thank you. you're wondering what a blank slide is doing. It's been very serious discussions here, so I'll make the mood a little lighter. Over the last about half a decade, we've had different adjectives given to the newer medications approved and available for diabetes and obesity care. The game changer, semaglutide, and the magic of tirzepatide, fondly called as magic of Mounjaro. However, now it's my honored duty to raise the curtains on orforglipron, and I choose Dawn of a New Day. And why did I choose this? Because it's very soon going to be available for clinical use. Today's duty is focused on the ACHIEVE-1 trial, recently published in the NEJM. Orforglipron is a small molecule non-peptide GLP-1 receptor agonist. So that's all we need to remember: oral, non-peptide and GLP-1 agonist for daily oral administration, has a very long half-life, about 50 hours. Now what the beauty of this drug is that it can be taken irrespective of the meals. Now keep a comparison in mind where we're talking about oral semaglutide, and hopefully in the near future we'll have OFG available for clinical use. Let's keep it in mind. It can be taken irrespective of the meal. Now the phase 1 trials indicated that irrespective of the meals, the Tmax, so the maximum concentration, is attained equally whether you take it fasting or after the meal. The AUC and the maximum concentration of the drug varied a little bit. So they did a modeling on that and came up with certain numbers at the drug dosage. They found if you start at 2 milligram, people don't tolerate it well. You give it, increase the drug dosage 2 weeks, it doesn't work that well. That's where the dosing schedule of 1, 3, 6, 12, and 24 and 36 came up with monthly increments. So that's, we made the base, and the drug is given without, irrespective of the meal. This is the entire ACHIEVE program, which is OFG in diabetic field. These are not the obesity trials, those are the ATTAIN trials. So one published is the ACHIEVE-1 trial. I'll talk about that. Very interestingly, we have an amazingly large representation of Asians, American Indians, and about 15% of these patients were enrolled from our country. So directly these results can be extrapolated to our own population. Very simple as that. Now, another beauty of this trial was the baseline A1C, 8%. So any drug showing excellent potency in A1C reduction at a baseline of 8 is equal to a great potency. We'll look at that. These people had a very short duration of diabetes, or we fondly call as young diabetics, and they had generalized and abdominal obesity as would be expected in a population like this. This was the dosing schedule, 3 arms, the 3 milligram, 12 and the 36 milligrams with 4 weekly increments, and treat to target. Inclusions, diabetics who had a A1C in between 7 and 9.5. Now they were drug naive, or they had discontinued the therapy in the last 3 months. So essentially they were not on any medications, and this was a placebo-controlled trial. The endpoint was a A1C reduction. Trial duration was about 40 weeks. Now, the comparisons were made in 2 ways. Now, statistics always used to confuse me, so I made it easier. We have the efficacy estimate, what essentially means the maximum potency of a drug under controlled situations. You take out people who've discontinued or rescue medications, so you get the true potency of the drug. And the treatment regimen estimate is basically when you and me use this drug in clinical practice, what do we expect out of it? So one is what actually happens under a controlled environment. 2, what is likely to happen when all of us use this drug. That's the treatment regimen estimate. Coming to the results, A1C reduction at 40 weeks, you see both in the real world and in a controlled situation, about a 1.5 reduction in the A1C. Now this is amazingly large where we're talking about a baseline A1C of about 8%, directly indicating the potency of the drug. About 73% of these patients with a 36 milligram dose achieved a A1C less than 7%. And talk of the town is, does this drug help in remission of diabetes, getting A1Cs less than 6.5 or 5.7? Large percentage, less than 6.5, 60%. And in the non-diabetic zone, we had about 20% with a oral medication, which can be taken irrespective of the meal, means big in clinical practice. They did a 7-point BG log and found all the blood glucose levels. Because of its long half-life, all the blood glucose levels coming down very well. Coming to the other basket of goodies provided by OFG would be weight loss, both in real world, expected in real world, or under controlled conditions. It's giving around 8% weight loss, with the benchmark for weight loss being 5% being achieved in 60% of the patients with the maximum dose. 30% people achieved more than 10% weight loss, and about 10% more than 15% weight loss. Now these are big numbers with a small pill. The last two slides focus on a question which all of us would have, or I had in my mind when I was preparing this slide set, that we know with all incretin-based therapies, there is a difference in how people with diabetes or without diabetes respond. So the two published trials are the ACHIEVE-1 and the ATTAIN-2 trials. ATTAIN-2 is in obesity and type 2 diabetes, in which over a longer period of time of 72 weeks, they were able to achieve a lower A1C of about 1.8% and about a 10% weight loss in obese and type 2 diabetics, again proving the fact that without diabetes, the quantum of weight loss would be greater. Some benefits on other cardiovascular risk factors happening, and possibly to me the most important direct comparison with oral semaglutide. Now purposely here I've taken the higher doses of semaglutide, the Pioneer Plus trial, which was in diabetes, where the 25 and the 50 milligram doses were compared with the 14 milligram over 52 weeks. And on the right hand side, we have the ACHIEVE-1 trial and the phase 2 trial, 26 week of OFG with the doses of 15 to 45 milligrams used. That clearly shows an approximately equitable A1C reduction with 25, which crosses 2% with the 50 milligram. However, with higher doses of orforglipron, they were able to achieve a similar 2% reduction in the A1C. Body weight change, it required about 50 milligrams in diabetics with oral semaglutide to achieve 8.5% reduction in weight. However, with the lower doses, with the higher doses of OFG, it crossed 10%. And in the ACHIEVE-1 trial, as I presented, it was giving approximately a 8% weight loss. So in clinical practice, if we really look at it, we're looking at a better glycemic potency, we're looking at greater weight loss, and the comfort and convenience of taking the pill at any point of time, irrespective of the meals, giving us food of thought of taking a decision in the near future. Is it really going to be dawn of a new day? With this, I end and thank all of you for your kind attention. I too learned a lot by preparing these slides. Thank you very much.
Thank you, sir. Next speaker is, we take the questions at the end, sir. Next speaker is Dr. Dheeraj Kapoor. Sir is the Chief of Endocrinology at Artemis Hospital, Gurgaon, and he's also the University Examiner for DM Endocrinology. Over to you, sir.
Good evening. I think this is the lecture which will draw the curtains. So I've been asked to speak on Maritide. Now, this is one drug, obviously, which has not been marketed as of now, but the data shows its great potential in terms of weight loss. So first of all, the name. So cafraglutide is the name. Glutide means something to do with GLP, and Madibart is a fantasy name. So this is a drug which has both a name and a surname. And to me, this is the most interesting aspect. Now, we've all heard about a drug which is a GLP-1 as well as GIP receptor agonist. This is a drug which is GLP-1 receptor agonist and antibody to the GIP receptor. So two GLP-1s which are in the pink, and the blue is the antibody. So it is a long-acting peptide, agonism as I said, and used for treatment of antibody. So the drug is AMG 133. Half-life is around 21 days, which means that it can actually be given once in a month. Now, how does it act? So it binds to the cells which have both the GLP and the GIP and triggers receptor internalization, and the CMP is released. Now this begs the question that if GLP-1 and GIP agonists can cause weight loss, then why doesn't an antagonist cause weight gain? It is still causing weight loss. So we know that GIP receptor agonism leads to nutrient absorption, yes. Increases the adipose tissue blood flow, which means the adipose tissue get more capacity to build in fat in their cells, and therefore ectopic sites don't get it. And of course adiposity, but primarily in the subcutaneous, but otherwise also there is weight loss. Now data is that in the animal studies, whether you antagonize the receptor or antibodies to it, or you delete the receptor gene, there is weight loss in the animal models. This drug is a GIP receptor antagonist, and on that account, therefore, it should cause weight loss as it has in mice and monkey models. So how does both agonism and antagonism work? So we know that GIP agonism increases GABAergic inhibitory hormones. GIP antagonism may decrease the activity, which means it may decrease the appetite. Chronic loss of GIP activity, as we see in agonism, would cause desensitization and increase in GLP-1 sensitivity. Now we are doing this, we are antagonizing the molecule straight away, so the GLP becomes effective from day one. This is a diagram which shows the GIPR agonism, GABAergic on GIP and glutamatergic on GLP, and glutamatergic is appetite suppressant, GABA potentiates, but on the whole, once there is desensitization, the glutamatergic predominates, and therefore there is no net loss of appetite. So agonism and antagonism seen in conjunction with GLP. So agonist causes weight loss even if given alone, not to that extent, but still some. Glucose lowering, we know that GIP accounts for 44% of insulin release from the beta cells, would not cause emesis. Weight loss, yes, through CNS, and of course increases insulin sensitivity at the adipose tissue. Antagonists alone would not cause weight loss, would possibly cause glucose lowering, and of course data on emesis or resistance of insulin is not clear. So with this in mind, we come to the phase 1 study. The doses studied were 21, 70, and 350, given 4 weeks apart, and there was a mean change in body weight around 1 month, 35 days, from 5.5 to 7 kilograms, which would translate to a weight loss of around 5.5 to 7%, because the mean body weight was 100. The phase 2 study, so this is a slightly complex graph, which actually shows that those studied were 140, 280, and 420, either escalated or not. There was a 420 dose escalation, which means starting from low and going up to 420, studied both in patients with and without diabetes. So the data 52 weeks, which is 1 year, the dose was investigated and also the maintenance-based strategies. But since this drug is not in the market, this dose is still not clear as to what is to be done. Now, in this study, the endpoint was a % change in body weight. That is 5%, 10, 15, and 20%. The change in HbA1c, pharmacokinetics, body composition as regards the fat mass, and of course the safety assessment. So the primary assessment, the primary endpoint, obesity. Now, the efficacy estimate means that the patients were given drug and there was no rescue medicine required. Treatment, rescue may be required. So in the treatment policy estimate, the weight loss was around 14% as an average as compared to placebo, and the efficacy, it was around 18% compared to placebo of 2.6. In obesity with diabetes, the weight loss was slightly lesser, and obviously there are certain drugs of diabetes which cause weight gain. Possibly that was the reason why there was a lesser weight loss in patients with diabetes, both in the treatment estimate and the efficacy estimate. The HbA1c, there was a fall of around 0.4% in patients with obesity without diabetes. However, in those with diabetes, at the end of 1 year, there was an impressive fall ranging across 1.9 to 2.2 kgs across the drugs. There was an improvement in waist circumference, BMI, and other parameters. Now, percentage of body weight change, well, as compared to the placebo, it was impressive across varying doses, anywhere from 16 kgs to around 20 kgs, and in those with diabetes, anywhere from 12 to 17 kgs. However, impressively, this was the drug which hung its head out to say that yes, lean mass loss also happens. In the initial stages, we've seen about GLP-1s and gliflozins that it was believed that lean mass is not lost. I mean, no one believed that, but in the sense it was portrayed that way. But here, in the obesity cohort, there is a lean mass loss of 8 to 11%. And in the obesity diabetes, it was around 6.8 to 9.6. So there is a loss in lean body mass. Side effect profile, as usual, GLP-1s, it's the gastric which is to be borne in mind. However, gallbladder events were reportedly more in the meratide group as compared to the other. Interestingly, in patients with a dose of maybe 420 straight away, that showed higher side effects as compared, higher side effects as compared to those in this, it was not happen. As regards the contraindications, pancreatitis, family with hepatic carcinoma, tests were done, calcitonin, amylase, lipase, all increased, but they stayed within the normal range. So the key points on the study were weight reduction with Maribat was accompanied by improvement measures. In phase 2 trial, patients had weight loss of 15%, around half of them, regardless of cohort. Obesity with diabetes had a lesser weight reduction, but still impressive, and there was also a hypoglycemia, which was more common in the patients who did not have diabetes, interestingly, and HbA1c fell by 1.6%. Now, in the pipeline, there are certain trials which most drugs need to do: overweight, type 2 diabetes, cardiovascular, and heart failure. So the maritime phase 3 clinical trial program would encompass all these. However, for the kidney disease and OSAs, trials have not started. So this is my final slide. The therapeutics have evolved from twice daily administration to once a day, once a week, and now finally, hopefully, once a month. The antagonism of GIP receptor by maritide may have a new mechanistic insight, and also once a month maritide has shown an improvement which is substantial and clinically important in patients with obesity with or without diabetes as far as phase 2 trial is concerned. Thank you so much for your patience.
Thank you, sir. Now I invite all the speakers of this session to the stage for the question answer with the delegates. So the first question is for Dr. Nilakshi. That is from Dr. D.K. Gupta. And he is asking that amylin analogs has too many properties. What naturally produce amylin from beta cells does to the physiology and diabetes?
So physiologically also, amylin is supposed to decrease the gastric emptying. It acts on the area post-trema in brain, thereby reduces the homeostatic as well as the hedonic appetite. That is the eating in response to the feeling of reward or gratification, as well as eating in response to hunger. It slows gastric emptying, thereby it makes you feel full. And then it also has effects on bone and prevents bone resorption, promotes formation, the pathophysiology goes towards formation. So these are the few physiological actions of amylin also. Decreases food intake, increases energy expenditure, and slows gastric emptying.
These next questions are also for you. The next questions are also for Dr. Nilakshi only.
So a question is, CagriSema in Redefine 1, the average weight is 100 kg plus. What will be the outcome of weight in percentage in patient weighing 80 to 85 kg? So around the percentage of weight loss that was seen was close to say 17 to 18% in the CagriSema group in the Redefine trial. So when we take 80 kg and we consider say roughly 20%, that would be around 14 to 15 kgs, I believe. Higher the weight, greater the reduction. Yeah. Yes, yes, very true.
What will be the outcome percentage? Will it be the same what is being shown here in theory, or will it be lesser than that?
So one good thing about, coming to your question, one good thing in the Redefine 1 trial was that there were 4 arms, one with placebo, one with cagrilintide, other with semaglutide, and the fourth with CagriSema. So the intention was to reach a dose of 2.4 Cagri and 2.4 Sema in the combination of CagriSema.
Yeah.
But in some they kept the dose low, say it could have been 1.7 is to 1.7, and still they observed the weight loss pattern. So it was not mandatory to go to the highest dose. Depending upon the tolerance, they were given a maximally tolerated dose, and it was seen that the weight loss was significant even in them. We know a concept that if the baseline weight is higher, then the amount of weight loss that is achieved is also greater. So perhaps in the usual OPD patient, the garden variety of patients which come to our clinic normally, of around 80 to 85 kg,
definitely
achieving a weight loss of 10 kg with this is fair enough. There's also that Redefine 9 trial which is ongoing, where they have tried a lower dose of this
1 milligram.
Yes, yes. 1.7 milligram.
Yeah. Second question is there. I would like to know from all the panels, if anybody else can be able to answer. I am getting one patient giving history, diabetic, last 10 year, 15 year, HbA1c varied usually from 7.5 to 8.5 in last 10 years. Now he is reaching to the extent of beta cell failure kind of a picture, and having all borderline investigation showing complications, macrovasculars, are now set in that patient. Now I start GIP, GLP-1 RA, etc. medicine. So I would like to know, like we are talking very high of CVOT trials, MACE reductions. So will it be possible that these complications are reversible? So in my point of view, is it possible those complications will be reversible?
So the microvascular complications per se would not be reversible. However, when we talk about the molecule in question, CagriSema, we know with semaglutide, there's a capping of EGFR till which you can use. Like you're not supposed to use at a EGFR of...
Later in the natural course of disease, we start the molecule. Lesser are going to be the expected outcomes from the molecule. So the spectrum starts from dysfunction of adipose tissue. Then you develop obesity. Then we develop hyperglycemia, which we identify as diabetes. And then long-standing hyperglycemia will result in micro and macrovascular complication. At every stage, these molecules will have favorable effects, but depends on when you start. If you start earlier, we get better outcomes.
Sir,
actually,
I think
these drugs have given us a very new perspective, going much beyond the UKPDS Accord Advanced Steno trials, giving us an opportunity even with a longer legacy of poorer control, providing very good organ protection despite having, like for tirzepatide, we had about average 8.3 and 1 in 2 developed remission.
Yes.
Two complications of diabetes that we're talking about. One, somebody who has proteinuria has very well stoppable and reversible. The second is the liver aspect of it. Look at the Essence trial that showed F2, F3 easily. You can stop it and reverse it. So that's what extra the newer age therapeutics is providing.
What
to our
about,
patients.
like if I did angiography?
Sir, Gupta
CAG.
sir, I think we can take this interaction on a one-to-one basis at the T, and if somebody else has any question, we can close down this.
Thank you.
session, please.
Thank you very much.
Excuse me, ma'am. For obesity reduction and in diabetes, semaglutide, etc., what percent of patients tend to discontinue the treatment because of its common GI side effects? And how to address kind of those normally?
There was a fraction of patients who had discontinued, but as we said, the one good point was that they didn't have to mandatorily go to the highest dose. So they could retain most of the patients who were on this CagriSema combination. Even in the placebo arm, there were discontinuation. In the placebo arm, discontinuation were because of loss of weight loss. I mean, there was no significant weight loss. So they discontinued the trial.
And with semaglutide, which is most commonly used?
Mostly GI, mostly GI.
So, thank you chairpersons and speakers for an excellent session. Okay, sir. Just a request, please don't forget to collect your mementos from outside the hall.
Sir, I think we all should stand up to give a great ovation to Dr. Makkar before he gives thanks to us.
May I invite Dr. Pushkal? Be fast. Sir, he wants to have a pic with you. He was the poster winner. So thank you everyone, and now I'll invite Makar sir to be here to carry on the further final proceedings.
नहीं जल्दी नहीं.
Good evening, friends. All good things must come to an end, and that's what is happening right now. First of all, I must thank sir for very kind words for this ACCD program. It's always overwhelming to have this program every year, and every year we have been trying to make it better, which is dependent on the feedback that we are getting. So it is very important that all of you please be critical and send us your critical feedback where we can improve on this program and how we can make it better every year. So first of all, I would like to thank here my friends from outside India. We had a fantastic faculty who had put in phenomenal effort in preparing the presentations and the kind of presentations you witnessed here. I am sure you would have not seen these kind of presentations everywhere. So thanks a ton to Professor Andrea Jacare, Professor Katerina Conte. She is not here. Must thank Julia Mather. She is the program chair and also the chair of Training and Education Committee of EASD, and my friend David Strain from UK. They just travel on a very sharp, fast schedule. They are all the time on bullet train, running from outside India to inside India, and once the program is finished, they will be flying back tonight itself. So they don't get much time to relax here or go for tourism also. So thank you so much for all the effort and making this program what it is. I must also thank the faculty from all over India who have come, joined this program and made it a very successful event. This program cannot be successful without the support of so many people who work behind the scenes and help me in running this program smoothly. We always try to run it on time and make it relevant in terms of question answers also, and I think we keep trying to modify the system every year, and hopefully you are liking it. To make sure that program runs on time, I have a lot of people working with me. Some of you faces you are seeing perpetually on the stage or in the workshop halls, but there are many others who are contributing here. So I must thank Dr. Pooja, Dr. Seema, Dr. Amarpreet, Dr. Amitesh here, RPS Makkar, Dr. Sunil Kohli, all the people in faculty. Dheeraj is here, so who supported, who took out time and helped us in making this program. But we had the whole organizing committee here, and the most important one is Dr. Kirti, my associate, who runs the show, who makes my life comfortable when I am organizing this program. So thank you, Kirti. Also, we have wonderful audience, and I must thank people who are coming from outside city of Delhi. They come. We had almost 450 people who came out from outside Delhi and attended the program for 2 days. We had phenomenal, number of people coming from within Delhi. All are leading physicians, endocrinologists, and they are part of this program, and must thank each and everybody in the audience who were here to make this program a success. We also have a huge effort going behind the scenes from the event team, so I must thank Concept Events for supporting this program, for organizing all the nitty-gritty of this program, the audiovisual from Growers, who does a marvelous job in organizing our audiovisual every year, though this time they were doing some glitches. I'm going to fire them, but thank you everyone for being there and running the show smoothly. Last but not the least, we have support of Pullman and Novotel Hotels, especially Ashish Kumar, who's the person coordinating this event. We have Nandan Singh, who is taking care of the whole event, and we have chefs, especially Chef Tarun, who, takes care of all the menus of our program and makes it special. If I have forgotten somebody, it's purely unintentional, but I want to thank one and all who have been involved in making this program a great success. Thank you very much. Very soon you will be getting dates for the next year. I am not giving a confirmed date because we have not been able to confirm the bookings as of now, but I think by next month end you will be getting dates for the next year program also. Thank you so much. Thank you very much. Yes, of course. So there are, we have our academic partners, and in fact, it is there in the app. Without their support, we cannot run this program. That goes without saying. And the best thing is, with this program, we get a lot of liberty from our academic partners in the pharma industry. They don't influence the program anyway. They help us driving science the way it is to be done. They don't push their agenda in the mainstream program, and that's how we are able to run science in this program. So thank you one and all in the pharma industry who are supporting this program. Thank you so much. And see you next year around same time in August, hopefully at the same venue only. Thank you so much. And of course, please enjoy a cup of tea before you leave.